And many of those patients were already on SGLT2 inhibitor. They were already, almost 80% plus patients were already having RAS blockade. So on the background of standard of care, when this was added, it showed an additional advantage in terms of improvement of chronic kidney disease outcomes. So what all of this data has meant? This data has meant that almost all the professional medical societies have gone on to endorse an early use of GLP-1 in various diseases spectrums for the CKM patient, for a type 2 diabetic patient, for a obese patient with multiple metabolic risk factors or multiple metabolic comorbidities. So you have the ESD guidelines which talk about it. So you have the ESD guidelines which talk about it, that the pharmacological management should have GLP-1 RS as one of the preferred options. So that particular slide is not coming somehow over here. Okay. So the ESD guidelines talk about it. The European Society of Cardiology guidelines also say that in patients with diabetes type 2 and ASCVD, to reduce the severest independent of glucose control, you should have GLP-1 analogs alongside medications like SGLT2 inhibitors. So important point to remember is that this is not a replacement, this is an add-on thing over there. Some conditions like heart failure hospitalization risk, if it is there, you need to have SGLT2 inhibitors in your treatment armamentarium, and alongside that you can add a GLP-1 analog, etc. The KDU guidelines also have come out with a similar statement. So what is the evidence as far as oral semaglutide is concerned? So we had a very robust pharmacological trial program called as the Pioneer Study. The Pioneer Study, which basically had about 6,500 plus patients, showed that significant number of patients were able to have good glycemic control. Not only good glycemic control, the A1C reduction was up to the tune of 1.5% in a significant number of patients. And not only that, the weight reduction also was there. But more important, since large number of patients have diabetes, more important will be how many percentage of patients are having to have a composite outcome of reduction of A1C as well as a body weight loss of at least 5%. Since we know that minimal threshold of 5%, when you start seeing some degree of advantages, the advantages in terms of metabolic advantages start becoming better, as we know that weight loss goes to 10%, 15%, and at 20% it is very remarkable. So you can see that this whole spectrum of data of pioneer trials that significantly more number of patients were able to achieve this dual composite advantages, that is having both at least a 5% weight loss as well as a A1C reduction of at least 1%. And you can see that even compare with drugs like empagliflozin, which again are very good drugs, very beautiful set of data, should be there as part of treatment armamentarium. And there also you saw that there was a significant higher number of patients which are able to achieve those dual advantages. And what about the markers for cardiovascular risk reduction? So you can see that the markers for cardiovascular risk reduction, whether you talk of inflammatory markers like CRP, lipids or blood pressure, they were significantly lower along with reduction of central adiposity. So we have looked at the surrogate markers. What about the actual CVOT trial data? Where do we stand in terms of that? So that is what the SOUL trial was. So SOUL trial, it was powered to prove the cardiovascular benefit with oral semaglutide in patients with type 2 diabetes mellitus, right? It was a randomized, double-blind, parallel group placebo-controlled trial, about 10,000 odd participants with about 800 odd from our country. So what was the objective? To demonstrate that if the patient is receiving 3-point MACE, receiving oral semaglutide, is the 3-point MACE lower compared to placebo? And how was the study population like? So you can look at the BMI. The mean BMI of study population was about 31, suggesting diabesity in the patients. The mean A1C was about 8%. The disease duration was about 15% plus. And almost more than 2/3 were actually male, with about 1/4 of population from Asia. And the mean age was about 66 years. What about comorbidities? How many percent of patients had a coronary artery disease or a chronic heart failure or a chronic kidney disease at baseline? You can see that almost 40% of patients had CKD and almost more than 2/3 of patients had a coronary heart disease and about 1/5 patients had cerebrovascular disease and chronic heart failure, and about 1/6 had peripheral arterial disease. So what about the concomitant medication? That is very, very important point to understand, because if you have a therapy without already proven therapies, then you are always doubting whether this effect is real or not. You want to have our patients to be on statins, we want to have our patients to be on antiplatelets, we want to have our patients having the RAS blockades and beta blockers wherever indicated. So you can see that in this particular group cohort, you had more than 80% patients on RAS blockade, almost 90% patients on lipid-lowering therapies, and similar number of patients were on antiplatelet drugs. Almost 40% on diuretics, and more than nearly 2/3 patients were receiving beta blockers. What about concomitant diabetes medications? Almost 76% of patients were on receiving metformin, and almost 1/3 of patients already were using SGLT2 inhibitors. So, what were the primary outcomes? So, what was this study powered for? This study was powered to see whether the 3-point MACE with oral semaglutide on the top of standard of care is better compared to placebo. What did it show? It showed the curve separating quite early, and the number needed to treat to prevent one event was about 50. The total number of events with the semaglutide arm was significantly lesser than compared to the placebo arm, highly statistically significant, which showed that the MACE reduction was towards even 14% versus placebo, right? So what component of 3-point MACE which was driving it, CV death or non-fatal MI or non-fatal stroke? Here, the non-fatal MI was driving it. So what exactly is the reason, what is driving it? We still are understanding this because we know from the SUSTAIN-6 trial, which was with the same molecule but injectable 1 milligram weekly. It was the non-fatal stroke which was driving the 3-point MACE reduction, right? So probably we don't have the last word as to what is driving it. Is it a direct atherosclerotic benefit? If it is there, why it is differential on one particular macrovascular complication, not another? And many of these questions probably in the coming years will get answered. So, what was the benefit across the subgroups? More interested, I would be in seeing what was the benefit in the Asian population. You can see that a larger reduction was seen in patients with A1C more than 8% and those in the Asian region, right? So significantly more benefits were seen in this particular cohort in subgroup having Asian population as well as subgroup having higher A1C percentages. What about renal outcomes? Well, this study is not powered to give an answer about the renal outcomes. If you want to ask about the renal outcomes with semaglutide, we will need to look at the trial which you mentioned earlier. That was the FLOW trial, which, as I said earlier, was powered for the end-stage kidney outcomes, which showed that the end-stage kidney outcomes were significantly better on the top of standard of care with semaglutide, that was with injectable semaglutide weekly compared to the standard of care, and which, as I highlighted earlier, had to be prematurely stopped after 3.5 years of therapy. So this oral semaglutide study basically indicated decreased risk. So the p-value was not significant over here. You can see that the p-value is 0.19, not less than 0.05. Probably the number of events were lesser, and the trend towards that were there. So this actually showed that the mean EGFR decline was significantly lesser with the groups who were receiving semaglutide, and this was seen across the subgroups. So what about the safety? The safety has been similar to what has been observed with previous clinical trials with semaglutide. What the main adverse effect we see with all GLP-1 analog therapy? The main adverse effect that we see is basically GI side effects. Most of those patients who get into GI side effects, most of them, they do tolerate it eventually. Some of those patients we may need to stop it also. We obviously need to be very mindful about choosing the right set of patients. We should not be starting them in a patients with pancreatitis, already having some conditions which already prelude us from starting this medication. So the serious adverse events which were reported in the participants were almost similar in the semaglutide group compared to placebo. The adverse events leading to permanent treatment discontinuation were more common with semaglutide, but predominantly they were driven due to the GI disorders or the GI disturbances which happened as a result of starting of this GLP-1 analog therapy. So, does oral semaglutide tick the boxes which we want our patients, which we all want our medications to tick? The glucose lowering efficacy, the effect on body weight, CV risk factors reduction, pleiotropic benefits, and risk of hypoglycemia. I must say all of these boxes are very well covered by SGLT2 inhibitors also. When you come to certain other advantages on the top of SGLT2 inhibitors, then GLP-1 analogs, where patients can afford, is a very good choice of therapy, right? SGLT2 inhibitors, I'm all for using SGLT2 inhibitors. They should be there as a part of treatment armamentarium unless and until they are contraindicated in almost all the patients with type 2 diabetes, and they also have good glycemic lowering efficacy, good effect in terms of diabetic kidney disease progression, in terms of heart failure hospitalization, and some of the SGLT2 inhibitors even have the reduction data in terms of CV death reduction as well, as we know from FRI outcome study. And many of those SGLT2 inhibitors now with loss of patency have become very inexpensive and affordable for the patients. But you know, the diabetes spectrum that we see is very diverse. The diabetes spectrum that we see, we tend to have patients at an earlier age with more complications. So probably there are a number of pieces of the puzzle that need to be put together to complete the puzzle. Metformin is probably one part of it, lifestyle management is one part of it, SGLT2 inhibitor definitely is one part of it, and GLP-1 analogs again is another part of this, perhaps, where the patients will be able to have a better outcomes in the long run. So yes, most of those criteria actually can be filled with oral semaglutide as well as with SGLT2 inhibitors also. And at this stage, I'd like to stop and hand over the stage to respected chairpersons for further deliberations. Thank you so much.
Wonderful talk, Dr. Well, there are always questions now that the injectable therapy with semaglutide has also come into the market. So in every talk that we have, this comes into prospect. How do you weigh the injectable semaglutide versus the oral one?
So injectable semaglutide, lovely molecule. Peptides work much better when given injectable. No doubt about it, right? Once weekly, the hassles are less, right? But the acceptability of the patient when it comes to कि oral दवाई शुरू होनी है या injection लगाना है, that is where the challenge comes, right? Efficacy wise, I feel injectable GLP-1 analogs do very well. Before oral semaglutide came into the market, I was a bit reluctant as to how this peptide in a pill will perform in terms of efficacy. Honestly speaking, I have been pleasantly surprised as to the efficacy. It has been very good. All of you would have used it right, left and center, and all of you would say that the glycemic efficacy has been very good. The weight loss efficacy, I personally feel with semaglutide, it's the dose wali kahani, right? If you see, if the latest trial, the step-up trial has come with injectable semaglutide 7.2 milligram weekly, which has shown a weight loss to the tune of 21%, right? While the earlier data with 2.4 milligram weekly semaglutide showed the weight loss up to 18%, right? So I think the exact amount of weight is the dose ki kahani. We have the Oasis trial also, which has shown that oral semaglutide in 25 and 50 milligram has shown much better efficacy. The question I always feel is ki many of my patients find it difficult to tolerate even 14 milligram. How many of them will actually be able to tolerate 25 milligram and 50 milligram is a question, right?
Well, what I have been experiencing in my patients is that the acceptability for oral semaglutide, the gastric problems of course are a main problem, but it's seen that generally somehow the injectable one has comparatively a lesser GI side effects, better tolerability, and of course the weight reduction is probably more potent than the oral form. Because with the oral form, I think maximum I have seen is 5 to 6 kgs is generally the weight loss that I see in my clinical practice. Very rare patients have gone on to lose another 6 to 7 kgs. Some lose only 2 to 3 kgs, that's all. And I think with the injectable form, the weight loss potency is probably also.
Yeah, because you have 14 milligram, which is equivalent to 1 milligram weekly. So the weight loss dose, you can go up to 2.4 milligram weekly, which becomes actually much more. So even though the approval is up to 14 milligram, majority of patients for weight loss now I'm using actually 2.4 milligram weekly only. But those who do not want that and those who want oral only, right? You can talk on a one-on-one basis that this is a molecule which studies have been done at this much dose. And I have used actually high doses on those patients who were not willing for injectable. And I have seen an incremental weight loss which happens. So that is what I personally feel, that with semaglutide, once you go up the dose ladder, you will get more advantages in terms of weight loss.
Quite right. audience, anyone would like to ask?
The only drawback of semaglutide is the cost factor. So most of the patients are on other anti-diabetic drugs. How do you adjust the dose of semaglutide in patients who are having other anti-diabetic, already on other anti-diabetic drugs?
So very good question, sir. Two questions. First, I would like to answer the cost factor. Cost is a very, very valid concern. These drugs are not by any means cheap or inexpensive. These are expensive drugs. They do have a significant degree of advantages also, but they are not meant for everybody. So, it's very, very important for us to be, very transparent and frank with the patients as to, this is the kind of cost which will be there, this is the amount of duration you need to take it, and this is the kind of advantages you can expect. I honestly feel that our job as caregivers, as doctors, is to provide them with the right set of information, empower our patients and let them take the call, let them take the decisions, right? If they are willing for it, then they can choose to take the treatment whichever they want to take, right? Regarding the second question about managing the doses of other anti-diabetic drugs. So these are very potent molecules, right? So the first thing you should see is whether the patient is on an insulin or an insulin secretagogue and what is the actual sugar levels like. If the sugar levels are reasonably well controlled and you're putting a patient on GLP-1 analog, you need to cut down the dose of either insulin or insulin secretagogue. Control the hypoglycemia very, very importantly to the patients. Do not cut the dose of metformin or SGLT inhibitors. There is no point of using DPP-4 inhibitor when you're using a GLP-1 analog already in the patients because you have a pharmacological concentrations of GLP in the circulation, so there is no point of using an indirect incretin molecule at that point of time. So yes, so I think having a conversation with the patient that they can expect some degree of hypoglycemia, if the sugars are already very high, then you can take a call accordingly. But the first medication to be cut down should be a secretagogue and an insulin, right? You can take care on take a call on a one-on-one basis whether you want to cut down the dose or you want to remove it altogether. And as you go up the spectrum from 3 to 7 milligram and 14 milligram, your efficacy, glycemic efficacy also will go up. Because the 3 milligram glycemic efficacy is equivalent to a DPP-4 inhibitor. The real glycemic efficacy kicks in once you have a 7 milligram dose being given in. So that is what you can take a call and explain to the patient that once you have this drug into your system, you will need to monitor your sugars regularly, cut down the dosages, be very wary about hypoglycemia, tell them clearly how to manage hypoglycemia, right? You can use technology also, like I've made a very small video of how to manage hypoglycemia, which we WhatsApp to all our patients when we are explaining hypoglycemia. So this is how we do it on a day-to-day basis.
Thank you very much, sir.
I think we will go for the next session. Okay. Just one line I would like to add is that as these are potent molecules, so what I offer my patients is what everyone probably offers is that before going on to insulin, you can at least try this molecule, and many patients will probably before going on to adding on to insulin to the patient, many times adding this drug actually saves the patient many times from going on to insulin many times.
Excellent insight.
Thank you, sir.
Thank you.
Just to keep it time, so I would request speaker, chairpersons and panelists to kindly come on the left side of the dais for the felicitation. May I request Rajiv Awasthi sir to kindly come and felicitate speaker, chairpersons and panelists. Thank you, sir.
Thank you very much, respected chairpersons, panelists, and speaker. So now we move to the second session, and the second lecture, and I would like to invite Dr. Avay Srivastav, Dr. V.K. Chaudhary as chairpersons, Dr. Ritu Karoli ma'am, and Dr. Vivek Agarwal boss. Please do come on the dais. The second session is from injectables to pills, the rise of oral GLP-1 receptor agonist, orforglipron and amycretin. So few words were spoken about this by the previous speaker, and the next speaker is Dr. S.K. Singh from Varanasi. Over to you all to invite the speaker. Chairpersons, please do invite.
Thank you. And now I am calling Professor.
I would request chairpersons and panelists that they maintain the timing. Let us keep conference going on time. Thank you, sir.
So, welcome Professor S.K. Singh, SDM and Pioneer in 1988 from IMS Banaras BHU, Varanasi, Professor and Head Department of Endocrinology and Metabolics, Institute of Medical Sciences, PHU, Varanasi. He is former President, Vice President and Secretary ESI, President ESI 2017, Professor of Endocrinology since 2003, Inside European Commission Fellowship, publication of around 165, out of which 80 international, 86 national publications, and Principal Investigator, ICMR, UGC projects. So welcome Professor S.K. Singh.
Thank you, sir. Thank you for kind introduction. And first of all, I express my gratitude to the organizer of LDSSCON. My personal thanks to Dr. K.P. Chandra, Dr. Avasthi, who has been so persuasive to call me from Varanasi. I always think that Varanasi traveling to Lucknow is most difficult for us in comparison with the traveling from Varanasi to Delhi. But then I made it. And I am again thankful to the organizers for two reasons. One, that they made you to learn in this CME, but at the same time they have chosen a topic that made the expert to learn. So here both are in the learning phase. You will listen what I am going to talk, and I have also studied, because there is no, my personal experience, neither I have been part of this oral GLP-1 therapy in clinical trials. And more advanced aspect of this, that oral GLP, which is orforglipron and abicretin, these two molecules which are emerging in the horizon of oral GLP therapy, I am going to talk to you in next 18 to 20 minutes. Just to recapitulate, what is GLP-1 receptor agonist? It mimics incretin hormone GLP-1. It improves glucose control, promote weight loss. So there are two advantages of using GLP-1 therapy. One, that you reduce glucose level, but at the same time also there is a weight loss, and you address two important components of the association of diabetes. Traditionally, these have been injectables. Now oral GLP is emerging, and that is going to replace and make the GLP therapy more acceptable by the patients. This cartoon explains that there are multi-factorial pathogenetic mechanisms of hyperglycemia in diabetes, and most of these pathogenic mechanisms are in fact addressed by GLP-1 therapy, and that is the peculiarity and quality of GLP-1 receptor analogs. It improves impaired insulin secretion, increased hepatic glucose production that is always seen in patients with diabetes, impaired appetite regulation, decreased glucose uptake by the muscles and the adipose tissue, improves glucagon secretion. It also decreases, there is a decrease in incretin effect in diabetes, and that is also corrected by GLP. So most of these pathogenic mechanisms are in fact addressed by GLP, except the two. One is that increased lipolysis and increased glucose reabsorption from the intestine, from the renal tubules. So these two abnormalities are not addressed, but rest of all those abnormalities are addressed by GLP-1. So there will be reduction in the A1C with GLP-1, reduction in body weight. In addition to this, there will be reduction in the blood pressure because it improves the elasticity of the vessels, reduction in inflammatory markers, and also there is added CV benefits with the use of GLP-1 therapy. This forest plot of the network effect sizes between the GLP receptor agonist and the A1C reduction. Various GLP receptor agonist analysis has been done in this, and what you see is one oral or injectable oroglipron, orforglipron, which is ranking 4th in the list of GLP receptor agonist therapy in reducing A1C. There are other candidates. There is a whole list of starting with tirzepatide to lixisenatide, and tirzepatide is ranking first in lowering A1C. So these molecules have their own limitations and their effect, but some of them are oral in the list, and that was the focus of the talk in this CME. The reduction in the weight loss, that is also added with the GLP-1 therapy, and CagriSema, which is a combination of semaglutide and amylin, which is ranking first in lowering the body weight, so that is very effective in reducing body weight. And CagriSema is also under clinical trials for its use in clinical setting. Tirzepatide is next to that, but orforglipron is also ranking 4th here in weight reduction, which is oral GLP receptor agonist. The advantage of GLP receptor, as we have already said and studied, it has a high bioavailability and therefore is most efficacious. Flexible dosing, this can be given any time of the day, not necessarily before meal or empty stomach, and efficacy is proven through clinical trials. We have established data on the GLP receptor agonist injectable therapy. Disadvantages are minimal, not that many. Invasive, we have to give injections. Injection site reaction may be a concern, and patient compliance because of the cost and the prick. These two, in fact, are synergistic. If it is expensive, that is one prick, and if it is physical prick, that is another prick. And therefore, the most people do not like to take GLP receptor agonist therapy. The oral will definitely circumvent some of these disadvantages. So advantage of oral will be the convenience, the daily pill avoids the need of injections, needle aversion, and it is less invasive. Orally, it is not that difficult to take. But disadvantage is that you have to give it at fixed time, empty stomach, and there should be timing between the intake of the drug and the meal. Bioavailability is a big challenge with the oral GLP-1 therapy. Usually it is 1% absorbed. So imagine that 1% absorption of the GLP oral therapy, and attempts are being made to increase the availability to 2%. Imagine that by so many maneuver, that can all improve only by addition 1%, so 2%. So this will always remain a challenge, that bioavailability of the drug will be very less if it is taken orally. The side effects, again gastrointestinal side effects, which is very common with GLP, whether injectable or oral, but it will be definitely more with the oral. The key oral GLP agents which have been tried and they are waiting for their acceptance in clinical setting is one orforglipron that is innovated by Eli Lilly. It is a small molecule, it's a non-peptide, and it is taken once daily, no food restriction is required. So it doesn't have any absorption enhancer, but again bioavailability is limited. Amitriptyline is another, which is amylin with GLP-1 receptor action. It is innovative product of Novo Nordisk, and it is a dual GLP-1 and amylin receptor agonist. And injectable is also available, but oral definitely would change the paradigm. So orforglipron clinical data are now available, that is phase 3 clinical trial. One was ACHIEVE, another was ATTAIN. ACHIEVE was to see the efficacy of the drug in lowering A1C, and it was found to lower the A1C by 1.6%, which is quite significant. In obesity, that was ATTAIN trial, where the weight reduction was 12.4% at 72 weeks. So that was ATTAIN trial. Again, it is phase 3 trial. Mainly the side effects were related to gastrointestinal tract, and it was superior to oral sema. This is the ATTAIN data That primary endpoint was weight reduction and graded dose of orforglipron 6 milligram, 12 and 36 milligram, and there was an increased weight loss up to 7.8%, 9.3% or up to 12.4%. The secondary endpoints that people who lost weight more than 10%, which is usually expected, that if you really want to have the impact of weight loss on metabolic parameters, you must reduce body weight up to 10%. So more than 10% weight loss was in majority, 35%, 45% and even 60% with the higher doses of orforglipron. Percentage of participants achieving body weight more than 15%, again it was graded with the increased dose, 16% to 39 or 40% in the ATTAIN trial. The A1C reduction with this agent, you see with oral SEMA was 1%, but orforglipron was, it is 1.5 to 1.6%. Amycretin clinical data. This is a GLP and amylin receptor agonist. Oral phase 1 and phase 2 trials are undergone. 13% weight loss over 12 weeks. Injectable version has led to more weight loss up to 22% at 36 weeks. And in the early phase, long-term safety data is pending. We do not know how safe this molecule would be. Side effects again related to gastrointestinal tract. The challenges with the oral GLP-1 therapy, that it is not fully understood how safe this would be because we have clinical trials available. Long-term safety is still being studied. Amycretin orally absorption needs enhancer like that of semaglutide that has an enhancer to increase the bioavailability, and cost and accessibility remain uncertain. GI tolerability is again a question. Overall, the weight loss efficacy, if you compare, the oral SEMA is 5 to 5.5%, orforglipron has 12%, amycretin has, oral has close to 12-13%, but injectable has very high efficacy in terms of losing the weight up to 24%. Development timeline of these oral GLP-1 therapy, 23 we got orforglipron phase 2 trial data available. By 25 we have phase 3 trial achieve and attain, and mid-25 attain data on the weight loss, and it has been submitted to FDA for approval, and by end of the year we expect approval from the FDA. Orforglipron approval is likely maybe 25 or 26, and amycretin data is still pending. 28, 29 we expect that it might be submitted, and by 30 we would be able to get the approval of the another oral GLP analog therapy. So there is a paradigm shift in treatment of GLP therapy from oral to injectable. It may improve compliance, as I said, that double prick will be avoided, and dual mechanism of some of the molecules may have more profound effect on the weight loss and A1C lowering. Regulatory approval, of course, is awaited, and it might revolutionize the GLP therapy in diabetes and obesity. So it is injectable GLP-1 now switching to oral with time, and it is emerging a newer molecule, newer therapy for obesity and for diabetes treatment. Phase 3 trial of orforglipron is available. Amycretin is changing fast on the same track as that of orforglipron, with the potential to surpass. Perhaps this will be even better than the molecule which has already undergone phase 3 trial. So I think I tried to finish it. Thank you.
Thank you, sir. Excellent and lucid talk, and within time you have finished the talk. As the injectable and the oral, injectable is directly reaches to the blood, and oral, this passes through the JT tract. So, is the oral equally effective, or switching from the injectable to oral, or what is the success rate of oral drug in comparison to the injectable?
If you give any molecule and it reaches the blood with the same concentration, the effect will be the same. That is a simple pharmacology. But the challenge is that if you give oral, you may not be able to achieve the same level of the drug in the blood. So definitely you will not get the similar response with the oral. But the ease of administration is there with the oral, and that is why the compliance may improve. So at the end, if you analyze the data of injectable and oral, you may not find that a big difference, because the compliance is another important factor that determines the efficacy of any drug. So the injectable, of course, will lead to good bioavailability, good level of drug concentration in the blood, and will have more effect on the target tissue. But oral, if it achieves the same level of bioavailability, same level of drug concentration in the blood, will have similar effect. But as I said, that there will be many factors, so that is the reason bioavailability is being improved by various maneuver, like adding the snack or adding the other carrier molecule along with the oral preparations, so that you achieve the or close to the injectable level of drug concentration in the blood, and you will get the similar effect.
Thank you. Any question from the house? Over to panelist.
Thank you so much, sir, for combining all the knowledge which is available about these two new drugs. What I have read that this orogliflozin, there is a dose-dependent weight loss which is associated with that. So you have told us that 1.5 to 1.6% HbA1c reduction which has been shown. So is there that is also dose-dependent?
Yes, that is also dose-dependent. Both the effects, lowering of A1C as well as lowering of body weight, is dose dependent. But one interesting thing that was observed, that it is not only the dose but also the duration dependent. Sometimes the response very fast in the beginning, but then with time the response doesn't go hand in hand with the same level of response. So maybe that with time the response is not that good, and we have a limited data of either of 72 weeks or we have 40 weeks trial data available. Within that period, the response was dose dependent, but maybe in longer interval of time, we may not get similar response with these increased dose. Therefore, we are trying to find out what would be the most effective dose for most effective duration. So it may not be a maximum dose like orgliflozin of 36 milligram. Maybe that will have the similar response with 12 milligram. So that is why the dosimetry is being tried in the clinical trials.
So in the near future, more phase 3 trials might answer these questions. Thank you, sir.
Thank you very much, Professor S.K. Singh, sir. You have been always kind enough to us. May I request you to join the felicitation area? May I request Muklesh Gupta Boss to kindly felicitate speaker, chairpersons and panelists. Kindly join the felicitation area. So we move to, and thank you very much, chairpersons and panelists, for keeping the timelines. We will try to keep session going on time. So now I would like to request our next set of chairpersons, Dr. P.P. Patel, Dr. R.P. Sagar and Dr. Atul Kharbanda. Aap se, boss ji. Thank you, boss. And for panelist, Dr. Mahak Lamba, Dr. A.K. Upadhyay. And the next session that we do have from our own young chap, Dr. Avivar Avasthi, and he is going to talk on non-diabetic causes of hypoglycemia. So to speak more about on this topic and to invite Dr. Avivar Avasthi, may I request chairpersons to please take over. Over to you, sir.
Good morning. Next speaker is Dr. Avir Avasthi, and qualification MD DM Endocrinology, affiliation RML IMS Lucknow, and his area of interest is obesity, hypothyroidism, bone mineral metabolism, and diabetes mellitus. His achievement is he is associated editor, clinical epidemiology and global health, and his publication is 21 publications and 7 book chapters. Dr. Avasthi, please continue.
Hello. Good morning, respected chairperson in the LDSS Society, for giving me this opportunity to present this topic to this esteemed gathering. And this is a great honor for me because Professor Shubhankar Chaudhary sir is sitting here for the first time we are meeting like this where I am presenting and sir is the audience. I have done my DM training in Calcutta, and even though sir has not taught me directly, but indirectly his methods have permeated through my entire being, and there's a before Calcutta and there's a after Calcutta. So I thank sir and Professor S.K. Singh sir, who has also, I've attended a lot of his lectures, and I was grateful enough to be part of 2 or 3 interviews where sir was the interviewee. So coming back to this topic, this is a very important topic, especially for those who see this kind of case where is a clinical dilemma. And I would like to start off with 2 or 3 important cases, then some rarer cases throughout my journey from Calcutta to Manipal and then to Lucknow over here. Next one. Yeah. So, for some reason, this is something else. Are they 2 different? Are these 2 not linked together? Because I see something else here. Yeah. So here you can see a 13-year-old girl having intermittent episodes of hypoglycemia. I will come to how to identify those symptoms later. And there was history of familial strife for detailed inquiry. And there was family history of diabetes, and the mother was taking a sulfonylurea. And the critical sample was suggestive of hyperinsulinemic hypoglycemia, and obviously imaging studies were negative. Now, when you look at case 2, I just want to show both of them together. There is some disconnect. Here it is showing something else, and there it is showing something else. I do apologize for this technical issue. Yeah. So case number 2, here you can see it's a 15-year-old boy who had 2 episodes of hypoglycemia 1 month apart. There was family history of diabetes in the grandfather who was also taking sulfonylurea. And there was the documented plasma glucose of 45 milligrams per deciliter. All other values were within normal range. Now the first case had come to us after detailed evaluation. They had spent quite a lot of money. Whereas the second case, the patient was fortunate enough to come to me immediately when this happened. Now these 2 cases do highlight something which is always rule out sulfonylurea or insulin-induced hypoglycemia even in those who are not diabetic. I will come to that in the later slides. If you look at case number 3, this is a slightly different case. Here you can see this is a 56-year-old lady who underwent bariatric surgery in the past, and she was under remission with her diabetes. Now she used to complain of hypoglycemic symptoms around 60 to 90 minutes after food intake. There were no symptoms on fasting, which is an important history which should be elicited. And the lowest plasma glucose for her was 65 milligrams per deciliter. If you have any ideas or suggestions of what might be the potential diagnosis, you can say that now, or you can wait for when I present what kind of non-diabetic hypoglycemia this is. Similarly, if you look at case number 4, this is a 19 years old female. She was having severe neuroglycopenic symptoms since the last 2 months. There was fasting hypoglycemia, and her hypoglycemia was not related to her meal intake. And on evaluation, she had hyperinsulinemic hypoglycemia. What investigations were done and what was done subsequently, I have them in the subsequent slides, but there are certain differences which you should be knowing. Case number 5 now here, it's a 48-year-old businessman. This is one of the commonest things which I encounter, and I think most of the practitioners here would be encountering. A middle-aged man or a lady, they present with restlessness or tremors, or they complain of severe fatigue or weakness, or they complain of brain fog, as one of them told me, probably around 2 to 3 hours after a heavy meal. So this gentleman had such episodes at around 11 or 12 at work, and similar episodes at 10 or 11 p.m. So here you have to ask, when did they take the food and after how long did these hypoglycemic symptoms start? Again, look at the body habitus, look at the family history of diabetes, whether present or not. So again, what type of hypoglycemia this is, I will come to subsequent slides. And the final 2 cases which I wanted to show was a 44-year-old lady, and she had history of Graves' disease and she was started on anti-thyroid medications, after which she developed hypoglycemia. And the last case is a case from Calcutta itself, a 58-year-old female who was admitted with a left thyroid tumor. She had poor spatial features as well, and she was having intermittent hypoglycemic episodes since the preceding 4 months. Her capillary blood glucose was less than 50, her other parameters were normal, and on detailed evaluation on the critical sample as well, she had suppressed insulin, ketones, growth hormone, IGF-1 and IGF-BP3. So coming to the defense against hypoglycemia in the body, the first defense is cessation of insulin secretion. That especially starts when the plasma glucose falls below 81 milligram per deciliter. The second defense mechanism is increase in the glucagon and epinephrine levels. And when there is protracted hypoglycemia, there is elevation of cortisol and growth hormone. So symptoms can be classified as autonomic or neuroglycopenic. The autonomic symptoms like the adrenergic symptoms or the cholinergic symptoms. And when there is severe hypoglycemia, they have neuroglycopenic symptoms. Now when we look at levels of hypoglycemia, we categorize them as levels 1, 2 and 3. Any hypoglycemia which leads to neuroglycopenic symptoms or requires external assistance is called level 3. However, level 1 and 2 are biochemical gradings for hypoglycemia. So coming to Dr. Alan Goldfather Whipple, who advocated against undergoing pancreatectomy for all patients who were having hypoglycemia in the early 20th century. Based on his seminal work, the Whipple's triad needs to be established in a case of suspected hypoglycemia, which is low levels of plasma glucose, signs and symptoms which were expected of a hypoglycemic episode, and improvement of those signs and symptoms with administration of glucose. If that cannot be done, or if we are strongly suspecting prandial hypoglycemia, a mixed meal challenge test can also be done, or if a 72-hour fast is negative, then a mixed meal challenge test can be performed. So, approach to hypoglycemia. So, we have to first look at the frequency and the duration of symptoms. If it is an organic pathology, the symptoms are more severe. There might be premonitory signs like anxiety, hunger, visual blurring. As I mentioned, there's some people who are at work who might have reactive postprandial hypoglycemia. They might have certain symptoms which I've alluded to. Severity we understood, and relation to the last meal is most important. For example, those who have elementary diabetes, elementary hypoglycemia, or those who have postprandial reactive hypoglycemia are a form of pre-diabetes, or those who are post-bariatric surgery, or those who have non-pancreaticogenous hyperinsulinemia, probably due to maybe a histopathological residuoblastosis, might have an exaggerated insulin secretion post-meal. So, relation to the last meal is required, whereas those who have insulinomas or IGF-2 secreting tumors, they might have fasting hypoglycemia or autoimmune hypoglycemia, where it can be any particular time of the day. So, yeah. So, as I mentioned, we have to establish hypoglycemia. If that is not occurring spontaneously, then we go to the next step, which is making the patient undergo a 72-hour prolonged fast. However, there are recent data which say that even 48-hour fast is adequate enough to get most of the cases who have an organic cause of hypoglycemia. Furthermore, there are more studies which say that sequential beta-hydroxybutyrate testing along with serial plasma glucose monitoring is enough to diagnose endogenous hyperinsulinemic hypoglycemia. So that's not part of my presentation today. And for postprandial hypoglycemia, a mixed meal challenge can be performed. So basically this is an algorithm. So here we can see if there is a spontaneous hypoglycemia which has been observed. So you have to look at the clinical condition of the patient. If you look at the right, if the clinical condition of the patient is unwell, we first look at whether there is a hormone insufficiency or not. Generally, individuals with multiple pituitary hormone deficiencies or adrenal insufficiency might present with hypoglycemia. As I mentioned, the body's defense is lost against hypoglycemia. Non-beta cell tumors, especially those which are producing IGF-2, should be suspected. In that case, I will show in the subsequent slides what would be the critical sample biochemistry parameters, or a critical illness, or probably drug-induced in the background of a critical illness. Now, if, on the other hand, the individual is a clinically well patient, we let the patient undergo a prolonged supervised fast, and if hypoglycemia develops, so then we look at the C-peptide, insulin, beta-hydroxybutyrate, and the sulfonylurea saline. So depending on that, we get to know what might be the possible etiology. If there is no hypoglycemia on the prolonged supervised fast, we tell the patient to undergo an extended GTT with a mixed meal test, and if there is a reduction in plasma glucose with a positive or a non-suppressed C-peptide and insulin, we call it a reactive hypoglycemia. So as I was alluding to earlier, these are the biochemical parameters. Now for all individuals wherein you are suspecting hypoglycemia, especially if the hypoglycemia is very severe, especially if they are requiring external assistance, always think of sulfonylurea or factitious insulin use. How to differentiate the two? When we get a critical sample, here you can see that the C-peptide is one of the differentiating factors, because insulin secretagogues will increase endogenous insulin secretion, so therefore the C-peptide level will also be elevated. And in the tox screen, there will be positivity for sulfonylureas or meglitinides or ipatinide. Whereas in factitious insulin, the C-peptide will be suppressed. Now, when there is endogenous hyperinsulinism, there is an elevated C-peptide as well as insulin. However, when we look at a non-islet cell tumor, in these cases, insulin, C-peptide, growth hormone, IGF-1 and IGF-BP3 are all suppressed. These are surrogate tests for IGF-2 secreting tumors, because in India we do not have access, to the best of my knowledge, which conduct the IGF-2 testing. And autoimmune disorders, the results can be anything, especially those who have insulin, anti-insulin antibody disorders. But insulin receptor antibodies are a different ballgame. They are extremely rare. I'm not covering those here. So coming to the causes, insulinoma is a beta cell tumor. It is exceptionally rare, but we do see it in endocrine setups. It's mostly a solitary benign lesion, intrapancreatic most of the time. Sometimes we have an extrapancreatic tumor. The one we saw in Calcutta was an extrapancreatic tumor. It requires a convincing clinical and biochemical evidence, and the definitive management is surgery. Coming to the imaging studies, localizing studies for insulinoma, here we can see that generally people start with a CT or an MRI, but here you see that both of them lack sensitivity. So there are certain papers from IPDMER which have done a flare sequencing and diffusion weighted imaging for insulinoma, which has very good positive results. However, endoscopic ultrasound and extended PET-CT have a very good balance between sensitivity and specificity. The arterial calcium stimulated hepatic vein sampling is only done in specialized centers with an interventional radiologist. That has the highest sensitivity, and it is only done in specialized centers. So For the algorithmic diagnosis of insulinoma, I would suggest an MRI and an extended PET if it is strongly indicative of insulinoma, followed by a EUS or a ASVS for exact localization of the tumor, if extended PET is not showing the exact location of the tumor. So in our case scenario, the case 4, she had an extrapancreatic neuroendocrine tumor which was localized with endoscopic ultrasound as well as an MRI. And in MRI we also added, as I mentioned, a flare sequence and a diffusion weighted sequence, which is kind of rare for an abnormal MRI. So coming to non-insulinoma pancreatic or venous hypoglycemia, again it's less common than insulinoma. Imaging studies are negative, and arterial calcium stimulation with venous sampling may be positive. It's mostly a histopathological diagnosis which shows decidioblastosis, and management includes dietary changes, smaller portions, lesser glycemic index means, using cornstarch in the food, or medications like diazoxide, verapamil, acarbose, or octreotide. And definitive surgery, if it is persistent, might require surgery. Now, post-bariatric surgery causes hyperinsulinic hypoglycemia. It's more common for a more destructive kind of surgery where more of the parts of the gut have been removed, like a Roux-en-Y gastric bypass, as compared to a sleeve gastrectomy or a banding. Here there is increased secretion as well as increased activity of GLP-1, and the management is mainly dietary changes. There are some off-label uses, and there are certain newer drugs like GLP-1 antagonists which are being used for this kind of hypoglycemia. So case number 3 was a post-bariatric hypoglycemia. Non-islet cell tumors I've already alluded to. Most of them are mesenchymal or epithelial tumors, and they have high levels of IGF-2. And generally what they say is IGF-2 to IGF-1 ratio is usually more than 10, but we are not currently having IGF-2 in our country. Complete dissection of the tumor might not be possible, and if it is a malignant tumor, the prognosis is usually very poor. In our case, once the thyroid tumor was removed, there was no hypoglycemia present thereafter. Insulin autoimmune syndrome, again, it can be 2 types. It can be either antibodies to insulin or antibodies to the insulin receptor. So this is extremely rare, and there might be some history or some clues regarding this. For example, an autoimmune condition or some drugs which lead to increase in autoimmunity. So our case 6 was hypoglycemia due to carbimazole. Hypoglycemia and severe illness can be due to increased circulation of insulin, decreased utilization of glucose, or due to drugs which the patient is taking. Also erratic insulin absorption, which is present if the individual is diabetic. Drug-induced hypoglycemia, as I mentioned, sulfonylurea and secretagogue should always be considered as causes of hypoglycemia, even in those who are not diabetics. One paper even stated that glyburide in ESRT, the hypoglycemia can persist from between 28 to 256 hours, and some patients require up to 2 kilograms of IV glucose to maintain glycemia. So they should always be remembered. So these are a list of drugs which can cause hypoglycemia, either directly or via autoimmune process. It's just a list for those who are interested in this. Post-pancreatic reactive hypoglycemia, as I was alluding to, many patients come with this. It can be early, idiopathic, or late. That depends on an extended glucose tolerance test. And here, this might be probably a pre-diabetic state, because the first phase of insulin response becomes exaggerated. So this requires probably lifestyle management, behavioral management, diet management, and rarely, or what we give is acarbose for these type of patients. So case 5 was case of reactive post-parental hypoglycemia. So to conclude, hypoglycemia is uncommon in people who are not on glucose-lowering medications. But if it happens, we have to demonstrate the Wiggles triad. And the critical shampoo should only be drawn when the blood sugar is low, that is less than 55 milligram per deciliter. And hypoglycemia always represents a medical emergency. If it is left untreated, it can lead to permanent brain damage and even death. Thank you.
Thank you, Dr. Ravasti, for your elaborative talk. One question from my side is, what is the prevalence of non-diabetic hypoglycemia in day-to-day practice?
So it depends. If we consider reactive hypoglycemia, that is postprandial, it's pretty common, very common. There are many patients, especially here in North India, where the healthcare, I would say, coverage is not that robust, where they would be going around for multiple years saying that they have some symptoms and nobody is diagnosing them. But when you look at those patients, they might be having signs of insulin resistance, or they might be overweight, obese. In them, a simple mixed meal challenge test with an extended GTT shows that their plasma glucose comes down to around 55-60, but they still have a positive C-peptide and insulin. So them just simple dietary changes improves their life. But we do tell them this is a precursor to over diabetes. So if you consider this, it's pretty common. But if you remove the reactive postprandial hypoglycemia, it is not as common. If you still find hypoglycemia, always take a detailed history, because there might be some family member or there might be some factitious sulfonylurea insulin use. You would be surprised so many patients we have avoided the entire battery of tests just because we have told the parents or the dominant partner to go away from the chamber, and you take a detailed history and they actually come out and they tell that yes, I have done this because I was seeking medical help. So that does happen. But organic causes are rare.
Thank you. Any question from house? Thank you.
Thank you, Dr. Adwar. Simply looking topic, non-diabetic hypoglycemia is not simple, and we have all witnessed this. You have done very good justice in given time. Thank you very much.
Thank you very much, Dr. Iyer, for such a lucid talk. May I invite you to the felicitation area, and may I request Dr. Nitin Gupta to kindly facilitate speakers, chairpersons and panelists. Please join there. Now we move to the next session, and for next session I would like to invite chairpersons Dr. S.C. Chaudhary, Dr. A.K. Avasthi sir, welcome sir, Dr. Nikhil Gupta, and our panelists are Dr. Trinmay Barua, Dr. Indrasis Mukherjee. Welcome. And the next session is with Dr. Meenal Mohit on New Dimensions in Diabetes Care, Updates from ADA 2025. So may I request chairpersons to kindly introduce the speaker and invite her.
So, good morning everyone. The next talk is the New Dimensions in Diabetes Care, Updates from ADA 2025 by Dr. Meenal Mohit.
Consultant and Head, Department of Endocrinology, Manipur Hospital, Jaipur. She is a President, AIAARO, Rajasthan Chapter. She is a Joint Secretary, RCCI, Rajasthan Chapter. Quiz Master, National RCCI 2025. She is a Director, Sussex Endocrine Center, President, Association of Metabolic and Obesity Physicians and Clinical Endocrinologists, published more than 50 national and international papers, and she has been invited in the faculty of different programs. I invite Dr. Meenal to deliver.
Thank you, chairpersons and my respected panelists. A very good morning to everyone present in this hall, Lucknow. Thank you, Dr. Muklesh. I have been invited here on the recommendations of Dr. Tanushree ma'am. So, Tanushree ma'am, thank you so much for inviting me here. So, the topic that has been given to me and timing, I have 20 minutes to take you through some 345 slides. So, please don't panic. So I have done some shortcuts. Let's see how they work out. We are going to talk about the New Dimensions in Diabetes Care, updates from ADA 2025. So what is it? ADA Standards of Care. Since 2018, annually, ADA releases a document which has actually become a living document. All updates are put here, compiled together for all of our easy references. There are some 17 subsections, and we all have talked 17 different times, at least once on each topic at different places. Now talking of all 17 at one go might be a little challenging. So beginning with the first section, that is improving care and promoting health in population. Nothing much to learn new here, but you have to understand that they have specifically mentioned a patient level care, a system level care, and then some job has been given to the policy makers also. So we have to keep patient as the center of every decision making, and the system has to revolve around the patients. Then coming to the second section, that is diagnosis and classification of diabetes, that remains almost same. We are still dealing with HbA1c as the diagnostic marker. The pre-diabetes cutoffs remain the same, that is 5.7 and 6.4. Diabetes diagnosed above 6.5. Fasting plasma glucose values again remain same, pre-diabetes 100 to 125 and diabetes cutoff 126 mg per dl. 2 or postprandial blood glucose challenges again remain the cutoffs are just the same, pre-diabetes 140 to 199, diabetes above 200. Random plasma glucose values again above 200 with symptoms. So there is nothing new here. Moving on to the classification, the type 1, that is autoimmune, type 2, which comes with a package of insulin resistance and a progressive beta cell failure. Third one is a gestational diabetes, and all the remaining have been clustered into diabetes from other causes, which includes your monogenic syndromes or the diseases of the exocrine pancreas, drug-induced or chemical-induced. It's refusing to go away. Okay. So now they have come to something new, that how do you approach a type 1? So type 1, if you are suspecting an adult with type 1, the first thing is go for antibodies. If the antibodies are positive, you label as type 1 diabetes. If the antibodies are negative and the age is still less than 35, then you look for other monogenic features, and if you find that yes, they are, you presume it to be a monogenic diabetes, then of course you go for C-peptide, and if the C-peptide values are above 200, then you are dealing with genetic testing and you go for the genetic testing for monogenic diabetes. If the C-peptide is below 200 and the antibody is going negative, as you remember, still you label it as type 1 diabetes. If the patient at presentation is above 35 and you clinically think that it is type 2, then you treat according to type 2, but after 3 years, go for a C-peptide. If the C-peptide is below 200, you were wrong in your initial diagnosis, probably it was type 1. But if the C-peptide is above 600 after 3 years, then probably yes, you were right, it is a case of type 2 diabetes. So adult with type 1, you are suspecting this is the algorithm. So what are the risk factors now for screening for pre-diabetes or type 2? They are almost again same. Anybody above 35, history of pre-diabetes. Now people with HIV or exposure to high risk medicines, especially steroids, history of pancreatitis or evidence of periodontal diseases. So this is the population you need to screen again, and anybody who's overweight or obese. So overweight in the Asian setup, we take a cutoff of 23, which makes almost 70% of our population, including myself, overweight. So what are the additional screening guidelines? There are certain additional screening guidelines that is something to do with HbA1c. Suppose you have a fallacious results with HbA1c, you are not satisfied, probably you are dealing with some hemoglobinopathies. Then population of HIV, population with acute pancreatitis, especially recurrent pancreatitis, patients with a history of cystic fibrosis, post-transplant kidney, you will see that the patients develop diabetes, that is NODAT, what we know as, or you are dealing with some monogenic diabetes, certain medications, so you need some additional screening guidelines which have been given in the ADA guidelines this time. Then coming to the third section, that is how to prevent diabetes or how to prevent or delay the complications of diabetes. So for type 2, the focus is on nutrition and physical activity. When you talk of nutrition, of course, the emphasis is on the greens and the grains. So the high fiber diets and of course the low carb diets. Then physical activity, again the recommendation is 30 minutes every day for at least 5 days a week. And when we talk of physical activity, it has to be a blend of endurance exercises, that is muscle building, flexibility and cardio. But again, there is a patient-centered approach. Every individual has to be taken separately. For some population, you focus on weight. For some population, you focus on cardiovascular outcomes. For the reproductive age group women, you focus on the gestational diabetes history. So it has to be a patient-centered approach. Then how to delay diabetes? Just focus here, no drug has been yet approved to postpone diabetes. But yes, metformin has the strongest advocates that they advocate using metformin, especially in the pre-diabetes phases, especially if you are overweight or if you are having a blood glucose which is nearing diabetes, like HbA1c above 6 or a fasting above 110. So this is the pre-diabetes population. Again, focus is on B12. If a patient has been on metformin for more than 5 years, then B12 deficiency is very likely. For prevention of type 1, yes, they have recommended screening of antibodies, especially in the first degree relatives of anybody having type 1 in the family. Or you can even use teplizumab infusion, that is in a stage 3 or stage 2 of diabetes, and this is still in trial phases that we can use teplizumab for prevention of type 1. So for that you need to do the staging. So stage 1, when the antibodies are positive but the sugars are still normal, that is normoglycemic phase. Stage 2, when the dysglycemia sets in, and stage 3 is the overt type 1 child or a hyperglycemic child. Coming to the comprehensive evaluation and assessment of the comorbidities, the recommendations are all focused around the patient. So you need to prevent complications and optimize the quality of life, and every decision has to be taken in consensus with the patient. So in type 1, you have to assess all autoimmune diseases, most commonly the hypothyroidism, that is thyroid disorders, and the celiac diseases. But besides that, there can be pernicious anemia, there can be autoimmune liver diseases, there can be primary adrenal insufficiencies. Vitiligo has a very common association, collagen vascular diseases, and even myasthenia gravis. And believe me, in my type 1 population, I have seen all these associated. So, for type 2, they have emphasized specifically the bone health. So please screen out for bone health, the bone mineral density, go for a DEXA scanning, emphasize nutritional uptake, intake of calcium and vitamin D, weight-bearing exercises, that is bone strengthening exercises, and finally, please prevent falls. I just had a discussion with Madam, so please prevent falls. Then of course, pharmacotherapy. You can choose drugs which prevent your bone loss. Specifically, avoid using pioglitazones in the postmenopausal females. Then the question of cancers. Is diabetes associated with increased risk of cancers? So we have no screening recommendations for the same. No, it has not been recommended for any extra screening. But yes, the chances of developing CA pancreas, CA liver, CA endometrium, colon, rectum, and breast and bladder, they are found to have increased prevalence in the diabetes population. Then coming to the MASLD, that is metabolic dysfunction associated steatotic liver diseases. MASLD has a very strong correlation with type 2 diabetes, so we have to identify this population, we have to screen them, especially the overweight and obese population. At least the FIB-4 scoring is important. This is the link for the calculator. The FIB-4 scoring is very easy. You can use this calculator and find the FIB-4 scoring. And based on the FIB-4 scoring, if it is less than 1.3, then the risk is on the lower side. But if the FIB-4 scoring is above 1.3, then the patient is at high risk. And if the FIB-4 is above 2.67, that is double of 1.3, then please immediately refer the patient to a specialist hepatologist. Though what is recommended, even we are doing it. So in stage F0 or F1, you have to treat with obesity pharmacotherapy. So here finds the place of tirzepatide comes here. Tirzepatide is approved, even pioglitazone is approved. But this all we can do only in F2 and F3. Once we have gone to cirrhosis phase, maybe compensated or decompensated, the pharmacotherapy with resmetirom is not recommended. So resmetirom you are using only in the F2 and F3 phase. Even in the stage, in the decompensated cirrhosis, only insulin is the only molecule. Even our GLP-1 RAs or the dual incretins are not recommended. The status of immunization, I'll quickly go through it. Please, adult immunization is important and focus on COVID vaccination, hepatitis B vaccination, influenza, pneumonia, RSV and DPT and zoster. So these are 7 vaccines. You must remember 7 vaccines in all your type 2 diabetic adult population. Now this is the comprehensive evaluation. You can look into this, what needs to be done at the initial visit and annually. So the detailed history taking, behavioral factors, medications, technology uses. I'm not going through the details because I have only 8 minutes and have a lot of sections to cover. We all know this. Now facilitating positive health behavior and well-being. Here comes your diabetes self-help group, that is self-management, education and support, DSMES, MNT, medical nutrition therapy, physical activity is very important, counsel on no smoking, moderation of alcohol, counsel on a healthy sleeping patterns, and a sleep quality is very important, and a psychiatrist on the board, that is a psychologist or a psychiatrist on team is an essential component. So what are the situations when you need to refer a patient to a specialist? When specifically you can, label diabetes distress. So if you can label diabetes distress, please refer to a specialist. Then there is some recommendations about religious fasting and intermittent fasting. So there are specific columns, the pros and cons. So religious fasting, please maintain hydration in all types of fasting. That is very, very important. Avoid ketoacidosis, and especially the religious fasting, because we have our spirituality and religion associated. So please take care while you are counseling your patients. Now this is a very, very beautiful slide with every color code and the effect of specific activity in your 24-hour pattern of your life cycle. What is the effect on your blood sugars, on your blood pressure, on your lipids? They have specifically mentioned this. So it's very detailed, but if you just look at this strengthening exercise, if you look into this, the red color, the benefits of strengthening, and the all red arrows, you can see that it will decrease your A1C, decrease your lipids, it will improve your physical activity, it will decrease your depression, it will improve your quality of life. So this is the slide which has mentioned your 24-hour physical activity and your behavior relates to your diabetes. Coming to the goals and hypoglycemias. So goals are again individualized, and one thing important is if the population is very old with a lot of comorbidities, you can specifically think of no A1C goal. Just allow them to live a happy and no hypoglycemic life. So stringent factors, stringent goals are required for certain population, and less stringent or relaxed goals are required for certain population. So it is again a very individualized approach. Even for the CGM, the goals are very, very specific, that for the very high, it should be less than 5%. The total high and very high should be less than 25%. The green zone or a healthy zone should be around 70%, you should be in time in range, and below range should be less than 4%, and very, very low, that is less than 54, symptomatic should be less than 1%, that is 1% is equivalent to 15 minutes. So these are the goals that have been recommended in the ADA. So the risk factors for hyperglycemic crisis have been mentioned both in type 1 and type 2 population. Diagnostic criteria for DKA remain blood glucose above 200, ketones above 3 millimoles, and pH below 7.3 with a bicarb value less than 18. If you're talking about HHS, that is hyperglycemic hyperosmolar symptoms, non-ketotic state actually. So hyperglycemia, blood glucose above 600 with the osmolality above 300, ketones should be less than 3, and acidosis should be absent. Hypoglycemic assessment, again the levels we just learned from Aviva. Level 1, that is below 70, level 2 below 54, and level 3 is below 54 with symptoms. Coming to technology part, yes, there are recommendations to use pumps, that is automated insulin delivery systems. There are connected pens now. You can use CGMs, mobile apps for your patients, and the self-help groups also. So all the technologies are included in the recommendations. Blood glucose monitoring, SMBG still remains a very important chapter. And what are the timings? It is a structured SMBG. Just don't do a random SMBGs. Go for a structured SMBGs, which gives you some idea where the patient is going. CGM recommendations, there are real-time CGMs, there are intermittently scanned CGMs, professional CGMs. Though these professional and OTCs, we have OTC CGMs in India, and they're all intermittently scanned, but now we also have the Liberate 2, which is a real-time CGM. We do not need an intermittent scanning. Coming to the obesity part here and the weight management. So these are the ADA recommendations, but the Asian groups come down another one step down. So we start recommendations from 23 kilograms per meter square. So the Asian cutoffs are 23. So behavioral counseling starts right from BMI of 23. But when you talk of pharmacotherapy starts from a BMI of 25, and metabolic surgery that begins when the BMI is above 27. So the pharmacotherapies for weight management are many, but we look into the molecules related to diabetes. So the very highly likely recommended molecules are tirzepatide and injectable sema. Like Dula has not shown very good results. Lina definitely has given good results. Then SGLT2I, yes, they gave us some 3-4 kg weight loss. So pharmacological approaches for glycemic management. I have 2 minutes. Okay. So for type 1, the only recommendation is MDI, that is multiple daily injections. Go for a basal bolus therapy with long-acting analogs and the rapid-acting analogs. You can look into the recommendations for the simultaneous pancreatic kidney transplants or the only pancreatic transplants. If the kidney is failing, go for SPK, that is simultaneous pancreatic kidney transplants. For type 2, the algorithms here, the interesting parts are, I'll just take you through if there is a high risk of atherosclerotic, so this left part we'll first look into. So high risk of atherosclerotic cardiovascular diseases, choose either GLP-1RA or SGLT2I. If the blood glucose is not controlled, you can add one to the other. Any one you can add to the other. So if the patient is already on SGLT2I, add a GLP-1RA. If the patient is on GLP-1RA, add SGLT2I. Then of course, the GFR is 20. Any eGFR above 20, you can add SGLT2I. For metformin, the GFR recommended now is 30 here. So if the GFR is above 30, you can still continue using metformin. Now, if there is no atherosclerotic cardiovascular disease and you are focusing weight loss, then GLP-1RAs or the dual incretin, that is tirzepatide, is recommended here. You will find that if the blood glucose is not controlled, in a very small name, one column still has sulfonylurea, but sulfonylurea will make your patient gain weight. So sulfonylurea has a very small place here. Okay, but if the sugars are not yet controlled, because ultimately we are dealing with diabetes, then comes the place for insulin addition. So you will start adding basal insulins or the prandial insulins. So this is how the algorithm goes. Then comes your cardiovascular disease and risk management. So the targets are for the blood pressure should be below 130/80. So if it is above 130/80, start with a monotherapy. If the blood pressure is above 150/90, start with a dual therapy. If you are choosing a monotherapy, preferably if there is albuminuria, choose ACE or ARB. If there is no albuminuria, you can choose either ACE or CCB or a diuretic. If the BP is above 150/90 and you are choosing a dual therapy, and if there is albuminuria, again one has to be ACE or ARB, the other can be a CCB or a diuretic. If there is no albuminuria, you can choose any two as a dual therapy. If the blood pressure is not controlled, you can add the third one. How do you screen for the CAD? You are not going to ask a CAG for everybody, but if there are symptoms, you can go for a CAG. Screen for heart failures, that yes, you can measure BNP, or you can go for ECO. Then PAD, again for the PAD, you can have to monitor the ankle brachial pressure index, that is ABPI, or even TBI, that is toe brachial index, can be measured. Prevention, and then preventing or treating people of diabetes and heart failure, of course the recommended molecules are SGLT2I. If there is CKD also, now we have a place for SGLT1 also. So either SGLT1 or 2 inhibitors, and even the Fendrinone has found its place. So Fendrinone is also recommended in people with diabetes, CKD and heart failure. Coming to the lipids, how frequently you have to monitor lipids at initiation and then annually. But if you are treating, then every 3 monthly or with every change of dose 3 monthly. High intensity at almost certain up to 80 milligrams, those who are certain up to 40 milligrams. Moderate intensity molecules, you know them. So who needs to be treated? Younger population, they need to be treated given statin if there is atherosclerotic cardiovascular risk. In population between 40 to 75, moderate intensity if there is a risk factor. If there is established atherosclerotic cardiovascular disease and the targets are still tight, you need to bring them below 70, you need to use high intensity statins. You can even use PCSK9 inhibitors or even inclisiran has performance plays. So all these molecules can be used as secondary prevention. For CKD, at initiation and every 5 years in type 1 and annually for type 2, you have to measure the urine ACR ratio or eGFR. Now based on eGFR and albuminuria, you again have an algorithm for the classification of CKD. For non-diabetic CKD, that is very important to recognize, not every CKD is DKD. Some CKDs can be non-DKDs. So you have to recognize which are the non-DKD CKDs. So for that, you must know the criteria that if it is type 1, less than 5 years duration, if there is increased urinary sedimentation, if the blood glucose is decently well managed, or if you have a very high ACR, no retinopathy. I can see Dr. KP Chandra standing up already asking me to stop, so please I'll stop here. So we have to manage this all. So this all rest you should know. If you do not know, you can go to the site and look into the ADS slides.
Thank you ma'am, for completing it in time, lucid presentation. So since we have already overshoot, quick comment only, 30 seconds to chairpersons.
Thank you ma'am for concising all these 360 slides into so much less time, and you have covered time to cover all the important points. So I think we can open any one or two questions if I'm okay.
So thank you very much. May I request speakers, chairpersons and panelists to kindly join the felicitation area. May I request Saili Avasthi ma'am to kindly felicitate them. So, at times you become villain when you have to keep the time. So I'm sorry for that, but this job was in the first session only. Maybe in third or fourth session I may come again as a time master. So with this we will move to the inauguration, and for inauguration we do have Dr. Vivek Agrawal and Dr. Tanushree Gupta ma'am to facilitate this program. So over to you, Vivek bhai.
A very warm welcome to all the delegates and faculty and esteemed speakers. On behalf of LDSSCON, we welcome you all. And a very short official inaugural function after the end of session 1. We inaugurate this conference not as a mere academic gathering, but as a collective vow to understand, to prevent and to heal. Diabetes, silent yet relentless, demands not just clinical precision but compassionate vigilance. Today we invoke the spirit of inquiry, the discipline of evidence and the grace of empathy. In the name of healing, the lamp is more than light, it is a legacy. As we ignite its flame, we honor the timeless pursuit of knowledge, the sanctity of care and the quiet courage of those who walk the corridors of medicine. This light is a tribute to every sleepless night, every life touched and every lesson learned. It reminds us that education is not just accumulation, it is illumination. And in this we gather not merely to learn, but to rekindle our purpose. So may I now request all the members of LDSSCON and our esteemed speakers who have come all the way to give their very, very knowledgeable presentation and enlighten us That's all for the lamplight.
And for the lamp lighting, I invite all the members of our organizing committee, LDSS, and our respected speakers, Dr. Sachin Mittal, Dr. Avivar, Dr. Vinal Mohit, Dr. Ashu Rastogi, Dr. Rajesh Rajput, Dr. Navid, Dr. Amit Rastogi, Utpal sir has left, and Dr. Shubhankar and Dr. Robert Messi. And along with this, I also invite our LDSS Nari Shakti to be present on the stage. I request all the speakers, dignitaries to stay on the stage, please. Group photograph with the speakers also. Sir, just 2 minutes more. Please, sir. Please be here for another 2 minutes. Group photograph. I request Nari Shakti to honor the speakers.
आपने थोड़ा लेट जा रहा है। हाँ थोड़ा डिले कर लो। ठीक है कोई दिक्कत पता नहीं तो होना चाहिए। आपने क्या वीडियो बनाया है क्या? पीछे भी पीछे
स्टोरी लगा के लिंक शेयर कर दो। हाँ नहीं एक बार में लाइव हो नहीं रहा था, इशू आ रहा था, टाइम हो रहा था, सर को बता दिया।
बताइए 809090
अनुभव से वो कहाँ गए मुझे पूछ के गए क्या
हमारे साथी हैं
लाइव आपको पता है सेटिंग चेंज करने का पता है इसमें किसकी फेसबुक में चले जाएगा साथ में ऐसा है
Thank you very much. I request our team members, LDS members to stay here for the group photo.
We'll have a group photo of the members of LDSSCON. So members of LDSSCON, please stay on the stage. Shelly ma'am. One photograph of LDSSCON members.
यूट्यूब में सेव हो जाएगा यूट्यूब भी तो लगा दो स्लाइड चेंज
May I now request our President of LDSSCON, Dr. Rajiv Awasthi sir, to make his welcome address and his presidential speech.
Thank you,
इसका लेक्चर में रहे
everyone. Good morning, distinguished, respected dignitaries, eminent speakers, colleagues and dear friends. It's both an honor and a privilege to welcome you all to this year's LDSSCON, organized by Lucknow Diabetes Society. On behalf of our association, I extend a very warm welcome to each one of you and to our guest faculties, eminent speakers from India and abroad, our delegates, and to the many professionals who have traveled from near and far to be here today. This conference marks not only a gathering of minds, but also a celebration of our shared commitment to advancing the science and art of medicine. The field of healthcare continues to evolve at a remarkable pace, driven by innovation, research, and the collective efforts of dedicated professionals like all of you present here. It is heartening to see such enthusiasm for learning, collaboration, and progress, especially in an era where multidisciplinary teamwork is the key for solving the healthcare issues. Today, the conference will cover a wide spectrum of themes in the field of obesity and type 2 metabolic disorders. Our scientific committee has worked tirelessly to curate sessions that are not only intellectually stimulating but also practically relevant to our day-to-day practice, and I can encourage everyone here to engage actively, ask questions, exchange ideas, and build meaningful partnership amongst each other that may shape the future of our profession and our city also for the academic circle. We try to inculcate and bring in more and more new blood, and I am happy to see lots of new blood sitting here. Those people will become mentor for the future generation. I would like to take a moment to express my deepest gratitude to our organizing committee, without whose dedication everyone is sitting here. Everyone worked so tirelessly in last few months, and meticulous planning, this event would not have been possible. A special thanks goes to our sponsors, collaborators for their generous support, and to all our invited speakers who have kindly agreed to share their expertise and insight with us. I am confident that this conference will spark new ideas, inspire research, and strengthen the professional bonds that unite our community. Together, let us make some difference in healthcare. Thank you once again for being part of this occasion, and I wish the conference great success and hope. This day is filled with enriching discussions, new collaborations, and memorable experience. Thank you very much. Thank you.
वैसे भापा पूरे बन जाओ, इससे अच्छा तो कोई प्रोफेशन ही नहीं है।
I now request our dynamic secretary, Dr. Mukesh Gupta, to present his secretary report.
So, a very good morning, in fact now good afternoon, to each one of us who have participated in the conference, maybe medical professionals, colleagues, friends, researchers, pharma people, all those who are supporting me as organizing committee for this particular conference. Each one of you is welcomed. Now this is the 5th annual LDSS conference. It's a very small bunch of like-minded doctors, clinicians, mainly in the private practice, those who have come together with a purpose. And that purpose was basically originating from a common question that can we busy private practitioners collaborate on meaningful clinical research? Because most of the time this research comes from the government institutions and big institutes. So with that basic question, this organization was formed in 2018. It's a fully registered society which is also exempted by the income tax. We are also having and backed up by Ethics Committee and Directorate of Health Research so that we can take on the clinical research simultaneously. So within that very short span, we have come up with 9 population-based studies in these 7 years based on very key topics like hypoglycemia, sexual dysfunction, psychological impact during especially the COVID times, the driving challenges, the drug discontinuation, the monogenic diabetes, psychological effects during the COVID-19, the basal insulin consensus that was once again very important during those COVID times when we were not able to see our patients physically. Then MSL, the impact of pioneerism on it, early experience on 1.0, that is something which is going on in Indian patients. So these are the excerpts of the publications which we have done in this short span of time, and we are dedicated towards research mainly. And this conference is basically to dissipate that knowledge to our fellow men, those who are residing nearly 150 square kilometers from Lucknow, so that they are also in sync with us. They are also moving with us, and we are able to contribute to upscaling of whatsoever is happening new in the field of diabetes and whatsoever we are doing. And that meaningfully converts into ultimately the patient care. And that is something which is the primary motive of this conference. I'm happy, and Dr. Rajiv has already mentioned that we have gained that sort of reputation and respect that we are able to do justifiably and very truthfully to communicate with our fellow men, those who are residing around us, in a very positive manner. So these are the publications which we have come up, and there are the recent ones in 2025. The report is for what Dr. Meenal was speaking about, how it is correlating, how should we go about detecting fibrosis in our patients, those who are detected to have fatty infiltration. Likewise, some nasal newer therapies which have come up, or the assessing impact of the pioglitazone which is coming up in AD 2025. It was talked about much more than resmetirom. That was something which was seen to be effective in cases of fibrosis of liver. And then our counterparts also coming up in other areas of the medicine, like this study which was published in the Gynae Journal. If we talk of the global recognition of LDSS research, then we have been present in ADA, AACE, European Association of Studies for Diabetes, that is EASD, IDF, and RSSDI, that is our local body. And these are the live presentations which have been done by our members in these conferences. We have got some active members, unfortunately.
Greetings from
our one of the
LDSS, the
youngest
Lucknow
member and
Diabetes
very
Study
active
Society
dynamic,
from India.
Dr. Arun, he has lost his
LDSS
father,
is a research
and
group
therefore
dedicated to
he is not
research in the
present here,
field of
but he is
diabetes.
otherwise also very active in the national research. These are the representations which have happened in AAC, or whether we talk of the clinical trials, the STRIDE trial, the results which have recently been published. We have been part of that particular multinational trial, and then the gynae part, also the Elagoline study which has been published in ICOJ. So this LDSS basically is a collaborative spirit, key to research success, emphasis on translating research into clinical practice for everyone, those who are residing around us. That is our basic responsibility also towards our fellow men, and that is what we are trying to do on a continuous basis. These are the excerpts of the previous conferences which we have had, the 4 of them, and actively participated by our fellow men, and that is something which is the success, actual success of any conference, is the participation of you delegates. I thank you, each one of you, from core of my heart, to be present, and probably we'll try to do it in future. So the future outlook and goals is increasing prevalence for diabetes in India, we know that. So there are rising challenges, let us address to that, and I'll invite all speakers, those who have participated, faculty members, that we are focusing towards collaborative research. Think of us whenever even you are involved in some sort of research, so that we can also contribute to your part of research. So this is where we can collectively give good data coming from India. So these are the thought processes which is behind the LDSS group as a whole, and from my fellow men and the counterparts, the Nari Shakti, what we label as, because they are all the time there to help us out, because we all are busy physicians, busy clinicians, and are short of time many times. So this team is always there with us to back and cover up for whatsoever is left over. Thank you so much for your coming here, welcoming you all once again.
Now with that short inaugural function over, now may I request Dr. Rajiv Awasthi to moderate the next session. Sir.
So, after a brief introduction and welcome from our core of heart to everyone present here, we now move on to again the serious business of starting the science once again. So this session for half an hour, we will have 4 talks. For first talk, I will invite the chairperson and panelist, Dr. Sanjeev Kumar Pathak, SK Pathak, Dr. M.H. Khan, Dr. Jamil, Dr. Rakesh Mehrotra, and Dr. Sanjeev Khatwani. Dr. Jitendra Prasad, sir. Dr. Jitendra Prasad. I would also request Dr. Pathak to introduce Dr. Rajput here.
Welcome everyone. Dr. Rajesh Rajput, Director and Department of Endocrinology, Medanta, Gurugram. He did MBBS, MD, GMC Bhopal, DM Endocrinology, PGI Chandigarh, Fellowship received CP, FAC USA, FICCP, former Senior Professor and Head of Department of Endocrinology, PGI, MS Rohtak. He has more than 180 publications, various international and national journals and books. His contribution is huge, and I will ask Dr. Rajput to start the topic. Thank you, sir.
Good afternoon, friends. At the onset, I'd like to thank all my friends from LDSSCON for inviting me. And the topic which I have been asked to speak is remission in type 2 diabetes, effect on height, which is quite a burning topic when nowadays you go on internet, people or even otherwise, patients are coming to you and asking whether remission of diabetes, or there is another term, reversal of diabetes, is possible or not. So I am going to discuss briefly in next 18-20 minutes about this concept. No conflict of interest. My stay, travel, everything has been taken care by the organizing committee. So there is no conflict of interest for this talk. And if we see that remission or reversal, these are the two terms. Basically, we have to understand first what is the definition. Reversal is defined as restoration of normal health, which means going back to the normal. While remission is defined as abatement or disappearance of signs and symptoms of disease. Therefore, for chronic diseases like diabetes, it is more accurate to use the terms remission rather than reversal, which actually means cure. Now we have to understand there is no cure for diabetes as of now. Note, whatever we are speaking here today applies to type 2 diabetes. In type 1 diabetes, there is no concept of reversibility or remission, although now there are studies that if we pick up in subclinical stages, those who are antibody positive type 1 diabetes, now there is a therapy where we can delay the onset of type 1 diabetes. But largely we are speaking about type 2 diabetes. Now there are three important terms: partial remission, complete remission and prolonged remission. Partial remission is defined as having blood sugar that does not meet the classification for type 2 diabetes, which means HbA1c less than 6.5% for at least 1 year while patient is not taking any glucose lowering medication. We have complete remission, which means return to normal glucose values, which is less than 5.5% for at least 1 year while not taking any glucose lowering drug. And prolonged remission when this state lasts for 5 years. So these are some of the standard established definition when we are talking about concept of remission. Now, when we are talking of this important concept, what are the questions? Are beta cell, as when we were students, it was told once beta cells are gone, they are gone permanently. So is it true? They can be brought back to function? If yes, how we can make beta cell function again? What are the clinical evidences for remission? And can we utilize it as a therapeutic strategy? So these are some of the few questions which I am going to answer in next part of my talk. Now when we talk of reversibility or remission, there is a pathophysiological basis. When we were students, we were taught about concepts of glucotoxicity, lipotoxicity. Ross-Taylor has given the concept of twin cycle hypothesis, based on which large number of things have now come up. Now what is twin cycle hypothesis? All of us practically nowadays are living in a state of calorie excess. I give you an example. We have lots of good breakfast. Even if we will not feel hungry, at the time of lunch, all of us go and will start eating the lunch. Now whenever you have excess of calories inside your body, ultimately this fat is going to be deposited inside your liver. Now when it is deposited inside your liver, the commonest thing which nowadays patient is coming to us with ultrasound is fatty liver. And then excess fat through VLDL will spill over into circulation, and there will be ectopic fat deposition in organs which are usually fat free. Say for example pancreas. Pancreas normally is fat free, less than 2 grams. But when there is deposition of fat in the pancreas, pancreatic function decreases. So this is basically twin cycle hypothesis given by Ross-Taylor. Chronic calorie excess leads to accumulation of fat at ectopic places, the places where normally fat should not be present, which will result in beta cell dysfunction, insulin resistance, diabetes and various metabolic problems. But then some of you will be thinking, what is the evidence? Before I come to the trials, if we see weight gain is the strongest modifiable risk factor in patients with type 2 diabetes. Rise in SGOT, SGPT, they are actually a proxy for excess liver fat, even without doing any imaging study. High liver fat is also associated with impaired insulin sensitivity. If you have deposition of fat in your pancreas, your beta cell dysfunction will decrease, and weight regain after any type of therapy which you have done, bariatric surgery, drugs, intensive lifestyle, there will be re-emergence of diabetes and various metabolic problems. Then there is a second aspect which Ross Taylor has given. If you consume very low calorie diet, now here very low calorie diet means 600 to 800 kilocalories a day. Now by doing so, taking such a low calorie diet, there will be mobilization of fat from ectopic locations. There is restoration of liver insulin sensitivity, improvement in pancreatic function, and it is possible that you will have remission of diabetes and decrease in various metabolic complications. And again, if you see the evidences for that, intensive weight loss by any means, we are saying by diet, by drugs, by bariatric surgery, or by combination, there is remission of diabetes, which has been exploited. There is decrease in liver enzyme. There is improvement in beta cell function. So therefore, these are some of the evidences. Now moving from this theory, let's look at evidences. When we talk about the concept of remission, there are three important studies which all of us must know. Counterpoint study. What is counterpoint? Counteracting pancreatic inhibition of insulin secretion by triglyceride. Counterbalance study, which is counteracting beta cell failure by long-term action to normalize calorie intake. And third, direct study, which is diabetes remission clinical trial. Very briefly, we'll show you the three important studies before I will conclude, give you take-home messages. What is counterpoint study? It's basically a hypothesis testing study. Only 11 people were studied in this study. Type 2 diabetes, 9 male, 2 females. And what was the hypothesis? Hypothesis is both beta cell failure and insulin resistance can be reversed by dietary restriction. And patients were studied before at week 1, week 4, week 8. They were given 600 kilocalories per day of diet. So very small study, small number of patients, hypothesis testing study. And this next slide is very important to understand the concept which is now there. Now when these individual 11 people, they were given only 600 kilocalories per day, you see within first week of giving such a low calorie diet, there is improvement in fasting plasma glucose. If you extrapolate it down, simultaneously there is decrease in liver fat accumulation, and this goes on till 8 weeks. Apart from decrease in hepatic liver fat, there is improvement in insulin sensitivity. And if we look at pancreas, the effect on pancreas started appearing by week 8. At week 8, even the pancreatic function and first phase of insulin secretion is restored. So this is a first hypothesis testing study which has shown that by giving low calorie diet, it is possible to improve insulin sensitivity. It is possible to restore first phase of insulin secretion, which means remission of diabetes is possible. So therefore, friends, the conclusion of counterpoint is normalization of beta cell function, hepatic insulin sensitivity is possible, and weight loss is beneficial. Now to test it further, counterbalance study is done to find out the questions: can people with longer duration of diabetes, remission is possible? And if reversal of diabetes is durable, if weight remains stable. So the counterbalance study is a relatively longer study. They have enrolled people with different duration of diabetes, both short duration of diabetes and long duration of diabetes, given same low calorie diet, weight loss of almost identical, 14 minus 6 plus minus 1% is lost through this low calorie diet. what counterbalance study has shown that in people who are having short duration of diabetes, see, if your duration of diabetes is less than 4 years, virtually everybody responded in counterbalance study. If your duration of diabetes is more than 12 years, virtually almost nobody responded to your low-calorie diet. Between 8 to 12 years, it's a gray zone. Few respond, few does not respond. So this gives us a message that if we are going to practice the concept of low-calorie diet, the concept of diabetes remission, duration of diabetes should always be asked in the history. Those who are having long-standing duration of diabetes, probably remission is not possible, and we should not give unrealistic expectation to the patient with which patient is coming to us. Now the third study is direct study. It's a direct remission clinical trial. Now based on counterpoint and counterbalance, it was thought, is it possible to apply this concept in primary care setting? Like Dr. Mukesh is telling, we are all practitioners, so in UK, in Scotland and England, in 49 primary care practice, this study was planned, age of 20 to 65, duration of diabetes within 6 years, not receiving insulin. Do not try this concept in those receiving insulin. And intervention was withdrawal of anti-diabetic, anti-hypertensive medication and replacement of total diet replacement with low-calorie diet. Now what in direct study it has been shown that with weight loss of around 15 kg, 46% of the participants gone into diabetes remission. Not only that, now we have 2-year data from direct study where it has been shown remission is closely linked to weight loss. 64% of the participants who have lost more than 10 kilos remained in remission even after 2 years. So if somebody who has lost weight and is sustaining that lost weight, it is possible to maintain remission even in long term. So what are the key learnings from these 3 important studies? 40 to 45% of the individuals can achieve remission, and durability has been demonstrated now even up to 2 years. Younger individual, less than 50 years versus more than 60 years, with relative shorter duration of diabetes, remission is seen in younger individual, shorter duration of diabetes. Individual who are needing fewer medications, does not are on insulin therapy, have lower HbA1c, more chances to achieve remission as compared to those who are needing multiple drugs or on insulin therapy. Response neither depend on absolute weight loss nor at baseline weight or at baseline BMI. Now this is important. There is no change in muscle insulin resistance during these 3 important studies. There is reduction in hepatic glucose output which is comparable in both responders and non-responders. But then those who have responded, those who have gone into remission, beta cell function improved markedly. Therefore, duration of diabetes is important. Weight loss of around 15 kg has been established as threshold based on these 3 clinical trials. Now before I stop, a new concept in type 2 diabetes has come up, subtypes of diabetes. Now these subtypes of diabetes are severe insulin deficient diabetes, combined insulin resistant and insulin deficient diabetes, severely insulin resistant diabetes, mild obesity related diabetes and age related diabetes. Now again, in routine clinical practice, if we are going to apply the concept of remission, we have to understand there is good and excellent probability only in those who have severe insulin resistance, obesity related or mild age related diabetes. Somebody who is having marked insulin deficiency, probably the concept of remission or reversibility does not apply. So again, this is a very practical information. But then it is not so simple. I have mentioned few questions. Dr. Mukesh, this is for you to plan out future research for you in diabetes remission. So this is for you. Now, how best is to maintain maintain the initial advantage which you have gained by taking low-calorie diet. How long somebody can continue on this low-calorie diet, it's a big question. Remember, 72% of the people with BMI more than 40 kg does not have diabetes. We now wrongly label obesity for each and everything because there is commercialization of obesity nowadays. Again, in this conference also you are going to listen many lectures on newer pharmacotherapies. But remember, 72% of the people who are having BMI more than 40, they does not have diabetes. It means obesity per se itself, there are some other factors. Genetic factors are important. Large number of people with type 2 diabetes with BMI less than 25. Still they have diabetes, they are not obese, which means something beyond. Currently, whatever literature is available, the concept of remission of diabetes is applied on those where BMI is more than 27 kgs. Now, today in Asia, in our country, BMI is defined as 23. Whether this concept of reversibility, remission is applicable on that population, in our population, we do not have any information. Beta cell factors that prevent return to normal glucose needs to be identified. Why I am saying so? Weight loss of more than 15 kg did not reverse type 2 diabetes in at least good number of patients even in direct trial. So therefore, if somebody is losing weight, that is not a direct mean, he is also going to have reversal of diabetes. Even weight loss of more than 25 kg after bariatric surgery did not result in remission of diabetes in as much as 39% of individuals on an average duration of 10 years. Duration of diabetes is today probably the strongest predictor, and C-peptide assessment is a good marker for that. Weight loss above 20 kg. Sometimes we think 15 kg पे इतना हो रहा है तो 20 पे ज़्यादा होगा. No, it is not associated with that. South Asians are more susceptible to diabetes at a lower BMI. Whether such individual needs to lose less weight as compared to Caucasian counterpart, again we do not have any information. So this is what I have shared with you. We know about concept of remission based on the pivotal studies. Lots of gaps in the knowledge, unmet need, research is needed, large number of questions which needs to be answered. So friends, to conclude with, type 2 diabetes is a chronic heterogeneous condition. Largely excess calorie consumption over time is one of the biggest modifiable risk factor. If you have excess calorie intake, there will be ectopic deposition of fat in liver, in pancreas, in other organ, which is responsible for increasing your insulin resistance, for doing your beta cell dysfunction. Weight loss is found to be beneficial. It is possible that remission of diabetes is a reality, at least in early stages of diabetes. We have evidence. If your diabetes is less than 4 years, we can practice this concept. Partial reversal of remission, which means you can reduce the number of drugs, you can stop the insulin therapy, which is possible probably at all stages of diabetes with good lifestyle. So with these few words, thank you very much.
Now may I ask a question?
Haji sir, aap hi?
Yes. Beautifully described. Now I've got two questions. First, along with low calorie diet or very low calorie diet of less than 800 calorie, is the type of macronutrient also matters? I should say very low carbohydrate diet or very low calorie diet, which is better?
When we are talking about very low calorie diet, which has been used in this trial, these are liquid diets. These are pre-made diets which have fixed amount of fat, proteins and carbohydrates. So in real world, these are pre-made liquid diets available in the market. They are used in clinical trial. So they are not, otherwise the diet restrictions we are performing in our routine clinical practice. So they are different types of diet. And then in all these trials, after patients are out, they are switched back to their isocaloric diets which they are taking in their routine practice. Otherwise, restriction of carbohydrate is important, but elimination of carbohydrate is not advisable. There is a fat ketogenic diet which is quite popular. It itself is associated with lots of issues. So ketogenic diet is also not recommended for each and every individual. Ketogenic diet is associated with fatty liver, it is associated with lipid abnormalities, it is associated now with accelerated atherosclerosis. So basically it has to be a balanced diet, a balance of carb, proteins and fat. In our country, what we are consuming is basically a predominant carb-rich diet. And to me, apart from macronutrient, it is the need to eat which one has to identify. This is by me that you have to eat by brain, you have not to eat by time. Now what we are doing conventionally today is, when we get up in the morning, whether we are feeling hungry or not, we see the clock, 8 बज गए चलो नाश्ता करते हैं, उसके बाद स्नैक्स खाते हैं, 1 बज गया या 2 बज गया, अभी हम सबने अपनी घड़ी देखनी चालू कर दी होगी, लंच कब डिक्लेयर करेंगे हम लीजिए. अब किसी को भूख ही नहीं लग रही तो लंच क्यों कर रहे हो, उनके पैसे बचाओ भाई. So if we start eating by brain instead of eating by time, the God has created a hunger center, satiety center here. So if we follow those natural cues, probably obesity will be taken care of. But somehow this needs lots of behavioral changes, which are very difficult to implement.
This particular topic, this topic is specifically taken in this conference for a reason, that because in last 3 to 4 years, all sciences towards obesity. So very meaningful messages have been given by Dr. Rajput that every obesity is not bad. There is a thing like healthy obesity as well. And we should not be overdriven by the science which is flowing at the moment all around us. So that remission part, yes, that is effective, but already a very nice summary slide has been shown that we have to be very careful that we have to be attempting only in a moderate sort of phenomena. Any extreme doing is not going to give you results the way you are expecting in today's world. So with that meaningful thing, this particular topic was picked up, and probably the message is very loud and clear, and you have done it so excellently well that you have to be very cautious and careful. Thank you so much.
Thank you.
Dr. Alnegar wants to come in and chip in for size comments.
Thank you very much. Thank you for having me here to start with. Very kind people in your beautiful country. I just have one problem with this healthy obesity perspective. There's no such thing as healthy obesity. Obesity, even if the patient does not have end products of obesity, any end organ damage yet, obesity is a risk factor for all these people. Can we say that high cholesterol is healthy? If a patient lives and dies with high cholesterol without dying of heart disease, can we say it's healthy? The patient didn't have heart disease. Can we say if a patient smokes all their life and doesn't get lung cancer, doesn't get stroke, can we say it's healthy? It's a risk factor. Risk factors are not healthy. High blood pressure. They go and be asymptomatic with high blood pressure for 30 more to 40 years and die with something completely. Can we leave it? It's not healthy.
So it's a big debatable question which you have raised, and if you see the last 2 slides, now if somebody who is obese, as per the standards which has been laid down by various people, but he has normal glucose, normal blood pressures, normal lipids, he walks 10 kilometers a day, he has no limitation of life. Now listen, if he has no limitation of life, why we should treat this obesity? We do not know. Everybody obese does not. So it's a hot, debatable topic, which is probably large number of commercially driven factors are involved in it. So we have to be careful, take a call, varying from patient to patient, that how we are going to choose various types of therapies in our patient, because now we are surrounded by so many drugs driven by
driven by so many factors. Thank you very much.
Sir, may I ask one question?
Please.
Sir, it was a nice lecture. I enjoyed listening to you. Sir, may I have just one query that these weight loss drugs, newer weight loss drugs, that is Mounjaro and DBD, are shown to be less effective in diabetics than non-diabetics for
Yes, Mr. Right. So actually that was not my topic. In diabetic, there is a concept that our adipose tissue become dysfunctional. It is not as in a normal obese individual without diabetes. Number two,
Diabetic individuals are on number of
Other drugs which itself promote weight gain, say like sulfonylurea, your insulin therapies, one of the commonly prescribed drug, pregabalin, which majority of doctors write, I do not know for what reason. So large number of drugs per se promote weight gain. So there are many secondary factors, primary factor related to the disease, adipose tissue dysfunction, and therefore adipose tissue is not responding similarly. So with both the drugs, it has been shown that the amount of weight loss is almost 50% less in diabetic population as compared to non-diabetic population.
Now the session is closed. Thank you.
May I request all the chairpersons and panelists and speakers to be on the right side of the podium for the felicitation ceremony, and I will request for the next session. I will request the chairpersons, Dr. Dharmen Uraiya, Dr. Pulak Raj, Dr. D.K. Shukla as panelist, and Dr. Ashok Kumar as panelist. And Dr. Dharmen, you may please invite the speaker and introduce the speaker.
For next session, I would like to invite Dr. Nivedya Chattopadhyay to talk on adiponectin receptor as a potential target for treating type 2 diabetes. So Dr. Nivedya Chattopadhyay, he has done his PhD. Presently, he is a research advisor at Paris Life Science. Past, he has had the post of chief scientist in CDRI, Lucknow, and he was assistant professor in medicine in Harvard's USA. He has got 8 patents and 271 publications, and his major achievement is he is one of the 2% scientists in the Stanford University global ranking. So over to Dr. Nivedya.
थोड़ा बहुत यही करो ठीक है okay yeah let me at the outset extend my sincere gratitude to LDSSCON for giving me this opportunity to share some of my findings with the audience. I am fully aware that the audience is predominantly, if not completely with the exception of myself, is comprised of clinicians. What you see here, my association is being for the past 4 months now, and the data that I will be sharing with you has been generated while I was at Central Drug Research Institute. This conflict of interest also relates to my tenure at Central Drug Research Institute. Now, what will you know from this talk? 3 things that you will know from this talk, but before I begin, I am basically a person whose expertise is on metabolic bone disease and related research on musculoskeletal health. So from there, how I bumped onto something related to diabetes would be what you will come to know, and that is what I will trace today. As you know that research never moves in straight line. And with the change in the data, or the surprise in the data, we had moved following the data. So here you will know from here what you will know here is about adiponectins and their signaling. The adiponectins are the most abundant adipokines, and the levels in the serum is pretty high compared to other cytokines. Adipokine level will range from anywhere between 2 to even 30 microgram per milliliter. And then I will discuss about the effect of an endogenous adiponectin agonist on bone and muscle, which actually gave us the clue that how it can have effect on the mitigation or the treatment of type 2 diabetes mellitus, and our search for peptides and small molecules to activate adiponectin receptor, particularly the type 1 receptor. Now if you see, look at the adiponectin simplified cartoon showing adiponectin structure. It has an N-terminal variable domain and it has collagen domain. Now what collagen domain does is that, I'm using this pointer. This collagen domain is the most important part of adiponectin structure. Because remember, like collagen, it allows multimerization of protein. Like collagen is a multimerization, oligomer kind of a protein, laminin, TNF alpha. So it has this collagen domain that allows multimerization, which assumes the higher order of structure that is taken or assumed by adiponectin. And then there is a globular domain, the C-terminal domain, which upon enzymatic cleavage leads to globular adiponectin. And this globular adiponectin, GAD, it exists in trimer. Remember, although the circulating level is pretty high, microgram per ml, adiponectin is never monomeric. It is always multimeric. Either it is globular adiponectin, which is a trimeric form, which is endogenous, and then there are low molecular weight adiponectin, which is a trimer, medium molecular weight, that means 2 trimer bound together, and high molecular weight would be 4 adiponectin trimers bound together. And this is high molecular weight adiponectin, which actually is most abundant adiponectin agonist in the serum. But despite the fact that it is the most abundant, what happens is that this form activates predominantly type 2 adiponectin receptor, and this one will activate predominantly type 1 adiponectin receptor. Now, we have already seen and we are bombarded with GLP-1 receptor agonist. GLP-1 receptor agonist is G protein coupled, right? It is a G protein coupled with GS, G stimulator. Now look at the adiponectin receptor structure. This is also a 7-transmembrane receptor, just like G protein coupled receptor, just like similar to analogous to GLP-1 receptor. But in this case, it is an inverted GPCR. Its carboxyl terminal is extracellular and amino terminal is intracellular in both R1 and R2. So it is an inverted GPCR. Now the signaling, so this is adiponectin. When it binds to either adipo R1 or R2, any 7-transmembrane domain receptor, it will recruit first adaptor protein, which is in this case is APPL1, and then there will be fast or the rapid signaling, and there will be delayed signaling. Among the rapid signaling, the most important signaling is phosphorylation of AMPK. AMP is a cellular energy sensor. So when AMP is high, that means the cell is saying that I'm hungry. So that is getting phosphorylated, and following phosphorylation of AMPK, after AMP8, adiponectin signaling, there will be downstream phosphorylation of acetyl carboxylase, PGC1 alpha. Now PGC1 alpha is a mitochondrial biogenesis factor. It stimulates the cell to produce mitochondria and effectively utilize energy. So with what phospho-ACC and PGC1 alpha does is increase fatty acid oxidation, increased utilization of energy, that means production of ATP, and then phospho-P38 will lead to increased glucose transport by GLUT4. It will enhance glucose uptake. That is activation of AKT pathway, which is similarly done by insulin, but in a different way. I will show you data that will promote glycolysis and inhibit gluconeogenesis. At the same time, adiponectin will mitigate inflammation by inhibiting NF-kappa B. And the last of all, a delayed signaling takes place by PPAR alpha, which is activated by adiponectin, and there is increased and sustained fatty acid oxidation and reduced fatty acid synthesis. So overall, there is a less production of fat, increased utilization of glucose. That is what is done by adiponectin. So in terms of its regulation, very briefly, adiponectin levels are low in metabolic disease, in diabetes, type 2 diabetes, in obesity, adiponectin levels are low. Estrogen enhances adiponectin production, and adiponectin, being the ligand, will induce its own receptor expression, so there is a positive feed-forward or beneficial feed-forward loop will take place. Now, overall what happens is that adiponectin is a system-level metabolic integrator. In the case of adiponectin R1, there is a rapid signaling of induction of AMPK, particularly happening in skeletal muscle, and in case of adiponectin receptor 2, ADIPOR2, it has an endogenous ceramidase activity that will lead to the conversion of ceramide to sphingosine. Sphingosine will undergo phosphorylation. That will lead to increased transcription of PPAR alpha in liver, and that is a delay of the slower pathway. So basically it is covering the muscular side or the skeletal muscle side for the glucose uptake and preventing fatigue. So we started, as I said, that I am basically a bone and muscle biologist. I started to test what is the effect of globular adiponectin, which is present in the circulation in the trimeric form, and what is its role in osteoblast. And we found that it induces osteoblast function in vitro assays using ALP production, and then it promotes a rapid phosphorylation of AMPK, and it induces its own receptor, as I said that it does in the osteoblast by 72 hours. It will induce PGC1 alpha at 36 and 48 hours. So you see, whereas in phospho-MPK the activation is within minutes, here it is it takes a matter of hours. And when you add the inhibitor of phospho-MPK, which is dorsomorphin, the PGC1 alpha production is mitigated. So this is a downstream. So phospho-MPK followed by PGC1 alpha, the mitochondrial biogenesis factor, and then if we silence PGC1 alpha by siRNA, what we see in this case, okay. Oh, sorry. So what you see in this case, that the ALP, the production of osteoblast differentiation was reversed by globular adiponectin. And then here in this case, we studied the mitochondrial versus glycolytic effect, and what we found is that oxygen consumption rate was strongly induced by globular adiponectin, and resultant was increased ATP production, and SIPGC1 alpha mitigated those effects, and proteinol, which is an electron transport chain inhibitor, blocked the pure osteoblast differentiation, but not 2-deoxyglucose. That means that only oxidative phosphorylation is driving or fueling osteoblast differentiation caused by globular adiponectin and not by glycolysis. And when we gave globular adiponectin to the animals, overectomized animals, we saw that the effect of globular adiponectin at 100 microgram per kg completely restored the bone mass and was nearing or approaching that of teriparatide. The bone strength was also tested, which is a surrogate for fracture, and the bone strength was restored, and the bone formation, which is a hallmark of PTH, was also seen to be matched to that of globular adiponectin. So it is an anabolic effect. It also mitigated or improved OVX-induced sarcopenia, and from here we started to get an idea that most probably it may have beneficial effect on type 2 diabetes. In this case, we found that it is a gastrocnemius muscle, and we found that the cross-sectional thickness of gastrocnemius muscle was reduced in overectomized animal, which was significantly improved by globular adiponectin as well as ferret diameter. And when we studied the genes or the proteins related to sarcopenia, MyoD was reduced in case of overectomized animals, but was completely restored, whereas the catabolic proteins such as atropine 1 and MARF1 were increased in overectomized muscle but decreased. Adiponectin receptor R1 was decreased, BDC1 alpha was decreased, both were reversed by globular adiponectin. But globular adiponectin is not a viable option for clinical translation. So what our peptide chemistry is that from the collagen, remember I said that the collagen domain is key for oligomerization. In this case, what Dr. Jimut Ghosh did is that he identified a sequence rich in glycine and histidine repeat. And these repeats allows this peptide, this is only 13-mer peptide, but it allows the peptide to oligomerize and take a higher order structure. And now look at when we did the glucose uptake assay in L6 myocyte, what happens is that with insulin, you get a strong activation of glucose uptake within 20 minutes. But in case of adiponectin, the effect is pretty slight. Remember that it activates AKT very much like insulin, but in this case, the glucose uptake is sluggish and it starts to go up at around 60 minutes and then continues to remain elevated. And when we studied the signaling pathway in C2C12 myocytes, like metformin, it induced phospho-MPK, it induced the induction of phospho-MPK was similar between metformin and ATP1, and then in DBDB animal, the DBDB is a leptin receptor mutated animal which are obese because they eat more and they have neuropathy and nephropathy, but they don't develop retinopathy, and it is quite a commonly used diabetes, type 2 diabetes animal model. And in this case, what we see is that when we did the oral glucose tolerance test, when we use the oral glucose tolerance test, we found that ADP1, this 13 amino acid peptide, was very much comparable to that of insulin, metformin in terms of oral glucose tolerance. Now, as this peptide chemists were struggling to make a better peptide because the dose was 30 milligram per kg, we started looking at the possibility of whether small molecule can have adiponectin receptor agonistic effect. And we studied the literature with the filter that it should have a positive effect, beneficial effect in type 2 diabetes. It will reduce obesity and it will rapidly induce phospho-MPK. And by studying, mining a large number of papers in thousands, we found, and we used AI in this case, and we found that this is the structure that most probably will do the job, which is quercetin. And quercetin is very common phytochemical. And when we looked at our natural compound library, we found that we have this many analogs. Now, when we studied these analogs in our phosphoenzyme studies, we found that this one is the most potent one. And we already actually had laid our hand on this kind of structures, and we found that they have positive effect on bone. That was what we found. But we haven't yet tested them in energy metabolism or in diabetes. To give an example of what we found their effects on bone, is that this compound, which we have in our library, which also already had a US patent, it was very similar to PTH in terms of restoring bone formation in osteopenic animals. It improved the glucocorticoid-induced bone loss, and it was comparable to PTH, and in this case we used methylprednisolone to induce glucocorticoid-induced bone loss. And as you know, that glucocorticoid is not only a cause for osteopenia, but also it causes sarcopenia. And we found that when we use dexamethasone, which is the strongest of all glucocorticoid, presence of GTTF was able to restore or improve glucocorticoid-induced sarcopenia as assessed by myotube area determination. That was in vitro as well as in vivo. It was able to completely reverse the deficit we find in terms of sarcopenia in dexamethasone-induced glucocorticoid treated animals. And then when we did the Western blotting of the muscles, gastrocnemius muscles, what we found is the PGC1 alpha was so much down in glucocorticoid treated animals, was completely restored, whereas this catabolic muscle proteins, activin 1 and MARC1 that were enhanced, were completely restored to their normal level. So the mechanism is that one will promote muscle formation and on the other hand mitigate the level of catabolic protein. Now when we got this data, then finally we asked this question. We asked the question is it a adiponectin receptor agonist? And here we radio-labeled GTTF. And this was done in collaboration with Professor M.M. Godbole at SGPGI. And here we overexpressed adiponectin receptor 1 and 2 individually in CHO cells, and then we used radio-labeled GTTF and chased with cold GTTF, and what we found is the most spectacular finding. And the finding was that ADIPO-R1 agonism of GTTF is almost 70 times more than ADIPO-R2. The KD is 4.9 nanomole per liter, whereas here it is 326 nanomole per liter. This is 70-fold within the adiponectin receptor family. And then, as I said, that because it is an inverted GPCR, we wondered that I'm almost finished. We wondered that if it activates other GPCR, we did the profiling and none of those were activated. And finally, coming to its metabolic parameter in DBDB animals, it improved restored glucose utilization, restored beta cell health, and it induces browning of fat. And it also improved bone phenotype in DBDB mice. So, together to conclude, GTTF mitigates osteosarcopenia, one of the small peptide derived from the collagen domain, can mitigate osteopenia and improve glucose utilization, and the small novel compound GTTF activates R1, the R1 specific, and improves metabolic health in DBDB animals. The large number of people were involved, several outside collaborators were involved, and funding was obtained.
Thank you for such a lucid and wonderful talk. We hope we will see another class of drug to treat diabetes in the coming years. With this, we can have one or two questions from the house. If not, we can close the session.
Thank you, Speaker sir. Thank you, Chairperson, Shanti, panelists. Please come on the right side of the dais for the felicitation ceremony. For the next session, I'd like to invite Dr. Satish Kumar as Chairperson. Dr. Satish. Okay. Dr. Satish, Dr. Mujahid, and Dr. Jyogi Pankaj as chairpersons, and Dr. K.P. Verma, Dr. Jyogi Verma as panelist. Dr. K.P. Verma, are you there? Okay, sir, as panelist. Dr. Satish, you may please introduce the speaker.
Very good afternoon to all. I would like to invite Dr. Amita Sugi sir for next topic. Dr. Amita Sugi sir is MBBS and MD from KJMU Lucknow, and he is DM Endocrinology from BHU Varanasi. And Dr. Amita Sugi sir is consultant endocrinologist from in RK and Eye Clinic Meerut UP. He was awarded with NN Gupta Gold Medal in MD Medicine KJMU Lucknow, and he is also ex-associate professor in Department of Medicine Shobharti Medical College Meerut, and founding member of World Integrated Society of Diabetes, Endocrinology and Nutrition. He has many research papers published in both national and international journals, and consistently he is engaged in number of teaching programs, particularly related with diabetes, thyroid and reproductive endocrinology, and have delivered many lectures in various forms like SICON, API, IMA, UP, endocrine chapter, and he is also a co-chairperson the scientific committee of UPRPI Meerut 2019, an executive member of API Meerut chapter, and also a faculty CCDM and CCBMD. And sir, over to you.
Thank you so much, and a warm good afternoon to all the audience. Stepping into Lucknow means that is a sense of belonging, and it's a nostalgic feeling. And with the stalwarts of my fraternity, I feel that I have gone to my college days and am presenting a case in front of them. And if there is any wrongdoing, I have mentors who will correct me. So we have just gone through one of the fascinating researches has just been pointed out. And the one point which clicked to my mind was, is there a new molecules in pipeline which will be combined with GLP-1 receptor agonist, and so that we can take care of this sarcopenia and bone health which we are seeing with these agents. Anyhow, it's an inviting news. Friends, I'll move from bench to bedside with my deliberation, and I'll be talking about a molecule which is a combination of a basal insulin, glargine, and a GLP-1 receptor agonist, lixisenatide, and it is named as iGlar-Lixi. I'll go through one of the study from an Indian origin, which gave us a snapshot of how diabetes is being managed. It's a 3-year study and tells us about what you already know about type 2 diabetes, about the complexities of type 2 diabetes, and therefore we rope in those agents in our armamentarium so that we can hit those pathophysiological defects in managing diabetes. So one class of group, if you choose for managing diabetes, will suffice long. The bitter truth this study highlighted was that are we reaching the target of HbA1c less than 7 in our diabetic patients? No, we are not. More than 60% of people who are living with type 2 diabetes are still beyond that Lakshman Rekha of 7. And what does it lead to? It leads to something which is very uninviting. It leads to 20% vasculopathy in our patients, which is micro and macrovascular complication. We have Dr. Rajesh Rajput speaking about obesity, and there was some debate about it. But then we have a hard fact that about 65% of our patients with type 2 diabetes are obese in any form. Whichever criteria used, 23 or 27, they are obese. So what does this study tells us about? tells us about the complexities in the pathophysiology of type 2 diabetes. It tells unmet need with all those agents roping in and day out, why we are not able to reach the target of less than 7. And I put one step forward. We should think beyond glucocentric approach in managing diabetes. What about hypertension? What about lipid? If we add these two into diabetes, I think the number will be more bleak and much more troublesome to us. So keep these 3 points in mind, because the onus of my deliberation would land upon you. So there are unmet needs in advancing diabetes management. My talk begins when oral hypoglycemic agents have failed in maintaining this control of diabetes. So we know that beta cell dysfunction will occur as the diabetes duration will increase, and we will look upon injectables. And I think among the audience, most of us prefer using as initiating insulin, we initiate insulin in form of basal insulin. But basal insulin is the end of the story? It's not. You have to think even beyond basal insulin. So you intensify the basal therapy by adding a
bolus shot, which becomes a basal plus regimen, and we keep on adding, and it becomes the traditional basal bolus regimen. Or once the basal insulin fails, most of us still uses premixes and co-formulation. We use it once a day or twice a day. And now we have injectable GLP also. So we can add a GLP-1 from another pen to the ongoing basal therapy. And last but not the least, what else we can do is, we can give a combination of basal insulin and a GLP-1 receptor agonist in a single pen. That is the fixed ratio combination of I-GLAR-LIGZ, glargine, the basal insulin, lixisenatide, the short-acting GLP-1 receptor agonist. This is a traditional form of escalating or intensifying your insulin therapy. You start with a basal plus, and then ultimately you reach to triple
basal bolus shots and a single basal. Another way of intensifying a basal therapy was you go and shift the patient from basal therapy to premix. Either premix once a day or twice a day. But while we are doing this exercise, what we are doing? We are increasing the number of shots from 1 to 3, and the complexity of the regimen is increasing. It's a bitter fact. You write a basal bolus regimen to the patient, and how many of the patients are able to take 4 shots daily? During festive season, during travel, during illness, they often skip 1 or 2 shots. And after 3 months, when we get our A1C done, we are off target. Doctor साहब लेट रहा था, शादी हो गई, छूट गई, अयोध्या में दर्शन के लिए गया, 2 दिन पेन छूट गया, दिक्कत कुछ नहीं हुई, and the story will keep on revolving in it. So what do we need? We do need simplistic medicine, treatment, so that the prick goes down, and the number of pills should go down, so does the prick should go down. And the prick should contain agents which will hit different physiological defects leading to diabetes. And now, with the ongoing evidence of GLP-1 receptor agonists, that they are not only efficacious, but they are also cardioprotective, at least some of them, like liraglutide and semaglutide. So the guidelines of 2025 ADA standard says the first injectable to be introduced in type 2 diabetic patient, if the patient is not having hyperosmolar symptom or crisis of hyperglycemia, should be either GLP-1 receptor agonist or a twin incretin, that is tirzepatide. So we have gone beyond insulin now. We have to think much more than the traditional way of intensifying the oral hypoglycemics. Having said so, our patients do not accept GLP-1 receptor agonist because of so many reasons, and one of the reasons is cost. They are not pocket friendly. They are not pocket friendly. And once the patient is not willing to pursue the treatment you prescribe, the adherence is compromised. And in chronic illness, if the adherence is compromised, the target is offshore. I think most of us will agree this. So the traditional way is, we still go with our darling basal insulin first, then we can we intensify by a basal shot, let it become basal plus or basal bolus, or we go in for a premix insulin. But now, there is an opportunity to introduce GLP-1 receptor agonist following basal insulin. Either you give a separate pen, 2 pens, or you can combine two in a single pen, iGLAR-Lixi. The first in this lineage was Idec-Lia, a combination of basal insulin, second generation basal insulin, Regulate and liraglutide. But somehow, the pharma giants have taken Idec-Lia off the market. And the only available molecule is iGLAR-Lixi as of now. What opportunity does it give to us? Now go back to that landmark study what it taught us. All of them, most of it can be taken care with this particular combination. Like they address multiple physiological defects, they increase convenience and therefore improve adherence to the therapy. That is a very important and practical point. You will achieve the target early and with greater persistence. Reduces the risk of weight gain with insulin monotherapy and reduces the hypoglycemic episodes too. And last but not the least, with a good efficacy, they will delay the onset of macro and microvascular complications. Needless to say, the basal insulin will reduce the fasting plasma glucose and the GLP-1 receptor agonist component will take care of the post-familial peak. You are getting two molecules in a single break that is much more acceptable in clinical world. So having said so, the science behind the combination of a fixed ratio combination, do we have evidence to it? Yes. The wall of evidence of iGLAR-Lixi is very strong, and these are the patients in whom it has been tried as a garden variety cases we see. First and foremost is when the oral hypoglycemic agents are not doing their job. So you have exhausted with 2 or 3 or 4 groups of OADs, and now you want to intensify the therapy. So either you add a large into it, or you can add a combination of Lixi and iGLAR-Lixi or a co-formulation. Patients who are on basal insulin, you want to intensify, you can add iGLAR-Lixi. Those individuals who are on GLP-1 they can also be shifted to iGLAR-Lixi because basal insulin is being added, or individuals who are on premix, you can shift those patients from premixes to iGLAR-Lixi combination. So I will take through just 2 cases and I will cut short the busy slides in the presentation so that we gain more time for discussion. So the first and foremost study is the SOLID study. Very simple to go through. It's a Chinese study. Type 2 diabetic patients who are on oral hypoglycemic agents and they fail to maintain an A1C. The baseline A1C of the study was 8.5, very common in our clinical practice. And now what you did? You give iGLAR-Lixi to one arm and you give co-formulation, that is Rhizodec, that is IDEC-ASP to another arm. So this is it. The first arm got the iGLAR-Lixi and the second got IDEC-ASP once in a day, and it's a 24-week study, and the primary endpoint was non-inferiority in A1C. So we do not want to show the superiority, we want to show they are as good as in lowering the A1C, the 2 groups. What we find? We find the lowering of A1C was achieved in both the arms, and it is very well accepted. Both did wonderful, because in both the arms you see the A1C went below 7, because these are intention to treat trials. Anyhow, both the arms have to bring the A1C less than 7. But that result showed it is not only not inferior, iGLAR-Lixi, it is superior to lowering of A1C by 0.2% A1C. Many of us will just give a sarcastic laugh. What is the difference of 0.2% of A1C reduction? It hardly matters. Just keep your smile to your face, and then we'll explore that how this difference means to us. Not only this, you can see the weight part, which you always keep in mind, was lower in iGLAR-Lixi because of the GLP-1 component, whereas there was weight gain with IDEC-ASP. You see the mean dose of insulin, it is 28 in iGLAR-Lixi, it was 34 in this. So lower dose of insulin or the formulation was required. There is the importance of 0.2% difference. That is, more number of people were able to achieve an HbA1c of less than 7 with IGRLC. You go ahead, less than 7 without body weight gain, and then the ultimate nirvana endpoint. Less than 7 without weight gain and without hypoglycemia. This was in favor of IGRLC. Level of hypoglycemia were lower, so we concluded that IGRLC was superior in A1C reduction with IDAC, that is ISLEC, superior weight, benefit, more patients achieved the target, lesser hypoglycemia, and there was no safety events. Another study is the Solomix study, where you are giving IGRLC and then you are giving aspart, no mix, which you often give. And just to cut the story short, I would say the same result was replicated. In terms of A1C reduction, in terms of more people achieving the targets, in terms of lower insulin dosage requirement, and hypoglycemia also went down. So, when you compare your premixes with IGRLC, and premix are given twice a day, here the IGRLC is being given once in a day. Better glycemic control, lesser hypoglycemia, fewer daily dose injections, and efficacy. So these two studies point towards the importance of IGRLC in a practical way. How does it given? It is in the form of a solo start pen, what we often use. Here the glargine and lisinopride are in the ratio of 2:1, and this is marketed in India. There are other preparations also, let us not go into that issue, because what is available, let us see. So if you will increase the step to 10 units, so if your 10 steps are clicked, it means you are giving 10 units of glargine and you are giving 5 micrograms of lisinopride. The ratio is 2:1. And the maximum dose you can give is 40 units. So you start with 10 units or 10 steps if the patient is insulin higher, or if the patient is using already glargine but the dose is less than 20. So very simple, you start with 10 units. Or if the individual is already on glargine but the dose is more than 20, you can start with 20 dose steps. So it's very simple, if you give 10 steps, you are giving 10 units of glargine, vis-a-vis you are given 5 microgram of lisinopride. This is given subcutaneously once in a day within an hour of the meal. You choose the meal, you give it within an hour of the meal, preferably in the breakfast. Now there will be an argument, it's a short-acting GLP-1 RA, how it will show its efficacy. There are explanations to that also. It is preferable to give at the same meal you choose. But where lies the advantage? The advantage lies that if you miss a dose, you can give this missed injection before the next meal also. So there is a flexibility component. It can be given in elderly, more than 65 years of age. With renal impairment, those in a CKD stage 4 and 5, it should not be given, but you can give till the eGFR is more than 30 ml per minute. Hepatic dysfunction, mild to moderate, contraindicated in pregnancy and lactation. So just to summarize, the combination, that is the fixed ratio combination of IGRLC work is synergistic. It will control not only the fasting but the post-prandial component, effective in A1C reduction, addresses multiple pathophysiological defects leading to diabetes. More people are able to achieve glycemic control. Beauty is once in a day combination. Benefits of weight, low risk of hypoglycemia, and improved GI tolerability versus monopharmacy. This is how I summarize it, that once the OAD are suboptimally controlling our A1C, the basal insulin is exhausted. You are using premix insulin or using GLP-1 RA. We have biosimilar GLP-1 RA available with us. If all of them is failing, you can shift very well to a fixed ratio combination of IGRLC, which is given once in a day, and the maximum dose of lisinopride amounts to 20 micrograms per day. You cannot go beyond that. So there are some practical tips once you start using this molecule. So the issue and the point in favor of this is it's a one injection, given once in a day and given within 1 hour of meal. This is a very practical approach of managing or intensifying your therapy for management of diabetes, and With this, I end my deliberation. Thank you so much, paying my utmost respect for my alma mater, for which I am here. My teacher, Professor Shari Vasti ma'am is here. My regards to you, ma'am. And it's wonderful being a part of you. Thank you so much.
Thank you so much, sir, for before time completion of the lecture. This was an excellent topic, sir. Thank you so much for your contribution. Thank you. Any one or two questions can be asked from the house. Okay, we are closing this. Thank you.
Thank you, Dr. Amit. Fantastic talk, well in time. So, thank you so much. I request speaker, chairpersons, and panelists to be on the right side of the stage so that we can have the commencement ceremony. And for the next and a very important lecture, we have Dr. Mohammed Al Nagar from UK. To chair the session, we have Dr. Abhishek Arun, Dr. Avivar Avasti, and Dr. Anurag Srivastava. Dr. Rajesh Khare and Dr. Vivek Katiyar as panelists, please be on stage. And Dr. Avivar, you may please introduce our respected speaker who has come right from the UK to deliver a talk in Lucknow. Over to Dr. Avivar.
Hello. Yeah. Good afternoon and welcome all. I would like to introduce Dr. Mohammed Al Nagar. He's a consultant endocrinologist, lipidologist, and clinical lead for lipid services at the University Hospitals of Morecambe Bay NHS Foundation Trust. He is also currently the clinical lipid lead of South Cumbria and Lancashire. With a background in diabetes and lipidology from Alexandria Faculty of Medicine, he brings his extensive experience in managing dyslipidemia, diabetes, and obesity. His integrated approach focuses on overall CVRM rather than treating conditions in isolation. He has played a key role in establishing local lipid services, developing guidelines, and implementing innovative CVRM strategies. He is actively involved in education and as a speaker at national and international conferences. He also serves as a principal investigator in multiple clinical trials exploring newer therapies in diabetes, lipids, and obesity care. He is passionate about the platform and reform and improving cardiovascular outcomes both locally and internationally. I give the mic over to you, sir.
Thank you very much for the kind introduction. I will go very quickly into the slide decks because I have a flight to catch. These are my disclosures. Now, I want to say something about the pathophysiology of obesity. People, specifically in our parts of the world, we do not treat obesity as a disease. Now, I have 5 seconds to speak about this there. The American College of Cardiology, the American Association of Cardiology, and, Clinical Endocrinology, and the European Association for the Study of Obesity, both have classified obesity into what they call preclinical obesity and clinical obesity. Preclinical obesity is considered as a risk factor to developing problems associated with obesity. In a similar way, like cholesterol is only a risk factor. If someone has high cholesterol and doesn't develop heart disease, that doesn't mean we should not have been treating their cholesterol all their life. Similar with high blood pressure. Risk factors are risk factors and should be treated as such. Now, people with obesity, in general, the brain has 3 centers to control our food intake and food expenditure. I like to think of them as the angel, the devil, and you come in between to try and control. You have the hypothalamus. The hypothalamus is responsible for what we call homeostatic eating. Homeostatic eating is eating to keep the balance. You've not had food all day, your calories are low, your glucose is low, the brain senses this, please go eat. You eat, you're full, enough calories, hypothalamus senses this, stop eating. You're eating for the good reasons, the angel of the brain. On the opposite side, you have the mesolimbic system, which is responsible for the primitive reflexes like pleasure and fear. That bit of the brain is the devil of the brain. It makes you eat for all the wrong reasons, makes you eat for pleasure. This is the part of the brain when you've already eaten and you're full, still finds a place for dessert, because the impulse for dessert is separate from the impulse of normal food. And within people with obesity, they have a phenomenon called an increased wanting and a reduced liking of food. Increased wanting means that they crave food too much, more than the pleasure that they actually get from food. The craving is much higher than the actual pleasure that comes in. And this is because of neurohormonal changes. And the decreased liking means that if I and you need one piece of barfi to hit the spot we're okay, they need two, they need three. And this all happens subconsciously, not by choice, in the minds of people with obesity because they have these neurohormonal problems. And then you come in with your prefrontal cortex, your behavioral center, to try and weigh it out. Yesterday I had cake, today I don't have to, etc., etc. So, drugs. More than 20 years ago now, Orlistat came out. Weak medication, 3 to 5% of weight loss, and very bad side effects. And then came naltrexone, and again around 6 to 7% of weight loss. 50% of the patients in the studies dropped out because of how bad the side effects were. And then eventually we had a breakthrough with liraglutide, which was the first GLP-1 to be used for obesity exclusively. Weight loss of around 12%. Then came semaglutide, once weekly, weight loss of about 15%, and then tirzepatide. Tirzepatide is not just another GLP-1 receptor agonist, it's a first-in-class combined GLP-1 GIP receptor agonist. Why is this important? I'll tell you in a second. GIP and GLP have very similar actions, but GLP has a specific action that GIP doesn't have, and GIP has the same. So what do they do? How do they work? Centrally, both of them on the brain depress appetite, increase nausea, give you feeling of satiety centrally. And this is the main mechanism of weight loss. People just don't eat. It's as simple as that. On the pancreas, there's an increase of insulin secretion and a reduction of glucagon with GLP-1. Both increase insulin and glucagon with GIP, but combined together, increase insulin, reduction of glucagon. Now, the GLP-1 specific activity is the slowing down of gastric emptying. That gives you 3 things. First thing, food stays longer in the stomach, and therefore you feel full for longer, and therefore a lot of people will eat 1 meal a day rather than 3 meals a day, because they're full. That's one. Number 2, when food is being absorbed very slowly from the stomach to the small intestine, and from the small intestine to the circulation, this means that instead of having a very high absorption of glucose, a very high postprandial spike after meal, you will have a much smaller postprandial spike because the food is being absorbed very slowly. Now, how about people with obesity? How does that impact them? People with obesity, when you have good insulin secretion and you have that very high glucose spike, you try to counteract that with a very high insulin spike to try and take all that glucose out of the circulation and bring it back into the blood cells in the form of glycogen. So if you have a very high glucose spike, you have a very high insulin spike. Insulin is an anabolic hormone. It takes all this, takes it into the cells. So this is weight gain. So the more of a glucose spike you have, the more of an insulin spike, the more of the weight gain. So GLP, by slowing down all of these things, reduces these 3 mechanisms. How about GIP? How does GIP exclusively work? GIP has receptors in subcutaneous white adipose tissue. Subcutaneous white adipose tissue has one main function. It is an endocrine organ, it's often endocrine, and it has one main function, and that is to store fat. In people with obesity, there's high levels of inflammation in the adipose tissue, and so they are unable to store as much fat as they would usually do. So where does the fat go? Goes on to the visceral fat. And this is the fat associated with insulin resistance, with high blood pressure, with dyslipidemia, with gout, with MASH, with MASH, with MAPL, with whatever you want to call it. All of this is because of the visceral fat. So GIP stimulation improves the function of white adipose tissue, something we call an increased lipid buffering capacity, and therefore the subcutaneous white adipose tissue can store more fat and less goes onto the viscera. So tirzepatide is a single molecule that activates both the GIP and the GIP receptor agonists to give you this mechanism of function: reduction of food intake, a reduction of appetite, and we've noticed a reduction in cravings for fast food, for sweet foods, for alcohol, for smoking, and there's a lot of use of these medications now in drug dependence. There's a lot of trials coming out because that center of the brain, that hedonic center, the mesolimbic system that's responsible for pleasure, when you reduce the cravings they have, you reduce it for everything, and that includes things like addiction. So, I'll take you very quickly to the SURMOUNT program. We'll talk about SURMOUNT 1. Of course, you know, Mounjaro has 2 indications for type 2 diabetes and for obesity. For type 2 diabetes, you have the SURPASS studies. For obesity, you have the SURMOUNT studies. SURMOUNT 1 was done in patients without diabetes. There are 2,500 patients on one of 4 arms, either a placebo arm or 5, 10, or 15 milligrams of tirzepatide. The primary endpoint was to see how much percentage weight was lost. With placebo, patients lost 2.4% of their body weight because all of the patients had 500 kilocalories diet reduced from their maintenance and had to have 150 minutes of physical activity per week. So the placebo lost some weight. With tirzepatide 5 milligrams, 16% of the body weight was lost, and with the highest dose of Mounjaro, 22.5% was lost. Of course, as I said previously, semaglutide in its STEP studies had around 15 to 16% of body weight loss, so it's very much comparable to the 5 milligram dose of Mounjaro. There was another secondary endpoint, which was how much of the patients had a weight reduction of 10, 15, and 20%. As you can see, with the highest dose of Mounjaro, 90% of patients lost 10%, 80% of patients almost lost 15%, and around 2/3 of the patients lost 20% of their body weight. Now, very importantly, we need to know where this mass is being lost. We've spoken about sarcopenia, and it's a very important thing, especially with our population getting older, life expectancy getting more. We know that muscle is related to longevity. The more muscle you have, there are studies to say that you live longer. So basically, a DEXA scan was done to a subgroup of patients in the beginning of the study and at the end of the study. We found that 34% of the fat mass was lost, 11% of the lean mass was lost. So a quarter of the weight loss came from muscle, 75% came from fat. Now, more importantly, the visceral fat, the bad fat, the one that's related to all the comorbidities, has been reduced by 40%, which is again very remarkable. Now, that of course shows in the waist circumference. All of these studies will have waist circumference because it is an indirect measure of visceral obesity. And there was a reduction of around 20 centimeters of waist circumference with the highest dose of Mounjaro. This will lead to metabolic parameters improving as well. So an improvement in systolic blood pressure, 7 to 8 millimeters mercury. We know that 2.5 millimeters mercury improvement gives you a survival benefit. This is 7 to 8. You got around 5 millimeters mercury reduction in diastolic blood pressure. Triglycerides improve significantly, around 30%. HDL improves as well. LDL does not improve that much. Why am I talking about it then? Because if your patients have high LDL and you think they need a statin, please start a statin. These are patients on average who had lost 22.5% of the body weight, LDL didn't change, right? Which tells you that lifestyle doesn't have that much benefit on LDL. So the SURMOUNT 1 is what we just spoke about. Now we'll talk about SURMOUNT 5, which was a head-to-head trial, maximum dose semaglutide versus maximum dose tirzepatide in patients with obesity. So after 72 weeks of observation, semaglutide arm lost around 15.4% of the body weight. The Mounjaro arm lost around 21.6% of the body weight. Waist circumference, again very similar, around 14.7 centimeters of waist circumference versus 20 centimeters of waist circumference with tirzepatide. With the adverse events, we'll talk about all that you can see in front of you here: nausea, diarrhea, constipation, dyspepsia, vomiting, decrease, all GI side effects. All were higher in the tirzepatide arm than placebo. However, if you look here, how much of the patients discontinued the treatment because of the side effects? On Mounjaro 5, 1.3%, 2.8%, 2.9%. So maximum of 3% of patients discontinued the medication because of the side effects. One important thing to mention here is hair loss. You will see that hair loss is higher in the tirzepatide arm than the placebo arm. Why? Any rapid cause of weight loss is going to give you some hair loss. So with bariatric surgery, with GLP-1s, with extreme dieting, you will get hair loss. Why? Because when you're reducing all that nutrient intake, we don't think of micronutrients, things that the hair and nails need, like zinc, or selenium, or manganese, things that we don't think about them. And so when patients reduce all that food, they will end up, by mistake, unintentionally reducing a lot of these micronutrients as well. These were the adverse reactions in SURMOUNT 5, very similar to the SURMOUNT 1. Now, one thing to mention is, despite the fact that between tirzepatide and semaglutide there was the same incidence of GI side effects, more or less, however, if you look at the discontinuation of treatment from GI side effects, 5.6% of the patients on semaglutide discontinued, 2.7% of the patients on tirzepatide discontinued. So there was a big difference in the discontinuation, more than double the amount of patients. Some practical considerations to speak about. You know that the pen has 4 doses, 1 dose a week, and then you go on to the next dose. You start with the 2.5 and you escalate until you hit the dose that you want for your patient. If your patient has type 2 diabetes and you're adding it on top of metformin and SGLT2 inhibitor, these medications do not typically cause hypoglycemia, so you do not reduce the dose. If you're going to add it on sulfonylurea or insulin, it depends on your patient. If your patient is coming in very well controlled and they want to start tirzepatide to reduce the weight, then in that case I might want to reduce the doses. But if they're coming in with an HbA1c of 9 or whatever, then I'll just add it on and continue monitoring to see what happens. There is no dose adjustment needed with the elderly or with renal or hepatic impairment, except if it's end-stage renal or liver disease. At that point, we don't have enough evidence, so use with caution. Acute pancreatitis. I just want to speak very quickly about this. There's been a recent meta-analysis that has compared all GLP-1 therapy by indication, whether that's for obesity treatment or type 2 diabetes treatment or a combination of both, versus all the other medications that patients were on in a very big study in the US, and there was no difference in the incidence of pancreatitis. There was no increased link or association between GLP-1s, all of them, and pancreatitis. Okay? What was the incidence of pancreatitis within these patients? 0.23%. Just to give you that number in context, what's the incidence of people having GI bleeds from aspirin? 1.5 to 4% in the study. More than 10 times more. What's the incidence of people having myopathy with statins? Around 1.5 to 5% as well in most of the studies. So again, more than 10 times at least the amount of pancreatitis. Okay, so put everything into context. It's contraindicated in pregnancy at the moment, and until now not used in breastfeeding. With diabetic retinopathy, any rapid improvement in HbA1c will lead to worsening of diabetic retinopathy. We know this from previous GLP-1s. We know this with insulin as well. So if your patient has severe diabetic proliferative retinopathy that is requiring laser therapy, I would hold off. If your patient has severe macular edema, I would hold off. But all the other levels, the advice is used with caution and close follow-up with ophthalmology. Because the most common side effect is GI in nature, these side effects happen mostly during the dose escalation period. We try to tell our patients what to do with their food in order to try and reduce these symptoms. So we tell them to eat smaller portions, to stop eating once they're full, to avoid eating if they're not hungry, to stay well hydrated, avoid spicy or fatty foods, because of course with the delayed gastric emptying they'll make reflux worse. So to summarize, tirzepatide significantly reduced body weight, around 16% with the 5 milligram dose, 22.5% with the 15 milligram dose. SURMOUNT 5 showed a clear superiority of tirzepatide in terms of weight loss over semaglutide maximum tolerated dose, 21.6% versus 15.4%. There was a lot of improvements in cardiometabolic parameters, and the most common adverse events were GI in nature. Very quickly, I'll take you through 2 cases This lady, Ashna, is 54 years old. She's hypertensive, non-smoker. She has a BMI of 33, which you don't think is really that high, but her problem was she has a lot of osteoarthritis that's getting worse. She was told by her doctor this is because she is obese, and she's told that if she continues doing the same, she will become morbidly obese. Why am I mentioning this? Because in this era of talking about obesity, we need to be careful of the language we use with our patients. Telling our patients you're morbidly obese means you're telling them you're so fat you're about to die, right? Which is not a great way of speaking to our patients. She has 2 kids which she cooks for. She is very socially active and goes out a lot. Her mom died of uterine cancer. Her dad died of type 2 diabetes complications. Blood pressure was a bit high. Risk score, which tells us the 10-year risk of developing atherosclerotic cardiovascular disease was quite high, 33%. Lipid profile was high. Liver functions, renal functions were normal, and she was pre-diabetic. So, we discussed with her incretin-based therapies, but she declined because of the fear of pancreatitis. She read a lot of pancreatitis in the news and decided I don't want this. So she decided she would go on 500 kilocalories less a day with swimming regularly. The plan was to reduce the weight by 10% in 6 months. After 3 months, she lost only 2 kilograms in weight. We had started the statin and started the metformin, so her lipid profile got better. A1C did not really change. So we spoke to her again. She was very much disheartened. 3 months, she put a lot of effort. She only lost 2 kilograms. She didn't see her kids because of all the swimming. She had to miss out on social activities because she could not tell her friends that she was dieting, that she can't eat, etc., etc. And she went to an orthopedic doctor. He said that she would need a knee replacement. At that point, she wanted to start Mounjaro. So she started 2.5, 12 weeks, up to 12.5. When she got to 12.5, she had a bit of nausea, so we held back for a bit, and then we were able to escalate to 15 milligrams. After 2 months on Mounjaro, she lost in total 18 kilograms of weight. HbA1c improved significantly, so the blood pressure and her triglycerides improved as well. My second case is Mark. He is a 62-year-old gentleman who has had diabetes for 12 years, father of 4 children. His wife died. He works 2 jobs to be able to pay for his kids, and he relies heavily on fast food as a result. His BMI is 39, and he fears he won't be there longer for his kids. Currently on a lot of medication for his diabetes, on metformin 1 gram BD, around 3 milligrams BD, and 45 units of insulin RG. Blood pressure very high. Cardiovascular risk was 83%, which basically means he's a heart attack waiting to happen. Lipid profile high, NFTs are high. So this guy drinks 25 units of alcohol per week. This is what they told us. So this could be alcohol, this could be MASH, it could be a combination of both. He has signs of diabetic nephropathy, and his A1C is 8.2%. So one thing that I always want to mention, we all talked about the global control, but it's very hard to remember all these things when you're seeing a patient. And to avoid clinical inertia, I would say remember the A, B, C, D, E's. A is A1C, B is blood pressure, C is cholesterol. D is what I call drugs with benefits. We know now that SGLT2s and GLP-1s have benefits beyond HbA1c reduction, and therefore you should be thinking, why is the patient not on them, rather than which patient should be on them. E is exercise and lifestyle. S is screening for complications and asking about smoking. We talked about
May I request you to please sum up because they have missed something.
Sure. So, basically, we started Mounjaro after he received bariatric surgery. HbA1c improved from 8.2 to 6.2%. He lost 18 kilograms in total and reduced his insulin to 10 minutes per day and thyroid 1 milligram per liter. Thank you very much.
Hello. That was an excellent. That was an excellent clinical lecture by Dr. Mohammed Al-Hacker, especially the ABCDEs. Those were really good clinical pearls. And the take-home message is to reduce the inertia for starting GLP-1 and GIP-1 twin agonists. Thank you very much, sir. Any questions?
Sir, we can change it after this. So, with that, probably I'll request our panelists and chairpersons and the speaker.
How long the patient has to continue this drug?
If we're talking about diabetes, lifelong. If we're talking about obesity, treatment of obesity should be lifelong, but how can we convince patients to pay such a cost lifelong? This is very hard, because when patients stop the medication, they regain a lot of the weight back. So this is still ongoing discussion. There is no studies to say how long or what to do. This is one of the tactics. This is one of the tactics people do. They can reduce the dose or stay on the same dose. There's no evidence of what to do, so there's different tactics people are trying to do.
So on the right for the felicitation or chairperson and the panelists. So with that we come to the end of this pre-lunch session, and there are a couple of announcements. Number one, that your badge that contains a QR code that is there. So all your photographs, they are available. After some period of time they are clicked, so you can download them yourselves and they are available for your memories. Number two, that we are breaking for the lunch, and because the session is delayed, so the lunch break will be only for 15 minutes. We'll start the session at 2:30. The lunch will be on. All those who want to continue, they can continue there and they can join the session the moment they are done with the lunch. So these are the two important things, announcements. So we break for 15 minutes and we'll once again start at 2:30. Now coming to the place of lunch, the delegate lunch is in the Oak, and that is through the reception area. And for the faculty, it is right about this hall that is Clo, but that Clo is divided into two parts. The section which is closer to the restaurant is for the faculty lunch. So these are the two places the faculty can have lunch in Clo, and the Oak, that is for the delegates, and there is a comfortable seating there. All of you can enjoy lunch and join back once again at 2:30 sharp. We'll start and cover up with the lost time. Thank you so much.
लाइव बंद कर देगा सेव तो अपने आप ही हो जाएगी ना, तो बंद कर क्या शेयरिंग अभी कैमरा से इनपुट आता रहेगा ना मेरे टाइम लाइव चलने दे रहा हूँ लैपटॉप में पड़ेगा पकड़े माइक ये वाला कैमरा डालो क्या नंबर नंबर है इसका सेव नहीं है तो व्हाट्सएप पर नहीं हमको सर व्हाट्सअप आया था हमको एक नंबर से खोजना था और ये नंबर है उसका सुजीत सुजीत तो फॉलो किसको लगा और कोई पसंद किया आपके बैग तुमको बता दो कहाँ जा रहे हैं गाड़ी में सारी बात चलिए ही छोड़ दो
नहीं हाँ बिल्कुल कड़ा नितिन भैया नितिन बाबू नितिन नितिन निखिल
अंदर से वो हार्मोन्स निकलने चाहिए
एकदम आप देख इस बात में गारंटी कर दो काट देंगे अरे सुनील 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 भाभी
ज़्यादा चिल हो गया नहीं आपको लग रहा है इसका मुझे
बढ़िया भी है जो बार बार फोन करके चिल्लाते हैं ये चीज़ें इसी से करिए और हाँ इसके दर्द है नहीं सुन लो हेलो लाइए भैया मेरा लाइए हमारा लगेगा ऊपर तेल ऑफ अल्ट्रा लाइट ठीक करो ऑफ नहीं जगह सही है हमेशा ठीक है अच्छे हाँ हेलो सर लो ना बिरयानी बाहर आ रही है पैसे निकालो भैया ने गूगल पे किया गूगल पे किया गूगल पे किया बिरयानी आ गया हाँ जा जो बाहर जाके फोन कर रहा है
घेरे हुए हैं सीट घेरे हुए
मैंने कॉन्ट्रैक्चुअल में ज्वाइन किया कॉन्ट्रैक्चुअल ये है कि कॉन्ट्रैक्चुअल में मतलब कि रिक्रूटमेंट निकलता है उसमें ये अच्छा है कि 1 महीने पहले बता के
डॉक्टर मुकेश भैया आए
इंडोर में चाहिए तो पुराना जिला हमारी बिल्डिंग के लिए अटैच कर सकते हैं बेड प्रायर प्राइमरी उसका हैंड ओवर देना कोई 25-30 बेड बढ़िया की इमरजेंसी में रहती है वार्ड में 30 है इमरजेंसी में जब 30 है बेड तुम्हारा तब भी 30 पैसे से मरीज कर रहे हैं नया वाला जो हैंड सेट है नई बिल्डिंग बन के शुरू कर हैंड ओवर
Good afternoon, everyone. Welcome back post-lunch session. So, we are a bit 10 minutes late, but we'll try to cover. For the next session, which is Painful Legs in Diabetes by Dr. KVS Harikumar, I would like to invite chairpersons Dr. Alok Agarwal, Dr. Nishant Kanodia, Dr. Komal Gupta, Dr. Vaibhav Shukla and Dr. K.K. Savlani as panelists. Dr. Alok, you may please introduce the speaker, Dr. K.K. Savlani.
He is recipient of Shakuntala Amir Chand and M.N. Sen Oration Awards from ICMR, New Delhi, Dr. J.S. Bajaj Oration Award from National Academy of Medical Sciences, New Delhi, Dr. A.R. Seth Gold Medal from Endocrine Society of India, Thyroid Rising Star Oration from Indian Thyroid Society, Young Investigator Awards from RSSDI, API and UPDA, Best Referee and Best Article Awards from Indian Journal of Endocrinology and Metabolism, and he has got 240 publications in peer-reviewed PubMed index journals. Now I invite him for his introduction.
Thank you, sir. Good afternoon, everybody, and thanks to the LDSS team for inviting me. Everybody.
Now, painful legs in diabetes is actually one of the most painful problem which most of us have encountered. Before I start my talk, may I just ask how many have treated painful legs in diabetes? Very good. How many have treated up to the satisfaction of the patient? So the problem lies actually there, that we see every second patient with diabetes who walks in has some pain in the legs. But we are actually not giving justice. I will tell you some of the reasons where we can do some change, but unfortunately we still can't do much in this aspect. So when somebody comes with pain, you are actually lost, because it can be due to multiple reasons. I mean, leg has a whole lot of structures. So it is not that easy to identify where is the problem, and after identification, some of them have measures to correct, some don't have. So that is also important to understand. So I will cover the topic under the following headings. Painful legs due to problems of arteries, muscles and veins. I will spend more time on the PDPN, which is the most common problem, the painful diabetic peripheral neuropathy, and some of the interesting cases or clinical dilemmas or what we have seen and published, I will show you. History is the key to diagnose at least grossly where is the problem. Claudication pain, pain due to a particular posture, pain which wakes up a patient from the pain, sharp lancinating pain. All these things will give you some underlying clues that you are either dealing with arterial or venous or possibly a neuropathic pain. So important to understand that if person comes with pain, just don't blindly think that it is just a peripheral neuropathy. Most of the times it is actually not. And second important thing, diabetic peripheral neuropathy is a diagnosis of exclusion. You need to exclude a whole lot of features or diseases before you actually come to a diabetic neuropathy. Okay, these are some of the features which you should be asking in the clinic to find out what is the problem. If it is a arterial, ABPI is fairly widely available, easily doable, and it will give you at least to give you some clue as to where is the problem, and depending on the ratio, you can actually subject them for revascularization strategies depending on where the artery is blocked. Okay, ABPI, please use it more often in your practice. Second important thing is the muscle disease, which again due to statins what the patient will be using, vitamin D deficiency which the patient is having, some diabetic myonecrosis and pyomyositis, mostly related or relevant in the tropical areas, but they are still quite common, but they would come out with more acute presentation, more visible presentation. So you may not miss them easily. So these are some of the things. Muscle infarction is another thing which comes with the diabetes. You have again, it's a busy slide, but as I said, the DDs of muscle infarction are important to know. Some of them, either it can be a muscle rupture, hemorrhage, or a abscess or osteomyelitis.
Another group of conditions is your venous disease. Again, DVT, before it actually comes up as a big swelling or maybe a redness or maybe a venous claudication, may have is just superficial thrombophlebitis, may have just been a varicose veins. So important to understand, please palpate, inspect the entire legs, at least make the patient lift their garments up to mid-thigh or at least knee region and see what is there happening to the legs. You will be able to identify some of these reasons easily. Okay, Doppler and other treatments are depending on whatever is the underlying disease. Somebody gets a regular claudication pain. You have done all possible tests, you have done all possible imaging. Still the patient has got no disease but no identifiable disease. Any clue? Any condition? Intermittent claudication pain, vessels, spine, everything normal. There is something known as chronic exertional compartment syndrome of the leg. Okay. You walk more, your muscles swollen, and it causes pain. Blood vessel normal, now normal, spine normal. Okay. So in resistant or recurrent cases, you may have to actually do a fasciotomy. You have to do a muscle monitoring image. So whenever somebody complies such things, think of some conditions which exist beyond what are known to us. Okay. We come to diabetic peripheral neuropathy, the commonest problem, the mother of all problems. Disabling, distressing both to the patient as well as to the doctor. That's why it is often associated with depression, and you have very minimal therapeutic options. Evaluation, basically you need to do the large fiber evaluation, small fiber evaluation, all those things are important. Types of pain what the patient can have is your spontaneous or evoked, either it is superficial burning or a shock-like sensation. Evoked is either allodynia, which is an altered sensation, or hyperalgesia, more sensation to the same stimulus what you are getting. On to your left, what you see is the typical diabetic peripheral sensory neuropathy, motor sensory neuropathy. But you may have radiculopathies, you may have plexopathies, you may have tarsal tunnel, carpal tunnel, other syndromes as well. Mononeuritis multiplex. So depending on the involvement, you can have different types of presentations of the underlying disease. So if you look at comparison of whatever are the neuropathies in diabetes and commonest being the motor sensory or the peripheral neuropathy, how many will have the pain, what is more severe, sensory clinical features, or whether the reflexes are preserved or not, or any other associated symptoms. Some of these things are the ones which come into your clinical practice. Insulin neuritis is one aspect. When you start in a new, insulin in a new patient, one CADP is something which you need to be worried, which you need to consider. Entrapment neuropathies also are very common in diabetics, especially in obese diabetic, obese hypothyroid diabetics. These are important to identify because these are some of the things which are correctable. If it is a CADP, you give steroid, they will be pain-free. If it is entrapment neuropathy, you do a corrective surgery, they will be pain-free. If you label them as diabetic neuropathy, obviously you will not be giving anything, or even if you give, nothing is going to change. So that is where it matters. So this is the algorithm of the neuropathic pain. Is it focal neuropathies or is it diffuse neuropathies? What do you look at? Focal, be it entrapment, you need to look at accordingly. Mononeuropathies, sometimes either cranial or peripheral nerves are also there. And in the diffuse neuropathies, symmetric, polyneuropathies, or if it is proximal, you may use IVIG or steroids. And the common drugs, I will come to that now. Now the drugs used for diabetes peripheral neuropathy, these are the groups of drugs what are available. Tricyclics, SSRIs, SNRIs, anticonvulsants, opioids, and topical application. Okay. So if you look at the number needed to treat and number needed to harm in the drugs what we are going to use, the best possible result would come with tricyclic antidepressants. But unfortunately, that is the least commonly used. Maybe because of tolerance, maybe because of side effects, all other reasons. Duloxetine, carbamazepine, and opioids are not much recommended, but still they are there, which will give you some pain relief. Okay. So if you look at how do we treat diabetic peripheral neuropathy, the first line options are tricyclic antidepressants, SNRIs, and anti-epileptic drugs. Start with one. If no improvement, use two of the same first line. No improvement, you go to third. All three combined. No effect, then you go to second line. So this is the commonest approach when you are treating the painful peripheral neuropathy. Tricyclic antidepressant, SNRI group, what we commonly use, and anti-epileptic group. So these are the first line options what are available. You can start with one of the first line, whatever you feel like, because number of studies have said that all of them have equal efficacy as far as treating the pain is concerned. Second line, you can go to tramadol, or Botox, topical depending on the again the pain, and some of the recent advances I will come to it now. Okay. Second important thing is what is the patient has come with. If somebody has come with numbness, actually most of them have got not much role to play. Okay. Somebody comes with a pain, it makes a lot of difference. Both fall under the issue of neuropathy only. So is it a small fiber neuropathy or is it a large fiber neuropathy? Will determine what is the ideal drug which you need to choose. The bottom line, if you look at lifestyle modification, glycemic control will hold good for irrespective of is it a painful or a painless neuropathy. But they stand more logic if it is a painless neuropathy, because if it is painless, you have only the SNRS which give you a small benefit. Otherwise, others are of not much role to play. Okay. So important that what patient has come with. Some of the other newer drugs or whatever are the options available or different things. That is something similar to the insulin neuritis you have known as TIND, that is a treatment-induced neuropathy of diabetes. Similar spectrum of insulin neuritis. The Monri are the ones which combine the norepinephrine reuptake inhibition along with opioids. Okay, so it is possibly has given the best result, but by virtue of being a more prone for addictions, ADA 2025 also has not given it as an option to choose. But studies have shown that it is good. Palmitoyl, ethanolamide, again, plus minus benefit in a small number of studies. ALA, the alpha lipoic acid is something which everybody talks about, but the only dose which has shown to be pain beneficial is 600 milligrams per day. Most of your drugs, what you are having in the practice, have 150, 200 or at the max 300 milligrams of ALA. It has not been studied, it has not been proven to be beneficial. So important to understand that if you have to use ALA, you have to give 600 milligrams. Only 2 companies make 600 milligram tablets. When for Diamond, you can give 300 to 600 milligrams per day. This is the summary slide of actually the entire how do you approach the patient of diabetic peripheral neuropathy. Glycemic control, lifestyle modification is the same irrespective of anything. The mechanism-based treatments, whatever is the underlying problem, be it your neuroprotection, be it your antioxidants, aldose reductase inhibitors, microcirculation enhancers. The standard first line and second line, what I talked about, your anti-epileptics or SNRIs, and then some of these resistant cases where you have to use spinal cord stimulation or acupuncture or some other measures to relieve the pain of the patient. So this is the nutshell spectrum of what your diabetic peripheral neuropathy is. Most of us have listened to this complaint. Patient says, when is your pain more? He says, actually, when I go in the night. We say night he has no time. He has all the problems he can think about. That is why he is getting pain. He is not having pain in the morning. Agreed, disagreed? Sometimes agreed. So there is something known as NENS, nocturnal exacerbation of neuropathic pain. It is important because when you lie on your bed in a supine position, actually the spinal stenosis is the one which compresses more. If you have to just differentiate a neuropathy versus a spinal stenosis, ask the patient to just sleep on a lateral position. If the pain is relieved, it is actually due to a spinal stenosis, it is not due to the neuropathy, whatever we have been thinking. Ask him to place a pillow beneath his thighs, just elevate that, so that the spine is not extended. So some of these measures actually will help you identify the underlying problem and reach to a diagnosis more easily, more clinically relevant, because it is more common in all neuropathies, but more common in spinal stenosis. Some DPN mimickers, Charcot's foot is obviously there, which always will be there. Morton's metatarsalgia is a specific pain because of the nodule at the neuroma. Plantar fasciitis, most of the patients do complain of, again it is localized pain. Tunnel syndromes, again specific areas, not widely prevalent, but they do have almost same presentation as diabetic peripheral neuropathy. Other etiologies, restless leg syndrome is something which again patients will complain in the night time. Here you may have to use dopamine agonist, the pramipexole. Amyotrophy is another disabling pain, which patient has intense pain, especially the proximal part of the thigh. It's amyotrophy or the proximal femoral neuropathy or lumbar plexopathy. The etiology is not very clear. One of our paper where we used Botox in the anterior portion of the thigh to relieve the patients from the painful state. After crossing all the anti-epileptics, all the SNRIs, nothing works, so Botox we use that. Three relevant issues in the practice, if you look at, are there any anti-diabetic agents which are more relevant to be used if somebody has pain? Okay. SGLT2 inhibitors, that amputation risk is by and large dead, so it is not a risk. But SGLT have not been shown to be beneficial. DPP4 and GLP-1RA have shown to be beneficial in meta-analysis as far as anybody who is having diabetic foot by virtue of their more of anti-inflammatory action. So in a given option, you may consider that. Second and most important thing in practice, most of us prescribe metformin. Metformin, the guidelines are very clear. If you are using long-standing metformin or at higher dosages, you may check B12 or may not check, but please replace B12. Okay, because one of the commonest causes of neuropathy is the B12 deficiency, more in people who consume alcohol and more in people who consume long-standing metformin in a higher dosages. You have something known as a electrical myostimulation, which will actually help the regeneration of the nerves in the periphery. Some studies are coming up, some recent advances are coming up. These devices will stimulate the nerve junctions in the muscles so that the pain sensation is going down. The meta-analysis, some of these are coming into practice. It will take some time, but will happen in maybe couple of years more. Last three interesting cases, I have 2 minutes to go. Okay. Diabetic foot presented to us, ray amputation done. You can see. What have I shown in the arrows? Anybody? Can you see? What is that? Absolutely correct. Arteriosclerosis, extensive vascular calcification. Because that is why some of these things, whenever you are interpreting your Dopplers, that's why actually the toe pressures are a bit more sensitive nowadays. When you do ABA, you need to be careful in diabetes because they have arteriosclerosis, so Doppler may not give you a correct picture. Possibilities? We don't see more often these patients nowadays. No. DVT, you don't get such sort of swellings. There are only two conditions actually. Whether it has to be a Madura foot, you don't see nowadays, or it can be a psoriasis. Okay, both of them have become by and large thankfully extinct. Okay, my last case, last but one slide. Diagnosis. Yes, ma'am? Oh, yes, we are in diabetes lecture. It is correct. As a possibility, I agree. What is happening here? What is happening here? You can see the toe going. The toe just gets shriveled, narrowed and falls off. Correct, correct. Auto amputation of course. Auto amputation is seen in diabetes, leprosy, syphilis. Okay. Technically known as ANHM. If there is an underlying disease, it is known as pseudo-ANHM. So it is an auto amputation of course. You need to identify. You don't have to do anything. That is most important here. So to conclude, painful legs is a common clinical problem. Numerous etiologies exist. Detailed history and judicious examination is important. Neuropathy and neuropathy will be the issues, and always look for treatable cause, because as I said, neuropathy can come with mononeuritis, along with neuropathy can coexist with the entrapment neuropathy. If you are able to identify a treatable cause, possibly you do relieve some pain of the patient, may not be the all pain, and suspect atypical disorders. And whenever you are prescribing the dosages, I have shown the slide and whatever are the appropriate dosages what you should give. Don't give a small dose and then say that patient is not improving. At least when we are treating, we should treat wholeheartedly to the best of our capabilities. And most important actually, if somebody is complaining of pain, be happy that that sensory system is intact, because pain is the greatest gift to mankind. And if you can see one of those negative ad campaigns, because just because there is a disease there, I am able to identify it and I am able to treat it. If somebody doesn't want to complain or has no complaint, we are unfortunately not going to treat. I have finished here. Thanks for your patient hearing.
Thank you, sir. Thank you very much. Sir, is there any role of magnesium? Because with peripheral neuropathy, sore legs and eye cramps are also there. So, with diabetes and without diabetes, both versions.
See, adequate normal magnesium alone is not going to be of any use. The only things what have been shown to be standalone beneficial as far as the nutrient wise concerned is vitamin D, not the magnesium alone. But if you feel that magnesium deficiency exists, mostly in somebody on a TPN setting or otherwise only you get a magnesium deficiency. A conventional patient who is eating normal diet and other things, they would get an adequate dose of magnesium in their day-to-day replacement. But if it's not happening, you replace and see whether that is going to make any difference or not. Second important, most of these, I would say the nutraceutical products have got no valid basis as far as the recommendations are concerned. That is why none of them have been recommended till date as a therapeutic measure. None of them.
And so not even as an applicator, magnesium application over
local application.
Thank you.
So may I request questions to be taken on one-to-one basis after the session? We are already doing that. Thank you, sir. Sir, one-to-one sir के साथ ले लेंगे.
I have shown that veno-occlusive disease and diabetes, it does make a role.
Provided you have a veno-occlusive disease documented. It is there. The Daflon, the MPFF can be given. Flavonoid fractions have got a role.
Thank you very much. May I request speakers,
Thank you.
chairpersons and panelists to kindly come on the felicitation area. Mukles Gupta boss, please do help them. So with this, we move to the second lecture of the post-lunch session, and I would like to request Dr. M.K. Yadav, Dr. Jeevan Prakash and Dr. R.R. Mishra to come on the dais to chair this session. Dr. M.K. Yadav, Dr. Jeevan Prakash, Dr. R.R. Mishra. And then as a panelist, I would like to invite Dr. Ashish Srivastava and Dr. Vipin Gupta. The speaker is Dr. Narendra Kotwal, and he is going to talk on management of type 2 diabetes in the elderly. What should GPs know? So over to chairpersons to invite respected speaker.
Well, without encroaching on the time of the speaker, I will straight off call Dr. Narendra Kotwal for his lecture. Dr. Narendra, the topic is management of type 2 diabetes in the elderly and what should the GP should know. Dr. Narendra Kotwal is MD, DNB, MNA, MS, MPhil, DM, FACE, FRCP, Edinburgh, Director Endocrinology, Paras Hospital, Panchkula, Past Director and Commandment, AFMC Pune, National Coordinator,
Thank you, sir. I would like to express gratitude to LDS team. I tweak the topic a little bit. Diabetes in elderly, what GP should know, already all of you know, but I make it a case-based scenario. So age is not a number, glucose is yes. Management of diabetes in elderly population. How are you is more important than how old are you, right? Elderly constitute 8.8% of the general population. Global perspective, elderly will constitute about 1/3 of the total population by 2050. In India, prevalence of diabetes is 11% in people between 65 to 69 years. So why diabetes in elderly is important? There is a lot of heterogeneity in clinical features, in cognition, and in functional status. There are various categories of older people. One is functionally independent, then category 2 is, again in subcategory A is frail, and subcategory B is having dementia. Very important to evaluate all elderly for cognitive dysfunctions. Category 3 is end of life care. So as I told you earlier, 11% of the people in India in the age group of 65 to 69 have diabetes. Mind you, 12% of the patient above 65, they may be having type 1 diabetes. Autoimmune markers may be positive. WHO also projects that by 2030, more than half of the diabetes sufferers in the world will live in Asia. More than half of people with diabetes, that is 53%, are above 60 years and more than 85% above 45. So in elderly, concomitant geriatric syndromes are there. One should evaluate for that. Varying expectations of self-management with aging and increasing frailty, social isolation, and clinical and functional heterogeneity, as I alluded to earlier. Pharmacokinetics and pharmacodynamic dynamics in elderly are different. Changes are age-related changes in gastric and intestinal physiology, intestinal motility, colonic motility, and pharmacodynamics depends upon the concentration of drug at receptor level, then post-receptor responses. Enhanced sensitivity to drugs occurs with aging, and due to less effects of the blood-brain barrier, they may be exposed to high drug levels. Use of polypharmacy, more than 5 drugs, is known as a geriatric, is a component of geriatric syndrome. And in older patients, if you see autonomic response and neuroglycopenic response are also low. That perception is low. So we ought to have a high degree of suspicion to detect hypoglycemia. As for ADA, diabetic care revolves around 4 M's. One is mentation, medication, mobility, and water matters most. So I will now go through the case-based scenario. The 67-year-old man, deeply diagnosed type 2 diabetes, fasting is 138, BP is 160, HbA1c is 7.2, creatinine is 1.9, weight is 65. No other illness. Works as a CEO of a major multinational company, no other medications. So whenever we are treating our diabetic patients, as has been discussed in this morning, it's a holistic treatment, we have to look at the duration of the diabetes, risk of hypoglycemia, comorbidities, patient factors, and others. Just to give an overview about the pancreatic cancer and diabetes, about 1 in 100 people with new onset of diabetes are diagnosed to have pancreatic cancer within 3 years of diagnosis of diabetes. 1 in 4 people diagnosed with pancreatic cancer were first diagnosed with diabetes. In elderly, if you see, as compared to the non-diabetics, all complications are more, be it congestive heart failure, angina, heart attack, or any other strokes. There is a U-shaped curve with the glycemic control. Below HbA1c 6, below HbA1c 6.5 and above 7.5, there is an increased mortality. So we have to keep HbA1c in those ranges. And comorbid conditions are so high: depression, polypharmacy, cognitive decline, cardiovascular disorders, urinary incontinence, disabilities. You should assess the general health assessment, looking at the various parameters as shown, general health tests, and diabetes-specific complications, all microvascular complications and macrovascular complications. Very important to look for the frailty and assess the frailty indices. Individualization of therapy. This is, I think, the most important slide. I spent some time over here. Look at the health status. Few are coexisting chronic illness, intact cognition and functional status. That means patient has a longer life expectancy. Try to keep HbA1c below 7.5, fasting 90 to 130, and blood glucose at bedtime around 90 to 150, BP less than 140 by 90, statin unless contraindicated must be given. Then complex intermediate having more than 2 illnesses, that means they have a lifespan intermediate. Try to keep HbA1c below 8, fasting or pre-prandial 90 to 150, bedtime glucose 100 to 180, and BP 140 by 90. Very complex, multiple problems. Try to keep HbA1c around 8.5. Below that, look at the fasting or pre-prandial values 100 to 180. You know, sometimes our patients are 100 and 180. They say, "Hame theek nahi lag raha." We have to keep a blood glucose at a high level. And at bedtime around 110 to 200 and BP around 150 to 90. So very important to keep pre-prandial values or at glucose values depending upon the functional status of individuals. And same as per the frailty, one has to keep HbA1c healthy 7.5, mild frailty around less than 8, and lot of frailty around 8.5. Now coming to our patients. Now, in this patient, he is relatively well kept. We would like to keep HbA1c around 7.5. Now, question is, should he be treated like a young diabetic? Great. Why? Because we see postprandial expressions are high, and even there may be a dip below the particular level. Again, low dose of medication that have a high affinity of muscle. Because as we know, after 50 years, all of us lose muscle. Greater risk of toxicity with the drugs that accumulate in fat, because as we age, fat increases, muscle decreases. Then increased concentration of water-soluble drugs. Then there is a decreased GI mortality. Then as far as the drugs are concerned, metformin is a good bet to use, but once GFR is less than 45, half the dose of the drugs, and if eGFR is less than 30, please stop it. As I reported earlier by the Hari also, if prolonged use of metformin causes butyrate deficiency, look at those features. Then as far as sulfonylurea is concerned, one should be very cautious in the use of elderly because they cause hypoglycemia, especially glibenclamide, and one should not use if it is eGFR less than 60. Glimepiride and gliclazide and glipizide can be used, but again in low dosages. As far as SGLT2 inhibitors are concerned, they do not cause hypoglycemia. Any of the epagliflozin, DEPA can be used. But point to remember is the volume depletion. Now in elderly, they are prone to volume depletion, so one should be careful, especially in summer weathers. As far as DPP-4 inhibitors are concerned, relatively safe to use in elderly person. But look at the eGFR to give the particular dose of the drug. As far as the insulin is concerned, we have to give insulin. If somebody is on the long-acting insulin to control the fasting, please shift it in the morning. If somebody is on the prandial insulin, if dose requirement is more than 10, half the dose of the insulin and add non-insulin drug. If dose is less than 10, one may stop it. As far as glitazone is concerned, they do not cause hypoglycemia, but they increase fracture risk, can cause fluid retention, can cause weight gain. So one should be cautious in the use of glitazone, but it can be used. GLP-1 receptor agonists do not cause hypoglycemia, may cause GIT side effects. Now, exenatide is no longer used, but others like liraglutide, dulaglutide, semaglutide, and tirzepatide can be used. But again, in the elderly, not elderly, older people, more than 80 years, they use very few studies are there where these drugs have been used, but otherwise these are good drugs for the CV and renal protection. Now coming to our patients, here we can use metformin, glitazone can be used, DPP-4 can be used, SGLT can be used, GLP receptor agonist can be used in this patient. Now another patient, 70-year-old man, diabetes 6 years on metformin 1 gram daily and glimepiride, history of PTCA. That means he has cardiovascular disease, BMI 23, ACE inhibitors, echo shows lower ejection fraction, right? Then to all those parameters, duration, risk of hypoglycemia, comorbidities, patient factors, and others. So in our patients, he has a CAD requiring PTCL and he has a decreased ejection fraction. Amongst the drugs, DPP-4 inhibitors can be used, but patient if has a heart failure, saxagliptin should not be used, others have a neutral effect. Glitazones, one should be very cautious with the use of the glitazones if there is a heart failure. Bionides can be used. Then SGLT2 inhibitors of the drugs in a heart failure should be used, and insulin, if sugar is very high, can be used, but watch for the hypoglycemia. As far as GLP agonists are concerned,
These are safe to use in these patients, and there are various studies to show use of GLP agonists. So in this patient, he has a heart failure, and GLT2 would be the drug of first choice, metformin can be used, and GLP receptor agonist can be used. So algorithm for the use of anti-diabetic drugs in elderly, look for the frailty and reassess the frailty after 3 months. If HbA1c is more than 7.5, one can use metformin or DPP-4 inhibitors. If heart failure is detected, BNP levels are high, use SGLT2 inhibitors. If pre-existing high risk MI, cardiovascular risk is there, use GLP. If there is no atherosclerotic cardiovascular disease and after screening for heart failure, one can use DPP-4 inhibitors or even SGLT2. If HbA1c is less than 7, heart failure is detected, discontinue glitazones and saxagliptin and initiate with SGLT2 inhibitors, reduce renal function, eGFR less than 30 ml, discontinue metformin, and if somebody is on insulin, reduce insulin doses of 20%. 74-year-old man, type 2 diabetes, duration 10 years, on metformin, fasting and PP as shown, creatinine is on a higher side, hypertension 20 years, consumes alcohol every day, lives at home. So alcohol use, creatinine is high. So what is the risk? What is the risk in this patient? Hypo, great. So risk factors are hyperglycemia in elderly are alcohol intake, autonomic neuropathy, cognitive impairment, complex regimens, hepatic dysfunction, polypharmacy, recent hospitalization, renal insufficiency, steroid drugs, therapy with sulfonylurea insulin. So many factors are there where patients go into hypoglycemia. And in elderly, hypoglycemia is more dangerous rather than keeping a sugar on higher side. So more difficult to recognize the interplay of various factors, which all of you know, I will not dwell upon. So in this patient, there is a risk of hypoglycemia, and patient factors there is using ethanol, which increases the risk of hypoglycemia. And the serum creatinine is high, creatinine clearance is low. So the drugs which can be used in this patient are DPP-4 inhibitors, SGLT2 inhibitors, and GLP receptor agonists. So another patient, 77-year-old, woman lives alone, she has a history of hip fracture. It's very common in elderly. She is a diabetic on Levipri, metformin, HbA1c is, serum creatinine is 0.8, functional level with assistance of depression. So in elderly, as I told you, please look for the comorbid condition, look at the polypharmacy, depression, cognition, and one must get their cognition test done. So these are the various cognition, look at the memory, learning, mental flexibility, executive function, try to differentiate between dementia and delirium, and there are various tools by which one can assess the cognition. Now, point I would like to make is what are the risks for the fractures? HbA1c less than 6.5, heart conditions, bone muscle skin conditions, neurological disorders, endocrine disorders, diazepines, opiates. As far as the drugs is concerned, glitazones increases the risk, and GLP inhibitors marginally. GLP are generally bone friendly, and DPP inhibitors are bone friendly. So in this patient, duration is long, the risk of hypoglycemia is there, and propensity to fall is there. So drugs here, DPP-4 inhibitor would be safe to use in this patient. Another patient who has a 79 is on drugs and pioglitazone. So as I told you, glitazone increases the fracture risk, one should stop. So in this patient, DPP-4 inhibitors and GLP receptor agonists can gain. In an elderly person, severely frail, HbA1c more than 8.5, heart failure suspected, BNP is high,
commence or continue SGLT2 inhibitors, add DPT before inhibitors if no heart failure. When patient becomes severely ill at any HbA1c, consider stopping metformin and GLP receptor agonists, substitute by DPT4 inhibitors, discontinue glitazones, substitute with DPT4 inhibitors, and discontinue sulfonylureas. If HbA1c less than 7.5, consider discontinuation of SGLT2 inhibitors, and if somebody is on insulin, then better to switch to premix insulin, which may cause lesser hypoglycemia as compared to the NPH and regular insulin. So just one of my last slide to show common scenarios in elderly patients. 75-year-old man, HbA1c 7.2, treated with metformin 1500 mg per day, hypertension, none of the diabetic complications. Here we would like to keep HbA1c less than 7. Consider to start metformin or add gliptins if required. 78 years old woman, HbA1c 7.6, treated with metformin 2 grams, heart failure, class 3, osteoporosis, CKD, peripheral neuropathy. Here we would like to give HbA1c around less than 7.5. Stop metformin, consider SGLT2 inhibitors, and in second instance, GLP receptor agonist or maybe renal-friendly DPP4 inhibitor or modified doses as per EGFR GLP receptor agonist, which I think one of the talk was discussed also. 80-year-old woman, HbA1c 8.7, treated with a combo of metformin and sulfonylurea, and metastatic breast cancer, CKD, coronary heart disease, recurrent symptomatic hypoglycemia, Resting syndrome, having autonomic neuropathy. Here we like to keep HbA1c less than 8.5, suspend metformin and sulfonylurea. So to summarize, in an elderly, there is a lot of heterogeneity. One must look for the genetic syndrome and try to keep HbA1c as per the age, as per the frailty, as per the comorbid conditions. Thank you, ladies and gentlemen.
Thank you, Dr. Kotwal, for a very nice elaboration, wholesome elaboration of yours. You have said that we should have the goal of...
So please, mic is working, please keep it close to your mouth.
A diabetic, an elderly diabetic who is having a lot of complications, comorbidities, and having a lot of comorbidities, and as well as repeated attacks of hypoglycemia, etc. You have indicated that HbA1c should be on the higher side, but already it is on the higher side, and the patient has developed complications because of the high HbA1c. So should we not have a very good control even if we have it on the higher side?
Complication, you mean to say what type of complications, sir? See, we don't want patient to go into hypoglycemia, so HbA1c on the higher side. If we have cardiovascular complications, we can give the drugs to take care of those risk factors. But as far as HbA1c is concerned, with so many conditions, CKD, cardiovascular disease, frailty, HbA1c should be around 8.5% in this patient. Fasting around, as I told you, somewhere 100 to 180. And
my question was that something on the higher side, will it not produce earlier complications?
Let me once again read what he's trying to say. It's a catch-22 kind of situation. That the patient is already having complications of higher HbA1c, and we are asking that.
Okay, I got it. See, an elderly person, suppose somebody is 75 and 80 years, controlling those particular complications, we have to look at the life expectancy of the individual. We are not looking at that after 10 years what will happen. At that particular moment, we don't have to go for the speed control. Already complications have happened, that is fine, but control the other risk factors. But as far as HbA1c is concerned, don't chase the HbA1c. There are tools to determine life expectancy. You should go calculate life expectancy. There are well-validated tools to determine life expectancy.
So I think
in an elderly, hyperglycemia will not kill the patient, but hypoglycemia will push the patient to mortality and morbidity. That should be the bottom line, that should be the carry-home message.
So one thing more, since majority of the elderlies, they are living in a nuclear family, wife or husband and helper, one of them must be told about all these things, which I do. क्योंकि वाइफ को अगर आपने बता दिया हस्बैंड हाइपोग्लाइसेमिक है तो वही प्रॉब्लम होती है. हेल्पर आजकल अमूमन एक होता है और वाइफ या हस्बैंड है. They must be told about all these complications, especially hypoglycemia.
I fully agree with you. Diabetes is a social disease. I mean, everybody should be involved in a diabetic care. Family, friends, everybody should be involved.
So I think we can close this session. The fact remains that all the RCTs, whatsoever we study, they don't have patients included which are beyond 85 years of age. So the data beyond 85 years age is really scarce in the scientific foray. But yes, these are the pertinent things which you have already explained. With this, I think we come to the end of this session and we close the session. Thank you so much, and the panelists and the speakers on the right side for felicitation.
Moving on to the next session, may I now request the chairpersons to take their place on the dais. Dr. Rakesh Srivastava, Dr. Rajesh Gupta, Dr. A.K. Srivastava, and panelist Dr. M.M.C., Dr. Sharad Kumar. The topic is continuous glucose monitoring, choosing the right patient, interpreting the data, and speaker Dr. Sunil Jain from Indore. I request our chairpersons to introduce Dr. Jain.
Our speaker is Dr. Sunil M. Jain. He is DM endocrinology from PGI Jipmed Chandigarh, consultant endocrinologist at Total Diabetes Hormone Institute Indore. Conducted more than 80 clinical trials, including Leader, Savior, Timmy, Canvas, Empiric, and Soul. Contribute chapters textbooks on diabetes and endocrinology. Key faculty for CAB like PGCDM for diabetes and PGCAD for thyroid attack, MPDA, Sandeepan, and over 6,000 physicians across India have participated in this workshop on diabetes, obesity, and thyroid disorder. Welcome, Dr. Jain. Over to you.
So, thank you, Chairperson, and I'm thankful to LDSS for this invitation. I'll be talking on continuous glucose monitoring. Now, we have seen the era when our patients were bringing the glucose report of fasting and postprandial, and we were treating diabetes on the basis of that. Then the time came for glucose meter testing, and many patients are doing now self-monitoring of glucose. Now we are living in the era where we are moving to continuous glucose monitoring, that is CGMS. How many of you are aware of doing CGMS? Can you raise hands so I am aware that how much is the people involved into continuous glucose monitoring? So right now the number is less in our country. Physicians are not much involved into technologies here. But I tell you, wait for a few years. These technologies are now becoming cost effective. Their usage will go very high. Younger generation, like we were talking about the elderly patient management, younger generation now getting involved into the patient care. And that's how a lot of technological improvements are happening. So I'll just give you a glimpse of CGM. 2002, I used this CGMS. This was a 3-day CGMS, and those days this technology was very expensive. More than 1 lakh rupee equipment, and then by sensors. And then gradually, you remember around 10-12 years ago, this Pro sensor came. And then we got this CGM where patients are applying a sensor and we give them a reader.
They just bring it close to that and see the glucose levels. We reached that here. And now we are having in India this 3-style Libre 2 Plus is now available. So imagine now it is possible to have every 1 minute glucose of our patient for 15 days. That means in 1 day the sensor is measuring 1440 times. Obviously a lot of data and some interpretation is also equally important. Choosing the right patient, I think now this is an alternative to glucometers. It's one of the best methodology nowadays becoming to monitor the glucose all the time. Otherwise, if you want to be little selective, otherwise anybody on type 2 diabetes or type 1 diabetes should go to CGM as a monitoring tool. But if we select a subset, obviously the most important subset will be all patients with type 1 diabetes. If type 1 diabetes, planning pregnancy, conceived. Any type 2 diabetes patient who is on intensive insulin therapy, somebody younger age, 48 years of age, GFR is 42, and this patient needs a very tight glucose control so as to delay the progression of CKD. You need to take the help of technologies if the patient can afford. Many times we keep seeing that the HbA1c and glucose data are not matching. You can utilize continuous glucose monitoring. People with wide glycemic variability, unexpected hypoglycemias, particularly on insulin therapy, how to understand these patients? We can use CGMS. And there are patients who are very well motivated, interested in monitoring, obviously good too. But again, there are some red flags. There are people who don't want to see their glucose reading. वो कहते हैं टेंशन हो जाता है सर हमको अगर शुगर हाई दिखता है. Lot of anxiety. They take wrong decisions by looking just at the glucose numbers and some dermatological conditions. So, first of all, we have to understand few points here. When your patient goes to a lab, they give venous glucose. When they measure the glucose by glucometer, they are measuring the capillary glucose. But when you are measuring glucose by CGMS, you are measuring through subcutaneous tissue fluid, interstitial fluid glucose. And all these fluid compartments have their own physiological variations. And that's how there is a concept of lag time. So, when initially CGM was launched, then lag time created some problem which has been now settled with the changing technology which we call it real-time technology. So lag time means glucose will first flow into the arteries, arteriole, capillary, then interstitial fluid and then now return. So the changes will happen first in the blood and then in the tissues. That means the glucose will reflect little later in the subcutaneous tissue if it is rapidly changing. And that's how many times sensor glucose, that is the reading coming on the CGM display through sensor versus the capillary may not match every time. But finally it catches up. That's the concept of lag time. How it has been taken here, I will discuss with that. But remember, CGM systems are measuring like this. The most common sensor in India which we are using is Abbott sensors. There are multiple CGM systems available. But in India, mainly it is the Abbott sensor which is used for monitoring. So now Bluetooth, and that's how the data are coming in the mobile, and that's how every 1 minute glucose measurement is possible. But one more thing you can see here, you have to focus that apart from the glucose reading, you will see that there is an arrow. Next to the number, you can see this arrow, and this arrow is very important. This is an important part of training to the patient, that don't just look at the glucose number, look at the arrow. Because now the CGM technology is not only giving us information about what is the current glucose, it is also telling us that is the glucose changing, and if yes, in what direction. Is it going up? Okay, the arrow will be up. So it is also showing the information about the direction of the change. In addition, it is also telling us what is the rate of the change. Means this arrow you are seeing obliquely up. That means right now the glucose is 112, but it is rising at a rate around 1 to 2 milligram per minute. On the contrary, if the arrow would have been vertically up, that means the currently glucose is 112, but it is right now rising at a rate more than 2 milligram per minute. If the arrow is vertically down, then the same information interpreted as more than 2 milligram going down. Now think of somebody who has checked his glucose by glucometer and it was 78. Patient is on insulin therapy. What most of your patients will do, looking at 78? Fear of hypoglycemia. They will unnecessarily push calories, eat food, kahin sugar low nahi ho jaye. Because they have checked just one point. On the contrary, CGMS, as I told you, measuring glucose every 1 minute. So the system knows that what was the glucose reading in last 10-15 minutes. Every minute value is known, and that's how the trend is created. So suppose in last 5 minutes the glucose were around 77, 79, 80 only. Then the glucose reading will come 78, arrow horizontal. That means don't eat anything. You need not to worry. You are absolutely safe. That's what CGM is telling us. On the contrary, if the arrow is down, that means more than 2 milligram per minute fall is happening. And you may have hypoglycemia in next few minutes. That's how CGMS technology has made the glucose dynamically available to us. So, take this example. That's like 78 milligram. अब ये player एज पकड़ेगा कि छोड़ेगा? You don't know when the number is 78. Is it stable? Is it rising? Is it going down? You don't know. But since CGMS is giving you continuous glucose, so with the arrow, we can suppose the arrow is up. This is the direction where the glucose is moving. If the arrow is down, it's also a lot of predictability has come into the place with CGM technology. Now, apart from the glucose number, how the glucose is changing, just think of a technology which is measuring every 1 minute glucose. It can provide you so much information about the patient. And that's what is happening now. We are gradually moving out from the era of fasting PP to HbA1c to now continuous glucose monitoring, where we can measure how are the trends, how is the glycemic variability. It's not just the glucose level which is important, how the glucose is going up and down. It also has a lot of impact on the development of diabetes complications. So when a patient has used a CGM for 15 days, one is you are using for once. My many patients wear CGM for 365 days. My many type 1s and many patients for an intensive glucose control, they all the time wear CGM. And that's how we can manage, they can self-manage very well. So when at the end of the 15 days, a report is generated by the system, which will show you that for how much time this patient has recorded the data properly. That's another technical area beyond the scope of this discussion. You will see what is his average glucose. That is another glucose statistics. And now rather than just fasting PP, now we talk time in range, time above range, time below range, because you have so much data. So range defined for how much percentage, how many minutes now you can predict you are higher, how many minutes you are lower, like that. And all this data can be structured in a diagram, in a picture, by which you can very easily understand what is the pattern of this patient, and that's how it can happen. That's called AGP curve. Every patient's 24-hour data are available for us to observe. And those patients who are well motivated, involved into their care, with CGM, they can always enter at what time they are eating food, what is the quantity of the carbohydrate, if they can have some assumed number, or even at least they can announce the meal that I am eating food. They can put the quantity of insulin also, rapid acting, long acting, and all these data becomes the part of it. And that's how, obviously, with the help of so much information, you can guide on a lot of fronts to your patient. All these things. This is a big glimpse of a complete CGM report, which is a 14-15 page report. That's what you will see. This is a 14-day CGM. And this patient cleared it for 99%. This is the glucose statistics I was telling you. The average glucose of all those 20,000 readings, this single number came. This is called glucose management indicator, like HbA1c. That's how some formulas and this calculation is given, so giving you some correlation kind of thing, though it's not an HbA1c. This is a 14 days data. Earlier estimated HbA1c word was used for this, but then it has been changed to glucose management indicator. Then look at the glycemic variability, and for that we have a parameter called coefficient of variation, which is mentioned here as 25.4%. It should be less than 36, and lower is the number, it is better. That's what you can see. This is time in range data. This green line is much percentage of the time. So here you can see 79% of the time this patient was in a defined range, which was 70 to 180. For around 18% time, people on a higher side kind of information. This is the AGP image, which gives you a glimpse right from the distance. You can see that in this patient, most of the time the glucose readings are good, except at these 2 points where something happens because of that, he peaks. Otherwise, remaining area, the variation is very low. That's what is very clearly visible on this graph. These are the daily glucose profile data. And meal and carbohydrate impact and all these information. So now we are gradually entering into the era where rather than talking what should be my fasting, what should be my postprandial, the better terminology will be for 24 hours, for how many hours I should be in the normal range. Obviously for 24 hours, but not possible. Particularly if diabetes duration is longer, beta cells are getting exhausted, and a lot of things are coming into place. So if we can achieve it more than 70%, it is considered reasonably good and acceptable. We don't want much hypoglycemia. So a glucose range of less than 70 can be up to 4%, and less than 54 can be up to 1%. Obviously, nobody would like this. You would always aim for 0% here, but this is very difficult, particularly in type 1 diabetic patients. In type 2, this is reasonably easy to achieve. And this is what will be time percentage, around 25-30%. If they are more than 180 throughout the 24 hours for 14 days, that's fine. That's the time in range concept. And then, as I told you, continuous data are getting collected, and that's how this image is created. So if you look at this image, what is happening here will be the middle line, which is a very dark line. This is the line which is around the mean glucose. And then these are my standard deviation. 25 to 75% of the values means roughly 50% of the numbers will come like this. Then 5th to 95th centile data will be created to make you understand easy if you look at this diagram. Every glucose number is like a dot here. And now so much data. That's how these reporting are important, because otherwise we have unlimited data. We can't understand those data. We can't interpret, so it's made very easy by this AGP. So basically, fundamentally, the narrower is the band, means the glucose fluctuations are less. That's how we will interpret. So multiple readings and all these data are plotted on the graph, and that's what you can see. That makes the work quite easy, and you can see different patients, how their AGPs are, and they are giving us a reasonable clue. Like this patient is very good, very well matched practically throughout the day. Most of the glucose readings are traced to one. So, whenever our patients are using CGMS, we look at TIR, time in range. The bigger is the green number, green bar number percentage, that's good. The lower is that number, we need to put more efforts. And then we will have to go into the further details, where is the problem, and then try to find out the solution. What is the glycemic variability? Look at the glucose statistics, that number, which was percentage coefficient of variability. It gives you an idea about the glycemic variability. Higher is the glycemic variability, those people are very fluctuating. So like you see many patients, students, शाम को night में 40 हो गया, obviously their percentage CV number will go quite high. If we want to understand where is the scope for intervention, to educate the patient, then the daily graph and the meal report will help them a lot. So a lot of kind of information is CGM. This is a topic where a lot of points were there for the discussion, but I will keep it brief that this is a technology which is now going to replace or become a very good alternative rather than replacement, additional tool to monitor patients' glucose and help them, particularly to those patients who are more challenging, to manage them in a better way. Thank you very much.
Sir, continuous glucose monitoring is a very good thing, but there are few sets of patients where Somogy phenomena and some patients depict Down's phenomena. So, if the patient is having dipping of glucose in midnight and increment in the blood sugar level in morning, and patient is on continuous glucose monitoring, what intervention as a clinician we should do in order to keep the patient stable as well as to have glycemic control?
So now we are moving on from, we got the CGMS data, and CGM data in a patient with type 1 diabetes has shown Down phenomenon. Let me talk the first point. Down phenomenon means the glucose was normal till midnight, till 3 a.m., 4 a.m. and without eating food it went up. That's Down phenomenon. That's classical, seen in adolescent type 1s and younger type 1s, which happens because of endocrine circadian rhythms. Obviously, now you have to bring some basal insulin into that slot. Many times not possible, because most of the basal insulin we talk it should be flat, not rising at a particular time, and that's how Down phenomenon is one of an important indication for insulin pump therapy. Because with the continuous subcutaneous insulin infusion through pumps, we can raise the insulin infusion rate in that particular time zone and achieve what we want. And that's how now CGMS, when the two technologies join together, CGMS and pumps, and 780G pump, you might be aware of, our many patients are on 780G pumps, where it will detect this dawn phenomenon and automatically start pushing extra insulin and bring it down. While in Somoge phenomenon, obviously it is a hypoglycemia first, which caused hyperglycemia. So the objective there will be, that will be relatively easier than dawn phenomenon. Because here now you have to bring down the insulin dose in that time zone and reduce the chance of hypoglycemia, or do some dietary modification and adjustment and manage it. But what Dr. Michael Somoge described in 1935, when no technologies were available, now we can very well demonstrate, document it with the help of CGM technology. Otherwise, earlier हम क्या कर रहे थे, रात को 3 बजे ग्लूकोज चेक करो. Now that time is gone. If somebody can afford, just put them on a CGMS and you can see everything what's going on.
So can patient on CGM may advise for MRI? Patient on CGM may go for MRI?
Oh, so caveats when patient is on CGMS. So different CGM companies have different recommendations. For example, Medtronic CGM doesn't permit for MRI or CT. But the Freestyle Libre Abbott CGM from 2-3 onwards, they had got an approval for X-ray, CT and MRI last year in October from US FDA. So Abbott sensors, if patient has put, they can undergo MRI, no need to remove them.
Sir, can we use this CGMS data in pre-diabetic population?
We can use anywhere. See, one of the misuse of CGM, pre-diabetic population will be good for education purpose. But simultaneously, like many times you see a lot of people who are normal, no diabetes, they apply CGMS and try to give a lot of education on the diet. But there the CGMS won't be right tool because they have good endogenous beta cell function present, which will immediately bring down the glucose. So for a normal individual, CGMS role, minimal. For pre-diabetes, yes, from an education purpose for selecting the food choices.
Sir, patient on pacemaker?
No issues, no problem.
Any other question?
I think it was a wonderful talk. Dr. Sunil Jain is an authority on diabetes. He has a very large experience on pumps. I think it's a privilege for physicians of the city to have Dr. Jain here. So if there is any question in your mind, I think it's best to come out with that.
So, may I now request our speaker, chairpersons and panelists to come on the felicitation dais, please. Moving on to the next presentation, that is redefining obesity beyond BMI, implications for management by Dr. Ashu Rastogi from Chandigarh. May I now request our chairpersons to please take their seat on the dais. Dr. Sudeep Sarkar, Dr. Dilip Verma, Dr. A.R. Tripathi, and our panelist, Dr. R.L. Jain, Dr. Vivek Gautam. Request our chairpersons to formally introduce our speaker, Dr. Ashu Rastogi.
Yeah, I would like to invite Dr. Ashu Rastogi for redefining on the obesity beyond BMI implications for management. Thank you so much.
Thank you. So good afternoon, everybody. It's a tea time, I know, and
and thank you Dr. Avasti, Dr. Muklesh and Dr. Chandra and all the LDSS team. Lucknow is always a homecoming for me because I belong to Muradabad, by the way. So I will be telling you something which is whole of the world is talking about, and especially the pharma companies are talking about, that is obesity. Let me tell you how many of us actually write obesity as a disease on OPD cards. So it's very less. So my purpose is to tell you that when you can write actually obesity on OPD cards and tell a patient that this is a disease that you need to treat. I come from northern part of India, PGI, Chandigarh, and Chandigarh otherwise is a beautiful city. So this is my institute from where I enter daily and where I am working as additional professor in Department of Endocrinology. And we have some original work also that I'll show you. So this is the problem with India, an India-specific problem. We are a growing economy. With that, our pocket is increasing, our buying capacity is increasing, and with that, what we are having is a disease that is called obesity. Now, this is the burden of obesity in India. We talk about 140 plus, maybe people, 140 crores population, but same is the number with obesity. Almost more than 10% are having obesity, 135 million. And what is glaring is my city in this whole table. Chandigarh is a city of rich people. It has a good socio-economic status, good per capita income. And that's why I have in my city almost 44% women obese. Almost 34% men in my city are obese, despite a city which has a lot of parks. You'll be surprised that 60% of Chandigarh is a forest area. Forest area means it has a lot of trees and a lot of parks and a lot of jogging grounds to work. But still we have a lot of obesity. And that is all because the average calorie consumption in my city is much higher as compared to maybe Jharkhand or some other tribal area or northeast states. So this is a problem. And another interesting story in this thing is this figure that highest proportion of overweight people are from Andaman. Nobody could imagine, and this is the Government of India data. And this is related to the percentage of people who are obese in Andaman. Almost every second person in Andaman is obese. And this obesity definition that they have taken that I'll discuss in future slides. Now let me dissect further obesity into a generalized obesity that we fondly call. So if you look at this whole of India, the area from where I am coming, Punjab, Chandigarh and all, वहाँ पे घी मक्खन बहुत खाते हैं. And that's why it is red. And same goes with rice eating states like Tamil Nadu, Karnataka and Kerala, which again is red. That suggests a prevalence of generalized obesity. As compared to Uttar Pradesh, a little bit lesser as compared to redder areas. You have maybe a prevalence of generalized obesity around 20 to 24%. I don't know what is the numbers for Lucknow as such. But if you divide this whole of India, generalized obesity into rural and urban India, the urban people are eating more. They are eating more of calorie-dense food that is causing whole of India as red. So in urban India, almost the prevalence of obesity is more than 25%. And you look at rural areas in Madhya Pradesh, Maharashtra and other eastern states, the prevalence is less. So it is just related to the buying capacity that is responsible for obesity. So this is the classical definition of obesity. You might be writing, taking weight of your patient, measuring height of your patient, then kg divided by height square gives you a BMI, and that is how we traditionally define obesity or categorize obesity basically. So what WHO says that for Southeast Asia we have to define a patient as overweight, somebody who is having a BMI between 23 to 24.9. Anybody having a BMI which is equal to or more than 25 will be classified as obesity. And I tell you a recent paper that is Obesity Commission, the Lancet Commission, that has now classified this as a disease. You definitely can write it as a disease. You can treat it as a disease. Maybe some pharmaceutical pressure, but probably I believe this is a right definition that this still is a disease. So somebody is having class 1 obesity between 25 to 29.9, class 2 30 to 34.9. Anybody having a BMI more than 35 is having class 3 obesity. So problem is that we rely very much on simple instruments like taking weight, height and weight by height square to give BMI. But problem is BMI doesn't capture everything. So we have a lot of people who have a very high BMI, maybe around 28, 29. So what he is having a lot of skeletal muscle mass because he is a bodybuilder. He might not have a disease. Same is a problem that BMI doesn't tell you what actually is the fat content in the body, because it is majorly the distribution of fat and the total fat content that defines kind of metabolic disease you have, maybe dyslipidemia, hypertension, diabetes. And I'm sure that we have a like Framingham cohort in Chandigarh also. We are following a cohort of around more than 2,000 patients for past 15 years now. I'll show you the data regarding that. So patient of same BMI, and the best example is a YY paradox that I'll show. So patient with same BMI may have different fat, almost even twice the fat as compared to a patient who is having a same BMI. Moreover, a BMI of X value does not tell you that this patient is going to have a particular disease after some time. It does not tell you that patient will have maybe osteoarthritis, OSA, or this patient is going to develop diabetes. So there has to be some other parameter other than BMI by which we can define obesity. That is more relevant, more pertinent, and more practical. So this is a simple scenario. You have a person who is athlete, whose BMI is 28. Otherwise, you have a female and a male who have again obesity by BMI definition. And all these three individuals are entirely different. One is an athlete, another is obesity who does not have any ongoing illness. And on the same BMI, you have a person who is having an ongoing illness. So therefore, a BMI only approach is a trouble. And that is well documented in this meta-analysis. What they showed that half of the individuals who were defined by BMI as normal, they had very high percentage of body fat. And they were absolutely defined as normal by BMI. So this is a ping-pong-like situation. So you can have any of these things. So always remember, it is the body fat that is responsible for metabolic conditions, rather than a very simplified tool like BMI, which is good for epidemiological studies, at least to identify at-risk population, but it does not tell you whom to treat. And now with current era of so many anti-obesity drugs, we should know that whom actually to define obesity and treat. So this is what we were telling in early lectures, what is normal weight kind of obesity, what is obesity which is metabolically healthy, what is obesity which is metabolically unhealthy. So at the same spectrum of BMI, you can see orange bar, all these persons are having almost the same BMI. But you can have people who have a normal weight, but they would be stunted, so they would have high BMI. You will have person who will be tall, but can be an obese, so the BMI might be quite false. So it's very important to define actually what we can do, and the answer lies in the abdomen. Especially in Southeast Asians, we put a lot of fat in our abdominal area, that is visceral fat. So the concept that is growing now is abdominal obesity rather than generalized obesity. So ICMR thought that we should do a study what actually Indians have. The generalized obesity, we saw the prevalence. In my city, it was 34% in men, 44% in women. So ICMR and INDIAB did a study and they found out that even the abdominal obesity was higher. And it was much higher than the generalized obesity. So overall prevalence of generalized obesity in India in this study was 11.8 to 31%. But once they were measuring the waist circumference by which they defined abdominal obesity, the prevalence of obesity was increased. That suggests if you are just using BMI as a tool, you are likely to miss people who have actually obesity and they might require your intervention. So this is the data of abdominal obesity. So now if you compare with the prior data that was with generalized obesity, you can assume that in this again whole of India is red, nothing are green areas and green zones. That suggests that we Indians are prone to put a lot of fat in our visceral area, and that is, this is a Lancet paper by Dr. Anjana's group from Chennai have showed that we are putting a lot of fat in visceral area, and that's why we have a very high prevalence of diabetes. And this is typical Indian phenotype. So we are thin from our limbs, but we are fat from our abdomen. And this is also called a South Asian phenotype or a thin fat Indian. So higher abdominal fat is very important, but are we catching this by BMI? Probably the answer is no. So we need to do something else. And that something else can be a waist circumference to identify people who are having a disease that is called obesity. Some people also do waist to hip ratio, some also do the waist to height. So this is thin fat Indian typical. We have lot of total and abdominal fat. We have less of the skeletal mass that we call sarcopenia, and we are doing studies with sarcopenia in our institute. And that's why the Asian cutoff for waist circumference has also come up, and in our OPD, we always do waist circumference in all our patients who come to our OPD. And what they say, any man who has a waist circumference more than 78, he needs to be talked about lifestyle modification. Any man who has a waist circumference more than 90 centimeters, he should be investigated for obesity. And this is the consensus statement which was chaired by Dr. Anup Mishra. So now they are saying that let's combine BMI and waist circumference and come up with a consensus statement to define obesity. And that's why they say that any individual who has a BMI which is more than 25 and or a waist circumference more than 90, vice versa, having a BMI less than 25 but a waist circumference more than 90 should be investigated and should be labeled as obesity. So we thought that we should do a study, and this is a prospective cohort analysis in Chandigarh. This is a very long prospective study of 10 years. So Chandigarh is very beautifully designed into sectors. So we did a stratified random sampling in Chandigarh in 2009. Where we went to all houses in the different sectors of Chandigarh, and we took waist circumference, we did a oral glucose tolerance test, and we just mapped all this general population who were not deceased. They themselves claimed, I don't have a disease. And we wanted to know, after 10 years in this population, how many become diabetic, how many become pre-diabetic, hypertensive, and ASCVD. Definitely some would become in 10 years' time. So we again went to the same houses in 2019. Unfortunately, COVID came, so we had to extend the study. From 2019 to 2024, we again went to same houses. There were some deaths also. So we found out that those people who become diabetic, they were more likely to be centrally obese in 2009. Those who were centrally obese, once we took the waist circumference, they developed diabetes. They had dysglycemia, that is transition from normal glycemia to pre-diabetes. They became hypertensive in 10 years, and they also have some coronary artery events. So you can see in this graph that we found out there was 82% increased risk of having diabetes in 10 years if you have a waist circumference more than 90 centimeters now. You have a risk of hypertension 84% more if you have a waist circumference which is more than 90 centimeters now. So this is a real Indian data of 10-year study. We also found out what actually is the change in the waist circumference. Suppose you are wearing a pant size of maybe 32. What is the change in your pant size over 10 years that predicts the risk of diabetes and dysglycemia? And we found out that if you are having a 2.5 centimeter or 1 inch change in your pant size, a waist circumference, that is a predictor of diabetes. And the risk of diabetes significantly increases with a specificity of almost 60%. So this is very important. We have to keep a check over our waist size. So we concluded in this paper that waist circumference is very important. And probably we believe that 90 centimeters is the cutoff to define obesity, but in India it may be 88 centimeters, because at this cutoff most of our patients were transitioning to diabetes. And what was more glaring was an increase of 2 centimeters in waist over 10.7 years is associated with higher risk of cardiometabolic disorder. But still, waist circumference also has some limitations. It's really difficult to do in epidemiological scenarios. So we thought that we should further redefine, and people now are saying that it is the fat percentage, because waist circumference also do not tell you what you are putting as a subcutaneous adipose tissue or visceral adipose tissue. It just tells you what you are having around your waist, but it does not dissect it. So this is the adipose tissue deposits across age. Usually at puberty, most of weight we put is during puberty. And it's more in the female as compared to the males, and it is the distribution also which is defined by the hormones, by estrogens, which predominantly have gluteal femoral distribution of fat, mainly around the hip in females, as compared to male where we have a slightly above or proximal fat determination. So this is the typical paradox which shows that at same BMI, people from two ethnicities will have different body fat percentage. You know this very famous figure, Dr. Judkin from London and Dr. Yajnik from Mumbai, they had a BMI which was similar of 22. But when the body composition was done, Dr. Judnik has only 9% fat, as compared to Dr. Yajnik who had 21% fat. This suggests that BMI is really likely to be false. And you have to dig deep into the body composition analysis also, that is body fat percentage. So we need to now move beyond the conventional beliefs and conventional assessment of our patients from BMI, but still do waist circumference in BMI, but body composition analysis also. So these are standard methods by which we can do a body composition. In our institute, we do very frequently BIA. Almost many of you might also be having this impedance machines. We also do by DEXA, which is now considered as gold standards, but these are research tools which need not to be discussed. But remember that we should know what actually is the percent of fat which is considered normal. So in a men, what they say that if somebody is having a relatively good kind of lifestyle, a body percentage fat in men should not be more than 24%. And in females, it should not be more than 29%. So this is the normal body percent fat distribution. If somebody is having body fat which is more than 25 in males, it is pre-obesity, and if it is more than 30, it suggests that patient is having obesity. So this is a new definition for obesity that is now endorsed by even obesity medicine associations and all the guidelines. So we thought that we should do a study related to body fat patterning. Body fat patterning means now you divide the body fat into compartments. The visceral fat, the subacute fat, even in visceral fat, the liver fat, the pancreatic fat, and all this. And we wanted to know that is the distribution of fat tells you who is likely to develop diabetes. So what we took two cohorts. One cohort had recently developed diabetes, less than 6 months, and another cohort was BMI matched, but they did not have diabetes. We took all anthropometry, did body composition by DEXA scans, and we wanted to identify the parameters. We found out that both of this cohort, one diabetic and non-diabetic, had similar BMI, but what was different in these individuals was the visceral adipose tissue. So diabetic individual, despite having same BMI, had more visceral adipose tissue. So that suggests the importance of distribution of body fat in Indians, specifically in Indians. We found out also that those patients who were diabetic had lesser muscle mass. You know that muscle is an organ that takes up most of the glucose in the postprandial state, after the brain definitely. And we found out that the best sensitivity to predict insulin diabetes was intra-abdominal visceral fat. And this is very important, and this is an eye-opener that probably you might also change your practice and start with body composition. This is one of the last slides that I want to tell you about recent Lancet Commission paper that came in 2025 in January. Now they are defining obesity as a disease. So any person who has physical phenotype like seems obese, but does not have any signs and symptoms suggestive of obesity is called preclinical obesity. But if somebody matches a BMI definition for obesity, you do a confirmation of excess body fat by waist circumference or fat measurement in addition to BMI. So even the now Lancet paper also says in addition to BMI, do BMI but also to waist circumference and body fat, and he or she is having any signs and symptoms of organ dysfunction or any age-adjusted mobility disorders like OSA, osteoarthritis. This is called clinical obesity, which now you can mention in your OPD card as a disease. Further ahead, this is another modification. Now we also write EOSS, that is Edmonton Obesity Staging System, to say that those who are obese, what kind of organ dysfunction they are having. A mental dysfunction, medical dysfunction like OSA, or any ASCVD, or any hypertension or diabetes. And this all conundrum that I am explaining to you, BMI, waist circumference, body fat composition, has treatment implications, because now we have drugs that affects the body composition. So whether it may be a GLP-1 analogs or dual analogs, they have shown reduction in waist circumference, they have shown reduction in percent body fat mass, they have shown reduction even in the visceral fat mass, in addition to reducing comorbidity. So now probably we should change our practice, as Dr. Sunil Jain sir were also saying, from glucometers to CGMS. Now from simple BMI defined obesity to waist circumference and also body fat defined obesity, because now you can offer to your patients. If patients visceral adipose tissue more, you can say, I can give you a drug that can reduce your visceral adipose tissue and prevent the metabolic complications. So I will conclude by saying probably we need to shift from BMI to more intense measures of defining obesity to waist circumference and percent body fat, because now you have many things to offer to your patients as anti-obesity therapies. Thank you. Thank you, Chair.
Excellent talk. Basically, we should think about other parameters beyond BMI in our clinics on routine basis. It should be done in every patient who are attending, especially with chronic disease.
I would like to ask a question. How can a physician at his clinic do visceral fat content?
Absolutely. This question is very pertinent. How a physician or a simple clinic can also do assessment. You might not have access to DEXA, you might not have access to other CT scan. But now even a simple weighing scale also that does this body composition analysis by impedance. So they just pass a small microsievert current in the body, and we know that the current, when it flows through the bone or a water or a fat, has different resistance. So just within standing on a weighing scale kind of thing, that is 2-point BIA, you can get a good estimate. Though it is not gold standard, but still it gives you a good idea. And very important is it gives you a visual report. The patient को report दिखाता है तो समझ में आ जाता है यहाँ fat ज़्यादा है. This is very cheap now. Now we can get these machines just in 5,000 rupees.
You want to say they are fairly accurate?
For a large epidemiological study, for a small clinic, they are fairly accurate to make the patient understand. Now, if he is having a abnormality on that BIA, you can do a DEXA scan if you are planning any kind of therapy to show what is the change with therapy after any intervention.
In case we follow up, again, are these machines good enough?
Exactly. So people have done studies with these BIs also in follow-ups, but try to have the same machine. That's very important. So once you are doing at baseline, have the same machine during follow-up also.
We have questions from the audience.
So, thank you, sir.
I would just with saying that gone are the days when we used to measure obesity just by looking at the person, but we need to move further. It's not just weight, it's also waist circumference. Away from those waist circumference, we need to have other parameters like waist stature and waist height ratios, which would be much more accurate. And then not only subcutaneous fat, also visceral fat, and then also dysfunctional fat. So we need to work it up and then follow for a decrease. With that, my compliments to Dr. Ashu for an excellent disposition. It's over to the organizers.
Thank you, sir.
I request our speaker, chairpersons and panelists to come at the felicitation dais so that we can move on to our next presentation. So after Dr. Ashu's eye-opener presentation on obesity and the correlation of obesity to diabetes and to the various cardiometabolic disorders, I think we all want to know about the diet for weight loss so that we can move towards fitness and make ourselves and our patients fit. And I invite Dr. Rajiv Singla for his talk on diet for weight loss. He is from New Delhi, and I invite our chairpersons, Dr. Naresh Rajpal, Dr. Sanjay Arora, Dr. Devashish Sachan to chair this session, and our panelists, Dr. Poonam Tiwari and Dr. Smita Singh. Chairpersons to introduce our speaker, please.
For the next topic, we have got another eminent speaker, Dr. Rajiv Singla. He is MD, DNB, DM, FRCP from Edinburgh. He's got multiple publications and awards, 1,500 citations, 70 plus index publications. He's got the best brief communication, best reviews, best original article, best review articles from IGAM, Endocrinology Society of India, course director of Type 1 Diabetes Education Initiation. Over to Dr. Rajiv Singla for our next topic, that's on diet for weight loss.
Thank you, sir, for your kind words. And thanks to the organizing committee for giving me the opportunity to be here. In the next 20 minutes or so, my job largely is to give you a very to the ground approach and basic options that we have in choosing diet options while we are treating people with adiposity. Now, I think lifestyle measures already are in a losing battle with more and more drugs coming and everybody looking for easy solutions. But I still feel that without lifestyle measures, eventually it's a losing battle for anybody who's trying to lose weight. So, I think before in my own clinic, if I go on and talk to people about the diets for weight loss, we need to set some goals, we need to understand, we need to talk to people and then see where do we want to go. So broadly speaking, the goals can be reversing diabetes and all metabolic conditions, reversing all mechanical complications, and then of course people may have different goals in their mind, with aesthetics in mind, with body shape things in mind. So if you ask me, these things happen in this sequence. With some weight loss, your metabolic complications gets reversed, and then mechanical complications get reversed, and then eventually there is no end to the body shape that we want to do. Another thing is that an expectation on course, because it's my belief that in the long run, eventually the patience that is needed, that leads to the failure of lifestyle measures in people. So we need to tell them that weight loss is not a linear process. Weight loss is a step ladder process. Somebody who starts on diet and exercise today, maybe for a couple of months, they actually end up gaining more weight than losing weight. Because they may gain some muscle mass while they may lose some fat tissue, so the kgs may not equate. So, but if they are losing inches, then it's okay. And then if they continue on same course, then for a particular level of exercise, their weight, muscle mass stabilizes, then that's the time when they would see those fall in those kgs, and then some step ladder pattern, and then there would be a plateau after some time, because body would reduce its need for calories to maintain that weight. And we don't have to lose heart at that plateau, so that we just need to keep on going. That's what we need to tell people. Now, if you would ask me without any diet, if there are a few things that we need to tell people and that can do wonders, is just these few things. First of all, keep on hearing that I am doing diet, wait to lose weight. And there are different people, we know that at same level of diet, different people may not lose same amount of weight. So for each and every patient, we need to start from what they are doing today and then what their goals are. Because each and everybody's response to diet and their body is different. Second thing is that practical is better than it is. If you already tell people to do things that they can't follow, there is nobody at home to make their food. And if you ask them to do specific kinds of food, then it's a recipe just on paper, it's not something to follow. And generally the common belief that 6-meal pattern is what we need to do for weight loss activation. So I think this 6-meal pattern we only adapted because at some point of time we didn't have adequate anti-diabetic medication. So we just asked people to eat same 3 meals in 6 divided times. But now what we are doing is we are not only eating 3 meals but 1.5 meals 3 times additionally. So instead of taking 3 meals in 6 times, we are taking 4.5 meals at least everybody. So that's what happened. And And the snacks that we take is actually a problem because these are calorie rich, they are just made of fats and oil. So 2 biscuits have almost same calories as a chapati roll. So whatever we take at that time, that doesn't even get counted into our meals, and then we just end up gaining more. And consistency is the key. So if we do it for 6 days, and if you take a day off, you may not gain weight, but there are very, very high chances that you will not lose weight. So consistency we have to maintain. Not related to the diets, but I would still say that I am a little skeptical about this entire story of obesity being just bad in all shapes and forms. If you look at data like this, and there are data from multiple national studies, this is data from South Korea, the national database, what it shows is that somebody who is diagnosed with diabetes has a particular BMI, when these people were followed for 8.5 years, people with higher BMI had lower mortality in a linear fashion till their BMI fluctuates. Beyond 30, your mortality increases as compared to somebody with BMI between 25 to 30, but still not more than if somebody got a BMI of 90 or 20. So it's not always good. We need to choose people very, very cautiously whom we want to make them lose weight, how much they want. This is basic slide as to we can go from a very common diet to a very hard diet. The more we go towards diet, harder it becomes to follow, but it becomes more efficacious. You will lose more weight, but then it becomes sustainability over a time becomes. So for each individual patient, we need to find a place on this linear line somewhere where their goals are met, the diet is sustainable, and it is efficacious. Now if you would ask me, this is what we do at our clinic. We start with a low calorie diet, then we add some combination of low calorie and low carb diet, and then strengthening it further, and then we go on to ketogenic diets and formula diets as and when it is required in people. When I say low calorie diet, it doesn't mean that we have to start with 1000 kilocalories or 1200 kilocalories. We just start off with 25% less calories than what they are doing today, and then we gradually increase it as and when that is required. But generally speaking, first 2 steps is required in most of the people, but then 80-85% of people are covered in first 2 steps. I'll show you some data. So if we talk about all strategies, all diets, now we may have different names to them, but they would have 2 broad categories. Either they are low calorie diets or they are low carb diets. All strategies will fit into some combination of these 2 broad forms. Now the major difference between these 2 is that when we are focusing on carbs we are focusing on carbs because of insulin. Insulin acts as a weight multiplier, right? So even in our traditional thinking, our dadis and nannies would say कि roti नहीं खाओगे तो खाना नहीं लगेगा, because it's simply because without carbs there is no insulin, and if there is no insulin there is no lipogenesis. So even if you are taking excess calories, if your body doesn't have excess insulin, it doesn't get stored. Body doesn't store it because insulin is the one which makes you do lipogenesis. And this is also true because when somebody is put on a low calorie diet, because we're still taking carbs, so our insulin levels doesn't go down in that case. So that insulin which is there is not going to make you lose fat, but you do not have enough glucose to be utilized. So your cravings is going to be more. So that's why in all diets, in low calorie diets, cravings are basically too much, and then they lead to long-term failure. While if you are on a low carb diet, because insulin is not there, and then you can use fat as an energy source, so that's a big plus point for low carbs diets, that you can eat at will. So that's why in ketogenic diet people don't feel craving or will to eat. Now if I divide in a traditional sense, then this is a standard diet that we do. It can be an American diet or an NIN diet. then we can say it's a Mediterranean diet, Paleolithic diet and ketogenic diet. Now if you look at this, the difference is between carb content again. So as we go down, the carbs are coming down and your fats are going up. So we are just changing the macro composition of different diets. Now, just to take you through these different diets, and normal diet everybody knows, in Mediterranean diet, everything is in moderation, which includes your grains and dairy in moderation, and then all other things are vegetable, fruits, whole grains, and then beans and nuts and seeds. And then of course the stress is on not taking fried food, and of course everything says that junk food and all those stuff need to go with any of these diets. So it's shown to be good for heart and non-controversial. Everybody agrees on value of this. And then if you go to Paleolithic diet, now Paleolithic diet is supposed to be which in earlier era humans, when cooking was not discovered, when they used to it. So only thing which will go off the table will be grains. So now there are no grains because we didn't used to farm at that point of time. So if you take grains away, so then of course a large portion of carbs are gone from your diet. So everything else is same, but then your grains are not there. And then it becomes a combination of a low calorie and a low carb diet. And then in ketogenic diet, you also make fruits go away because now you want to keep your carbs to less than 30 grams a day or so in non-vegetarian diet, and less than 60 grams in a vegetarian diet or so. But of course, these becomes very, very difficult to sustain in the long run. Now, just a point here that by itself, it's not that ketogenic diet is not a good idea in the long run. For a selected people, like any other therapeutic intervention, it can be a very, very good thing. We have done a series at our clinic where we could make people lose 25 kgs or 30 kgs by doing them ketogenic and following them diligently, looking at their kidney functions and all other stuff. And none of those things happened in any of our patients. So it's safe, it can be done. Of course, it needs to be done under a medical supervision. Now, there are certain other variations, like for example, intermittent fasting. Now, intermittent fasting again is a form of inducing low carbs. So we're not giving them carbs for an extended period of time. Your insulin levels goes low, and then your lipolysis kicks in. You are able to lose weight for some point of time. Then you again go have some food. So then in daytime, your lipolysis kind of increases. And there are some interesting variations, some YouTube food diet where people ask to take everybody some fruits. And then very, very interesting diet, one patient told me, that you are only supposed to eat 2 foods in a day, whatever you choose, whatever your choice is. And then now in a traditional thinking, we may think, okay, what is this? This is not. But I would say that if it works for somebody, it works for somebody. If you look at the logic, if I ask somebody to eat rajma chawal for the entire day, how much rajma chawal would somebody eat for an entire day? So he just can eat rajma and chawal. So if it works for people, it works for people. It doesn't matter. Of course, you have to look at the macros composition and nutritional deficiencies that can happen with these people, because now you're limiting the type of foods that they are taking. But if it works, doesn't matter. Now, how do we do at our clinic? So this is an unpublished data. We did it on people with diabetes, but what I just want to show is that what works in the real world. So 56 people, if you look at males predominant, age 43, duration, weight around 91 and BMI of 33 kgs per meter square. Now, what we do is we do an intense diabetes diet program at clinic where it's a three-tiered. I see them every month. My senior dietitian, she sees them every week, and then there is a junior dietitian who follows up them twice or in a thrice a week. So just to increase the compliance. Now, over 3 months, people lost 7.29% of their body weight, and their BMI came down from 33 to 30 kgs per meter square or so. Now, just to tell you what diet did we give them. So we just gave, as I told you, we just gave them a combination of a low calorie. We started with 1800 kilocalories, eventually we reached around 1400 kilocalories and so on. And if you look at fats and protein are fairly stable where they were to start with, and large calories reductions were done from the carbs. So from 258 gram carbs in a day, we came down to 147 gram carbs in a day. And just by doing this, and nothing special, no special diets, nothing extra foods, simple homemade diet, just regulation of macros, and then you could make it for these 8 to 10 kgs of weight in 3 months. And then with some time, I'll show you basis from these 56 cases. If you look at this 42-year-old male and 97.9 kgs of weight, diabetes for the last 5 years, HbA1c 10%. We did add dapagliflozin and vaccine to start with, and we started on the same diet. Then I will show you macro distribution. And if you look at over 3 months, this is the 6 months data. So the weight has come down from 97 to 85. Skeletal muscle mass has gone slightly up. But there is a large change in percentage body fat. As Dr. Asha is rightly saying, in our practice, we are now regularly using these body parameters, and this is actually a bioelectrical impedance. You look at same story, muscle mass is fine, we are within range, but if you look at fat analysis, over 500% more than what it should be to start with, and it gradually comes down. And if you look at diet, is almost similar. To start with, baseline was 348 gram carbs, we brought it down to 173, which is not undoable. And we cut down the calories, and only 5 milligrams of dapagliflozin was metformin, and doing very, very well since then. Similar case, another little more longish follow-up, 8.3 HbA1c, and started on just on metformin diet. If you look at now this data is from almost 1.5 years data. If you look at the sustainability, the starting HbA1c was 8.3, and then it has come down to 5.9, 6.5 of all medicines. Now, if you look at this, there is slight upward curve in the diet. So which is little fatigue that people would have, although the percentage body fat still remained little lower and the muscle mass went up. So HbA1c never went beyond 6.5. And it came down again. If you look at the 2024 HbA1c, it came down again. And similar, 370 grams to start with, and eventually around 180 gram carbs, which is very, very basic, simple. 400 kilocalories diet, doing very well. However, you do have other people, 40-year-old male, 1 year diabetes, HbA1c 9.4%. Did lose some weight, then gained again, and despite years asking for compliance and everything, and then did not tolerate dapagliflozin, we had to put glimepiride. And then, of course, these cases, similar diet, but more fat. So everybody is a different person. So we have to check for their adherence, we have to ask them whether an aspiration of diet would be acceptable to them, or perhaps these may be the cases where we need to go for the medical help. So just to summarize, weight loss goals are very, very personal in nature. Simple step-ladder diet therapies, we believe, work very well in clinical practice, although follow-up is the key. Because I tell people that 70% of what dietitian does to you is follow-up is more important than the diet they do prescribe. But same therapies may have different response in different people. No therapy is good or bad in itself, and we also need to know when to stop and how much we need.
Thank you, Dr. Rajiv. Wonderful coverage. I understand due to cost of time, we will not have many questions over here. Any questions can be taken on one basis. Thank you very much.
आवाज नहीं आ रही मैं निकालो तो हम खींच के तो नीचे तक
is from the diet calculation.
Like it's more about the nutrition the patient or person is taking, because from macro we have to see to the micro even. And as you talked about, like there are weight loss diet, nothing one can fit for all. We have to take the cultural, the geographical, the variations which people have in their eating pattern into account for the sustainability. I feel so.
Just want to add one more thing. Any diet plan can be best for any other person, but our human body is so intelligent that it can adapt to any of the single diet. So I mean to say, because your data has also been confirming that we should be changing the plans for a period of time so that the body can get don't get adapted and get the results. So for the weight loss, no single diet can work. We have to have a simple combination of food groups, and that can be done only by the qualified dietitians. Thank you.
Go to the match.
Thank you, Speaker, Chairperson, panelists. Please be likes on the stage that we can do the segment. For the next session, I would like to invite Dr. Nitin to take over proceedings.
We have a very interesting session now. It would be a keynote address by Dr. Prasanna Kumar on cardiovascular risk in type 1 diabetes and its management. So for this session, I would invite our chairperson, Dr. Sanjay Singh, Dr. A.K. Sharda, and Dr. Ghanshyam. I also invite our panelists, Dr. Sanjay Tandon and Dr. Atul Mehra. As far as Dr. Prasanna Kumar sir is concerned, I think most of the people sitting in the hall would be knowing him. He had been a DM Endo from Foreign Institute in 1987. He was former head and professor endocrinology at Brahmia Medical College, Bangalore. He was past president RSSI 2007 to 2009. He was past president Endocrine Society of India in 2008 and 9. He was past president Indian Thyroid Society in 2018 to 2020. He was director of Primer, chairman Changing Diabetes in Children, and he has more than 200 publications in different journals, and he has spoken more than 25 orations. So without wasting time, Dr. Prasanna. I just invite Dr. Rajiv and Dr. Mitra to felicitate Dr. Prasanna.
This excellent meeting with such a good high quality of science as such. Why did I choose cardiovascular risk in type 1 diabetes management? Because that is my passion now. I'm working with a cardiologist and some of the mentors across Australia on this project. I'll show you what we have done. I have no conflict of interest. As you know, type 1 diabetes is absolute insulin deficiency. It should be an endocrine disease. Apart from hypothyroid, it's the commonest one you will see, and it's autoimmune mediated. And mortality is increasing because compared to non-diabetics, the diabetic type 1 have 10 times higher risk of developing the cardiovascular disease as such. Okay. So, as you know, it accounts more than 90% of diabetes in children as such. There were 330,000 new cases of type 1 among children in 21. Now it has increased. Number is expected to be 500,000 by 2050. India probably has 980,000 all age groups. This is Graham-Ogle's data. And below 20 years will be 3 lakhs and all, meaning more and more children younger are getting. And cardiovascular disease is the leading cause of mortality 2 to 5 times, and I said sometimes probably 10 times. 1,70,000 people will die prematurely with type 1 diabetes. Unfortunately, less than 25 years are nearly 50,000 of them. So, life expectancy. Earlier you get diabetes, you will die earlier. The quantity of life lost is much more. This figure, as you see here, these are the countries. If you are born in Cameroon 10 years back, average lifespan is 6 months. And that's what we used to see 50 years back. Today I have a 1983 20-year-old boy who was diagnosed diabetes, 43 years on multiple doses, married, children, grandchildren, no complication 43 years. So we are seeing the other extreme. So type 1 diabetics are living longer to die of chronic complication, macrovascular complication, not due to microvascular. Of course, Australia, Canada, US may be better. So quantity of life lost may be as less as 8 years or even 50 years. So this is the statistics. My statistics are different. I got 1,000 patients. They started in 2011. Abdul Kalam started CDIC. And out of 1,000 patients, over a period of 14 years, 16 have died. At life I checked 2,000 children, 3 expired, 3 months per follow-up. So what is it to have 90 children died over a period of 14 years? That comes to 1.5 per 1,000 children. Whereas the data from abroad, we have not seen this, they show 12,000 children will die every year in India. That means 30 children will die every year due to type 1. I don't see that. My own patient, I can vote for every patient. We ring them up every 3 months, how are you? I'm fine. I go to another doctor, I'm taking it, so the government is giving whatever it is. This is my roadmap to identify modifiable, non-modifiable risk factors. How to investigate 10-year-old child or 50-year-old man for the risk factors, cardiovascular test. How to manage these and prevent cardiovascular. This is the pathogenesis. I don't want to go into detail. How postprandial hyperglycemia acts on the mitochondria, PKC, and then you will see that nitrous oxide generation and peroxynitrite can cause DNA damage and it's endothelial dysfunction. And that is the root cause of peroxynitrite, and it also affects the addition molecules because the age, advanced glycosylated end products, and we will see how pro-inflammatory cytokines have the complication. This is how macrovascular complication cardiovascular. This is a Europe type 1 diabetes study, 3,200 children, and the prevalence of cardiovascular 9%, 10%, 6% in the age of 15 to 29, 25% in the age of 45. We are going to study 15 to 40 years. Identify modifiable, non-modifiable factors. Modifiable hyperglycemia. This is it. Tight control of diabetes can prevent complication. Likewise, then hypertension. Probably the most contributing factor. Diabetes contributes only 16%. Hypertension. You can have 130 by 80. LDL cholesterol less than 100. Tobacco use any form, smoking, eating, lack of exercise, obesity, just so much about obesity. Depression is also a cause of it. Nephropathy from microalbumin to chronic kidney disease, of course. Autonomic dysfunction leading to abnormalities. So, age and mean A1C are strongly associated with any CVD and MACE. For each percentage of point increase A1C, risk of any CVD MACE increase 31 and 42 years. So that's why they are very, very important upon. Other modifiable factors, insulin resistance, just heard about obesity, how fat is, socioeconomic status. Poorer people have more mortality, mortality compared to life, affordability, availability, acceptability, adaptability. This is what it is. Naturally, a rich parent will take care of this type 1 better, including the insulin pump cost of that, whereas poor people have 3,500 who can't afford it. Right? People who are poor eat more of fat, more carbohydrate. People who are rich have protein. Hypoglycemia is a controlling factor. On one of these studies, people who died of cardiovascular disease had an episode of hypoglycemia 15 days before that. It is true for adults and children. Endothelial dysfunction, that's the main cause for cardiovascular disease. Erectile dysfunction. Last 20 years we say ED is equal to ED. What is it? Endothelial dysfunction is equal to erectile dysfunction. So patient with type 1 should not have routine stress test. Yes. Today you see all that. Their doctors get a TMP, calcium score. No, that is true even for type 1 also. And advanced testing not necessary. But calcium score is one of the things which is important, but you cannot do everything, you don't have to. One of our Austrian partners, as I said, Jenkins, professor in Baker's Institute, I think only 25 to 30 years of diabetes, then only you do calcium score. Otherwise, 10 years, 15 years, type 1 you don't do. Non-modifiable factors, yes. Type 2 diabetes, one parent diabetes, two parent diabetic chances. So also type 1 diabetes, if the one of the parent is type 1 chance more. Age, higher the age of type 1 diabetes, like atherosclerosis, you get more cardiovascular disease. Sex, all of us know men have more chance of cardiovascular disease than women, but after post-menopause, both victims. Kidney failure, South Asians were the highest risk of diabetes, highest risk of cardiovascular disease. Today you see that cardiovascular disease is increasing in India, it is coming down in the US. And the reason is very, very obvious. You see 30, 40 years people are dying. So diabetes, heart disease, 1 decade earlier in India as compared to duration of diabetes, longer the diabetes, and more chance of having ischemic heart disease. Age of diagnosis, below 5, above 5, below puberty, above puberty. You like to have type 1 diabetes after puberty. I would like to have diabetes at 70, not at 30, or whatever it is. HDL. Indians have a typical lipid profile, they have low HDL, high triglyceride. Right from birth. Singapore is a place we get 3 people. Chinese, Indians, Malaysians. Indians have the worst of the lipid profile, including homocysteine, LP and all that. It's a marker, nothing else. Past history of smoking, not only present. Diabetic retinopathy, there are unknown genetic factors trying to see. Type 1 diabetes, those are genetic, probably have more cardiovascular disease. That will be precision medicine in future. How to screen glycemic control from urine sugar, blood sugar, self-monitoring today have come in. Where we want time in range 70% important. With insulin pump, I can achieve 90 to 93% time. A1C, not only just one A1C, 3 A1C, glycemic variability, A1C variability. This is done by CGM, blood pressure measurement. Every child from 5 or 10 should be checked with a pediatric cough. Lipid profile has to be done as early as 10 years. When we say abnormality, atherosclerotic changes start 2 years of age, not 10 years of age. LPA is one unmodifiable factor, so we have a very high LPA that goes to above. BMI, I heard so much, obesity child, more chance of it. Urinary artery creatinine ratio takes 2 minutes to do it. Very good index of future cardiovascular disease. Some people disagree. EGFR, serum creatinine are again correlated to cardiovascular disease. So, some of them did not show much of change of albuminuria leading to cardiovascular disease. How do you screen adults? This Steno model, Life 131 model, Pittsburgh model, carotid artery. It's very simple to do with the Doppler, coronary artery calcium score, as I told you, more complex, more expensive. Cross-compartmental is also a good tool to detect the future. This is a Pittsburgh EDC study. 302 children and adults at mean age of 32 years, prevalence of coronary artery calcification, 11% patients below 30, 88%. I don't think we see that. Though we have very few patients, still if you screen 100 of your type 2, you don't see such a high incidence. And this is the CACRI study, coronary artery calcium was more than 39% of males with type 1, 12%. I have already done both are normal. 25 to 30 years of diabetes. I'm happy to 100. Give me 100 cuts and so see how many we have consecutive patients. This is what is published in diabetes. So type 1 diabetes is also a higher coronary artery score volume, accelerated. Let me see, every 5 years, if I live next 20 years, what happened to these 3,000 children? Menopause also increased the calcium score. Both men and women had higher calcium score, older, more commonly affected excessive weight, high BMI, more intra-abdominal subcutaneous fat, and waist depression, what just now we had. We don't have any data about this in the world also, not small papers. Everybody should get an ECG. There are major abnormality, minor abnormality, no. Today information, artificial intelligence, probably normal ECG. Minor abnormality, major abnormality, middle branch block, left ventricular is a high risk, left ventricular is a high risk, atrial fibrillation is a high risk. Every child from the age of 10 or 15 do it. Follow them 5 years, what happens? And also, age 30 echoes in children, age of 18 to 40, left ventricular dilation, left ventricular mass, left ventricular function, vascular dysfunction. Pulse wave velocity, arterial stiffness. So far in 30 patients I have seen, type 1 diabetes compared to control higher arterial stiffness. What does it mean in the future cardiovascular risk from 5 years? Endothelial function, very important. These are all the risk ranging. Wikipedia segment only for adult, STIMO type 1, and pre-risk are the one. There are already few papers from India where said pre-risk is higher in type 1 compared to other population. So, how to manage the cardiovascular risk? It's a teamwork, multidisciplinary care. Endocrinologist, cardiologist, 35 years we are working. We have a nutritionist, diabetes educator, psychologist, to see how much of monitored exercise is done. You should have optimal glucose control, A1C is crucial. Nothing like one size. So, what is good for 5-year children? Below 6 to 14, 14 to 20. During the adolescence, as you know, even non-diabetic, your children or grandchildren, you know how much of problem. Diabetic has such more problem during that time. CGM, time in range, time above range, time below range. Blood pressure, low risk, target 140/90. If they have high risk, please target 130/80, not even 140/90. Normal at 17 years, I want to have 120/80, not 140/90. LDL cholesterol should be less than 100 if no CVD. If they have CVD, LDL should be less than 70 also. Lifestyle modification, probiotic cessation, any problem, dash diet, just now I maintain that, exercise regularly, 30 minutes per day, 150 minutes per week. Type 1 diabetes is no way different from type 2. Children may take even 8 hours per week. Flexibility and balance is very important. And if you want to prevent muscle mass, sarcopenia, you have to use strengthening exercise, high intensity interval training. That's what is necessary. One therapy, all of us have started with rent and train, 8 rupees per mile. Then we started 3 weeks once per type 1 diabetes. Now we are in recent course. Optimized control, close to syndrome ideal. Then if the blood pressure 2 occasions are high, please start ESRL. Statins are used. I have many children, 10, 12, 14. The cholesterol about 200, LDL about 100, I have started already statin in these children. Aspirin, if they are high risk, every type 1 don't need aspirin. If we think high risk, family history, start that. So, SGLT3 may be good for others type 2, but not, because diabetic ketoacidosis, euglycemic ketosis will occur. So currently not EDA, nice. GLP-1 receptor are promising. Semaglutide, tirzepatide, but nobody has approved for type 1 diabetes. Out of this, you can prescribe. I have used adults about 30. Fantastic result. Please, type 1, A1C drops down, 20 to 30 kg people have lost GLP-1. What are the research questions? What is the role of CVD risk factor type 1 diabetes? What are the indications? What are the efficacy and safety of lipid-lowering anti-hypertensive in children? We don't. When should statin be Can you agree? Any pharmacological purpose safety used to promote cessation smoking? We don't have anything to do with it. Can be safely be used in that to prevent nephropathy? What are the best lifestyle modifications? We still don't have answer. When you don't have answer, you start working. Much work to be done, and especially in this country, hardly do papers. Only thing I have seen is BMI, hypertension, lipids. Our project is CV, 100 type 1, type 2 times 15 to 40. We have already completed 100%. What is it that we do? To generate new data, to identify risk factors, determine, to use data type of what to conduct collaborative research, to see what is the cardiovascular risk, why do you want to do that? To introduce policies, programs, and innovation that improve care and outcome for individual. We are always looking at preventing risk. We are always looking to preventing decay. That's not that. That's a minimum. The goal is my child, 5 or 10-year-old, I have 4,000 children, should live 85 years like me and you, should not get heart attacks, should not be able. What I can do today beyond placing it. 50 boys, 50 girls, in this age group, protein history, sleep assessment, which we have completed 100 patients. Depression is one other thing. So that is quality of life. Depression score PH to 9. We have completed 100 patients each, not once, twice, 2 months apart, to see if there is discrepancy. Physical exam, behavior, attitude, alcohol intake, exercise, family history, blood pressure, medication, what they are using, and also lipid levels. All these were done routinely for them. Diabetic specific duration, insulin dose nephropathy, hypoglycemia recorded, which are recorded, and episodes which need assistance, grade 1, grade 2. HbA1c every 6 months, if possible 3 times. So, these are the things we are doing. And life expectancy has increased substantially last century, leading to CVDs, lifestyle measures are necessary. To summarize my talk, good lifestyle control of hypertension, basically, LDL cholesterol, that's all what we have to take. But I am looking at certain parameters. Fibrogen, I don't know. LPA, I don't know whether it can. Or some other test, ECG, autonomic function, which can say prolonged degree interval, and then what we have done 10 years back. Varying RR interval is an indicator of future cardiac disease. 20% of them have it. Yes, can they prevent it? Whether GLP-1 are given in those children with type 1 diabetes, BMI more than 27, will it prevent cardiac? Nobody has an answer in the world. We have it only. Type 1 diabetes is one of the most common chronic diseases in children and adolescents, but remains unpreventable. What is unpreventable? Uncurable. Last time I had 3 talks. Prevention of type 1 diabetes or cure for diabetes, who will win the race? I think cure will win the race. Prevention has not won the race. It will not win the race. 30, 40 years back I gave a talk. Prevention of type 1 diabetes. It was funny. At the end of 40 minutes, old gentleman came, very good talk, ornamental talk. Person I ordered him. Recently nothing will happen. 3 years. I said, who is this old man? He said, he was father of diabetes. Now what he said 40 years back, is to diabetes. Nothing has happened. Prevention, you can give a talk. What has happened? Nothing has happened. Not even diabetes. There is no hope that one day type 1 diabetes will be cured. I am sure before I die it will be cured. But my goal is no child should die of diabetes. I have seen 16 years only in my I want to see 26, 27, no child dies. But the goal is big. The woods are lovely, dark, but I promise us to keep I go before I speak. Robert Parks, yes. Thank you for your listening. Thank you for this. Thank you.
A wonderful lecture. I think very, very insightful, and it would evoke a lot of thought process and idea. I request you to, sir, come down for the salutation. All the chairpersons.
And without wasting time, we must move on to a very interesting session about navigating the clinical myths and everyday dilemmas in type 2 diabetes. And for this panel discussion, I invite
our moderator,
Dr. Sunil M. Jain, sir. I also invite our panelists, Dr. Manoj Srivastava, sir, Dr. Nirupam, Dr. Ghanshyam, sir, and Dr. Shakti Vajmeya.
सिंगली पूछ रहा है क्या बस नहीं कार्ड ने कोड फॉर्मेट कैमरे तो बनवाना पड़ेगा कैमरे मारो
So, after the session of Dr. Prasanna Kumar on type 1 diabetes and CBD, now we are moving on to a panel discussion. And it is related to day-to-day issues in diabetes. So, if anyone of you have any question, we have a panelist who will answer it. Anyone has any question? In general, on diabetes, any controversy, any common area, any points in your mind? Any question on your side? So till then, you can take off and let me start. So we are discussing a lot of neuroscience today about diabetes. So I will ask this question to Dr. Ghanshyam first. Traditionally, diabetes therapeutics in India, still it is going on, is using sulfonylurea and metformin combination therapy. Now we have a new learning on diabetes over a period of years. What do you feel? Should the same approach is okay or there should be some big change?
नहीं दिखाई किसके
You keep mic a little close.
Hello. Metformin, after metformin, we have to think about SGLT2 inhibitors. This is not very expensive also. Then GLP-1 is also one can consider, but the cost is quite high. So if the patient comes with cardiac problem or renal problem, in cardiac problem we have to think about GLP-1 if the patient can afford. In the cardiac problem like CHF and other things, then we have to think about SGLT2. Otherwise, sometimes patient is overweight, then we also think about GLP-1 after metformin. So no doubt metformin is still the first line of drug, but sulfonylurea we can start later. But combination is not very good. If the HbA1c at the beginning is like up to 7.5, then we have to go for with metformin.
So basically, what sulfonylurea is doing are they are just bringing insulin out of the beta cells and bringing glucose. And now our horizon for the diabetes management is quite broader, as we are talking about. So obviously, the positioning of sulfonylurea is going relatively down. And metformin remains a good drug, but in addition we have many other options. And next time, I will request the panel, Dr. Nirupam, you can comment on what is the positioning for SGLT2 inhibitors versus GLP-1 receptor agonist in our population.
As Dr. Ghanshyam pointed out that first line of drug to be added select group of patients like patients with cardiovascular disease, renal disease, or heart failure, where primarily the GLP-2 inhibitors or GLP-1 analogs would be the ideal drugs to be added. because these are agents which are as such also noted whether the patient be diabetic or non-diabetic. So if we have a patient whereby we are compelling indication of heart failure, cardiovascular disease or high-risk ASCVD or CKD, in these group of patients, SGLT2 and GLP-1 analogs would be the first drugs to be added on. Apart from that, these agents have the benefit of reducing weight. So wherein our population, we have said with obesity, these drugs also have an action of reducing weight. They are SGLT2s, if I were to say, they are now economical, they are affordable. GLP-1 analogs are still on the higher side. But overall, if we were to consider that there are many patients at risk of CVD with multiple risk factors, there are patients with heart failure, other comorbidities and have obesity, then SGLT2 inhibitors stand a choice to be used as first line of management, and GLP-1 analogs in patients who can afford them. So that would be my take on it.
Next, you can give that to the next panelist. So the question is, if we look at the prescription practices in India, what do you think? Right now there is so much talk about all ADA and so many organizations about the GLP-1 receptor agonist versus to prescription practices in India. What is your observation? How much GLP-1 we are utilizing in India? What are the barriers? Is there any reason because of that we have less number of patients on GLP-1 receptor agonist? Why we have less patients who are using these drugs?
I think there's a lot of misconceptions regarding the use of GLP-1RA, especially in the HCP community. And the reason is that we always took it as a drug for obesity, right from the time when the first of these GLP-1RAs were introduced in India. So we started targeting those patients who were obese. And in that purpose, we failed to look at the cardiovascular risk factors, the renal risk factors, the HbA1c reduction in these patients. A large number of our patients would still require GLP-1RAs even if they are not obese. This is a message I would like to convey, because in the LEADER trial and the other trials, the CVOT trials which had been done with the GLP-1RA, obesity was not a criteria. So these drugs can be used even in patients who are non-obese. Once we leave behind the concept that these drugs are meant for obesity and they are to be used in patients who are type 2 diabetics with obesity, then we can look at the different aspects, including a very good HbA1c reducer after metformin, sulfonylureas and insulin, a very good ASCVD risk reduction drug, even better than SGLT2 inhibitors, with a lot of anti-atherosclerotic effect. Thirdly, again, it has got benefit as far as renal dysfunctions are concerned, even in patients with heart failure. So looking at all these aspects, I think GLP-1RA should be kept as a drug to manage the comorbidities and the complications of diabetes, rather than keeping it as an anti-obesity drug in type 2 diabetes. Once this concept gets clear, I think every patient who is coming out of an ICU with an MI situation should have a GLP-1RA in his prescription. Every patient who is on dialysis probably should have a GLP-1RA. Every person who has a stroke probably should be on a GLP-1RA. So if these are the criteria, even now with MACLD, GLP-1RAs have now been approved even in patients with fibrosis, liver fibrosis. So I think the indications are increasing day by day, and we are sticking just to the obesity. I have found very few patients who are non-obese and who have been kept on a GLP-1RA. So I think if this message goes, that please don't keep obesity as the criteria for prescribing these drugs. There are a number of other indications. Always use those indications. Obesity is one of the indications, and I think that's not a very serious indication as compared to what we are talking about.
So obviously, the science of indications is very clear. We have enough science about that. But why? Any other panelists would like to comment? What are the barriers? Why we don't see many of our patients taking benefit of these drugs?
So, sir has rightly said that there are a lot of barriers. The commoner prescription still today we see it's a combination basically with sulfonylureas, metformins. Though the SGLT2 nowadays we see more in the prescriptions because now they have become a little cheaper. So I would see the cost is a big barrier in our subset because somewhere we fail to outlook, we don't foresee how much we can cut down in the terms of mortality if we look at the complications, the mortality burden because of the cardiovascular, renal failures, even the obesity per se. If we calculate the long-term expenditure on health and with the short-term calculation of the cost of the medication, and if we try to explain, then we might use it on a wider aspect. Secondly, the side effects, the GI side effects are there. Somewhere I feel the counseling should be more, we can give shortcuts how it can be mitigated because in my OPD I see a lot of patients deferring the drug because of GI side effects as well. But they can be mitigated and definitely few will be left out. So I feel cost and side effects become a barrier in our subset.
The other point is I would say that most of these are injectable. So that again is a deterrent, and furthermore the combinations are not available. Of those which are available as oral pill, semaglutide is now available as an oral pill. But you have to go very slow and then raise the dosage depending on, and then the inhibition that it has to be taken as the first pill in the morning along with 120 ml of water. So these things are a caveat which perhaps a physician also feels that it would be very difficult to administer to a patient. So these things in the mind, whether it be physician inertia or in the minds of the patients, their affordability are slight deterrents which would come to this.
Yeah, so I agree that if we look at these two molecules which have been talked a lot since last 4 to 5 years, if we look at India, the SGLT2 inhibitor prescriptions have gone very high. Everybody is prescribing SGLT2 inhibitors, right, for the management of diabetes. Because it is just a pill, easy to prescribe. On the contrary, GLP-1 requires some efforts, some training, some education, diet discussion, adverse effects management, etc. And that's how there are so many barriers here. So there is a tremendous scope for improvement. Anyone from the delegates, any questions from your side will be most welcome. Anybody want to ask any question? Any comments, any questions? So now we are talking about metformin a lot, but one molecule I would like to discuss now from you. Let's start with again Dr. Ghanshyam, and then I will request all of you to give your comments. What about glitazones?
Glitazones is a really very good drug. In fact, whenever you will not able to control blood sugar, and think about glitazones, especially again the thin persons. Sometimes they want to gain weight also. Although there is no one is promoting, so people are not writing this medicine. But if you go the chart of WHO recommendation for poor patients, especially in poor country, third world countries, so you have to add pioglitazone before adding insulins or any other medicine like GLP-1 or SGLT2. So this is the good combination, adding pioglitazone after sulfonylurea and metformin. So patient are doing absolutely, but you have to just rule out CHF, or the patient is gaining too much of weight, then you have to stop. So few precautions you have to take in these patients. But I am writing quite a lot this pioglitazone.
So, if we look at this year's American Diabetes Association 2025 guidelines, they have brought the glitazones, pioglitazone up, particularly in the patients who are having MSLD. Specifically, they have created an area for GLP-1 receptor agonist as well as pioglitazone. So what do you think? And how often we see, though I understand that we are not doing any liver biopsy or those testing to prove is the patient is having steatohepatitis or fibrosis is ongoing. But very common with type 2 diabetes patient coming to you with a moderate fatty liver kind of thing, some elevation in liver enzymes. This population also we come across a lot of patients such coming into our OPDs. So what do you think about the pioglitazone class in such patients? Any other comments from anybody else?
So definitely pioglitazone or the glitazones work very well with the insulin resistance. The mechanism of action is such that they have shown promising action in reducing the liver fat. And definitely if we omit out the side effects, if we choose correctly the patient, especially we have to rule out the geriatric population because they have certain side effects in terms of glaucoma, increased fracture risk, and the pedal edemas. And if we look at the patients, younger crowd, which are thin, as sir has rightly said, we can definitely use them, and they do very well with the insulin resistance phenotype. And we would all agree that some patients, even if we give insulin, metformin, still we fail to achieve the glycemic target. And if we add these glitazones, we can achieve those targets because they kind of act as a catalyst to the insulin action, and definitely they have proven results as well.
I would say that they are a perfect add-on as far as insulin resistance ma'am has already talked about. The only bad thing has been that it has been in and out for all the good and bad reasons. There has been negative publicity against these molecules. If I were to use, I would say that it can be added on at any stage of diabetes and be used in patients who have insulin resistance, and it can be combined initially with metformin. Only in patients with heart failure you have to be very cautious, especially class 2 NYHA onwards. Otherwise, if we were to see even in obese, it has a action whereby it would move the reduce the visceral fat and increase the subcutaneous fat. So the weight gain also is either because of fluid retention or the shift of adiposity from the visceral to the subcutaneous. And that's why its role comes in NFLD also, whereby it has been shown to not only reduce steatosis but also has certain effects in reducing the inflammation in the liver tissue. So that's why NFLD, it has got a role, and I would say
I think most of the points have been taken up with pioglitazone. It's a very good drug, a very good HbA1c reducer. Number 2, it is quite cheap, so can be prescribed to a population where the affordability is an issue. Third important thing is that it has got an effect on MACLD, a very good drug which can be used in patients with type 2 diabetes and MACLD. Fourthly, it has also CV protection effect. I think this is something that we miss. Just because of heart failure does not mean that it has basically an should not be prescribed in heart patients. It is shown to have anti-atherosclerotic effect. It has shown to reduce the incidence of strokes. Remember, strokes are also atherosclerotic. So those strokes, ischemic strokes, have been reduced even in pre-diabetic population. So now all patients who have stroke should be on pioglitazone to reduce the second incidence of stroke. So this is a very good indication that we seem to miss, that pioglitazone as an anti-atherosclerotic agent to reduce the cardiovascular risk. So these are some of the important things, and I think most of the panelists have already discussed the rest of the issues.
So basically, metformin is a good drug. SGLT2 inhibitors are good drug. Somehow, for years, pioglitazone had got a flag as if it is a very bad drug. And that's how most of the newer physicians who are working in last 8 to 10 years, because lot of negative things about pioglitazone, but once the understanding about the MASLD, visceral adiposity consequences, some newer data including IRIS trial in the stroke, pioglitazone and atherosclerosis, these information is coming. It is relevant to our population because we have talked in many presentations about the thin fat Indians. where there is visceral obesity, fatty liver, and this is a molecule which works at various genes, activates them, and moves out of the fat from the visceral area, and the fat which is deposited in liver and moves into the subcutaneous compartment, and that's how it is having also a lot of beneficial fats. So what do you think? At present, whatever way we are going to treat diabetes, we are treating diabetes right now versus to next 6 to 8 months later, as we were talking about GLP-1 receptor agonist also, that one, it is injectable, and secondly, it is expensive. Now it is expected that the GLP-1 receptor agonist therapies will become lower priced when they will be once weekly also. Maybe in next few months, like semaglutide is going to be off patent from the March 2026. So what do you think, how the diabetes management overall is going to change in India from once a weekly semaglutide also becomes a low price drug? In addition, we already have SGLT2 inhibitors, we have glucagon, we have all the drugs, and majority of the therapy will come under the possible economy will be such that most of our patients will be able to afford that cost. So one by one I would like to have your comment that how the diabetes therapeutics you visualize is going to change.
So I would say that until now, the armamentarium for treating diabetes was focused on pills. And from pills it went on to molecules, fixed drug combinations of 2 or 3 drugs. And it was focused on insulin sensitizers and
insulin secretagogues.
amongst these we focused on sulfonylureas, metformin and etazoles. And apart from that, in a certain group of inhibitors we worked on alpha glucosidase inhibitors. But with the advent of GLP-1 analogs, there is a new horizon, there is new optimism which would open up, and especially because it would be low priced, once weekly injection would perhaps even then be acceptable to the patients, and the only deterrent would be the incidence of side effects, which if carefully administered would be minimum. So that's how I perceive that GLP-1 analogs would be much more acceptable. They would be able to provide the right kind of transformation without the added risk of hypoglycemias. So increasing slowly the dosage of GLP-1 analogs carefully under the supervision of a well-trained physician or practitioner would be an ideal thing. And the only thing is its misuse, because many of these when they go off patent, the price will be so low that even in the rural population where there will be untrained clinicians, where there would be RMPs practicing, the misuse might increase and that might give a negative risk. So it has to be, when it goes off patent, it has to be very carefully taught to the practitioners how to use, when to use and whom to use, so that they get the right way.
Any other comment?
I think the best combination in the newer times would be when we use a GLP-1RA, an SGLT2 inhibitor and a pioglitazone. This combination has also been recommended by DFAN because it takes care of both the insulin sensitivity, beta cell secretion, as well as the glucose excretion by the SGLT2 inhibitor.
Can I come in with the same question in line that because now we have newer therapies like GLP-1, pioglitazone, we are already discussing SGLT2 inhibitors, AGIs, they all don't give you much of hypoglycemia. So in that background, how relevant is now HbA1c in the changing canvas as far as the diabetes is concerned, number one? And second, can we target a stricter HbA1c in most of our patients like less than 7, because we know that anything more than 5% is also continually directing towards the micro or macrovascular complications. So if we can avoid hypoglycemia, shouldn't we target and break this figure of 7 and target a stricter HbA1c? And then in that case, how relevant, as far as your talk is concerned, CGMS in place, how relevant is HbA1c as of now in today's changing canvas as far as the diabetes management is concerned?
HbA1c around 6.5 or 0.7 is differently good. Whenever we use sulfonylurea, then there is risk of high. So if you are using metformin, SGLT2 and GLP-1, then definitely we can keep HbA1c around 6.5. The thing is that in our population, what we are seeing our patients is different from the Western population. Most of the patients are coming with normal BMI parameter. But as it already reported in many studies and Indian patients having their BMI. Once we start GLP-1 these patients, they will lose a lot of weight. आजकल उनका क्या SGLT2 देते हैं because number of patients जो आते कहते हैं कि डॉक्टर साहब बिल्कुल निचुड़ गया शरीर, बहुत दुबले हो गए. Then we have to stop SGLT2. The same story will also happen with GLP-1. So this is slightly different. Another thing is whenever we start GLP-1, the side effect of GI side is very much. So whenever I start 5 patients, almost 3 patients whatever the reason GI side effect comes. So even the cost reduction will be around 3-4. So 3,000 is not an easy job for
So if you look at the way diabetes is changing, obviously we were earlier on the glucose, then came to the HbA1c, now I told you about CGM, and now we are learning. Then in a subset of patients with HbA1c also there are a lot of debates and issues in HbA1c. And that's how another new concept which is coming, that will be personalized HbA1c. That's how with the help of one CGMS and HbA1c measurement, some calculation, it will be possible to fix up one particular HbA1c for a patient, taking into consideration the glycation rate, because there are high glycators and low glycators in our population. So that's how the HbA1c scenario is going to change. And see, we are a very large country, heterogeneous population, not that everybody is here. And the new generation which is coming with diabetes type 2, a lot of people are getting obesity. So my perception is 2026 March onwards, once a GLP-1 receptor agonist weekly will come at a cost which will be around 25% of the current cost, its uses will go significantly high. Particularly your patients who are on premix insulin can become on basal plus GLP-1. Patients who are on basal insulin not yet controlled well can be added upon a weekly GLP-1. So that's how I foresee that in future this therapy, though it will take time, slowly pick up. And it won't be just an obesity management drug, it will become a very important diabetes management drug in our patients. Let us see what happens. So anyway, any other question? So if there are no more questions,
जनरली जो जब से और ये जो आपके जो उस पे GLP-1 आर के जो एनालॉग्स को जब ट्रीट कर रहे हैं, दे रहे हैं, तो पेशेंट्स का जो जनरल जो कमेंट एक जो आता है बाद में, डॉक्टर साहब आप समझा तो रहे हैं कि हमारा फ्यूचर के लिए अच्छा है, लेकिन प्रेजेंट तो आपने ख़राब कर दिया है, हमारा सब सिकुड़ गए हैं, सब हो गया, ना खाने का मन करता है, ना भूख लगती है, इसमें कुछ करिए।
सो ये इम्पॉर्टेंट है कि आप पेशेंट को पहले प्रिपेयर करें, उनको एक्सप्लेन करें, और अगर आप एक BMI 22-23 वाले से ये थेरापी का बात करेंगे तो मुश्किल है। एट प्रेजेंट इसका मेजर यूज़ कहाँ पर हम कर रहे हैं, जो जिन लोगों का BMI 27, 30, 35, 32, 33, वो लोग तो अभी तक इनफैक्ट कितना सारा वर्ल्ड में जो बेरियाट्रिक सर्जरी, बलून, ये सब धीरे धीरे इन फ्यूचर it seems that the obesity will be treated more by physicians, endocrinologists, diabetologists. At present, we have different kind of population. So you are talking that is one population, but there is other side also. So we have multiple type of patients. So anyway, I hope with this we can end up with this panel discussion. Thank you very much.
chairpersons, and please come on for participation.
Okay. Now, for a wonderful session and this clinical discussion about myths of diabetes in day-to-day life, we move on to another very interesting topic of from sugars to stream, unmasking LUTs in diabetes, by nobody other than our favorite sir, Dr. Diwakar Dalila sir. And I invite our chairpersons, Dr. Arun Kumar sir, Dr. Rajesh Arora sir, and Dr. Manmeet Singh. I also invite our panelists, Dr. Deepak Diwan sir and Dr. Satyen Sonkar sir. I will request Dr. Arun to introduce our
Very good evening. It is a really very interesting topic, from sugar to steam, unmasking LUTs in diabetes patients. Low urinary tract symptoms in diabetes patients is an extremely important topic. I'll see how important this topic is in coming few minutes. We have this speaker in the name of Dr. Diwakar Dalila. He does not needs any introduction in this audience. But just to brief you briefly about this, what he's all about is, he is alumni of prestigious KGMU. He done MBBS and MD. He had done his MCH from SGPGI, and he has almost done more than 2 decades of practice in urology. He has innovated of 19 operative techniques. He is innovator of 5 urological instruments, on which one has been patented also, and he has 1 urological disease innovation from him. He is author of multiple educational books, so many index research papers, and he has also received multiple gold medals and silver medals. And interestingly, he also run a YouTube channel where he uploads all the videos which are of good use for the patient and the doctors. Almost he has got subscriber of 150 subscribers of this YouTube channel.
So kudos to Dr. Dalila, and nothing will start this topic. Start, sir.
Thank you very much. Very good evening to all illustrious physicians here. And outside, I'd like to express my gratitude to my dear friend Dr. Muklesh for having me here. And I understand that we are coming to the end of the program, so I must not be taking very long for you. But I want to assure you that I'll not be talking too much of data. There are no research studies in my talk. It is purely a touch with the basic. So let me first of all explain to you a bit about why do low urinary tract symptoms happen. And since you're all clinicians, I'll only make few clinically relevant points which are good for clinical practice. The lower urinary tract word is used for urinary bladder, prostate and urethra. And when we have symptoms coming from that, we tend to focus only on the lower urinary tract, which is not true. The lower urinary tract symptoms can happen because of more inflow of urine coming from kidneys. It can happen because the bladder storage function is not proper. And then it will also happen because the outflow of urine from the bladder is not proper. So although we say it as lower urinary tract symptoms, the symptoms not only come from lower urinary tract, but they come from upper urinary tract as well. Now in the lower urinary tract, patients only talk about the symptoms of urination, what they experience in the voiding. So for the patient, voiding phase of urinary tract is the most important, because that's what they only see, pissing the urine out, and that's what they will complain. But as a doctor, we should know that Mother Nature has allotted, if I were to sum up for you how many hours, how much time for voiding function of low urinary tract.
Everyone voids about 4 to 5 times in a day. One voiding leg takes about 30 to 40 seconds. So how much is the time we give for voiding function? Not even 1.5 minutes in 24 hours. So imagine, very little time nature is given for voiding function, very big time nature is given for the storage function, and nature is not foolish. Nature wants bladder to store urine at low pressure and go on storing at low pressure so that kidneys continue to drain in the bladder without experiencing any resistance. So kidneys are conserved because of good compliance, good storage function of the urinary bladder, and that when bladder is full, then it empties by contraction, and through that the urine flows out from the urethra. So remember this dynamics. If you want to understand low urinary tract symptoms, you have to understand this dynamic function of the bladder. So the low urinary tract symptoms will happen, friends, because of problems at all these 3 levels. For the inflow, you are physicians, you know, all of you, whenever there is a high urinary output in any individual, there will be frequency. And I don't have to elaborate to you these conditions which produce high urinary output. If the bladder is not able to store urine well, the inability to store, so the urine will come into it and bladder will have to empty. So patient will have frequency. And these things happen because of neurological diseases like Parkinsonism, strokes. This happens because of non-neurological diseases, and this also happens because of the inability of the sphincter to hold. So what is neurological? Parkinson, CVA, head injuries. What is non-neurological is overactive bladder. Then you have inability to empty. The passage, the urethral passage is at the problem, and the patient is not able to empty bladder. This happens either on account of obstruction in the urinary passage, or it also happens on account of the underactivity of the detrusor, the poor contraction power of the detrusor muscle. And so the lower urinary tract all the time is doing storage function. This is called storage phase, and at 4-5 times a day, voiding phase, and patient empties urine. So accordingly, we classified our low urinary tract symptoms into storage phase symptoms, which are called these frequency, urgency, nocturia, incontinence, and bladder pain, and voiding phase symptoms, which means symptoms related to the stream of urine. And then some symptoms experienced after the voiding has finished. That's called post-void symptoms. So there are 3 phases of low urinary tract symptoms, and we should be able to split out these 3 to make a good clinical diagnosis. The point of my talk this evening is, first of all, which low urinary tract symptoms happen due to diabetes, and in the early part of diabetes and the late part of diabetes. Which low urinary tract symptoms happen because of a disease within the low urinary tract, and commonest being the prostate. So I'll take today prostate as an example. So what is due to diabetes? What is due to prostate? And then how do we differentiate? And this is the point of discussion today. When we have a patient who has a diabetes and who has a prostate obstruction also, how do we navigate a clinical judgment as to what is the major contributor in low urinary tract symptoms? Before I dwell further, let me explain what diabetes does to low urinary tract. In the early phase, most problems are only because of the glycosuria, the uncontrolled glycosuria, and some reduction in the immunity of the patient. And this is the polyuria with which the patient will reach you and also us sometimes. But then majority of patients come to us with urinary tract infection, both lower and upper, prostatitis, acute prostatitis, and some patients even develop prostatic abscess. we see them as the first time we see them, and then we do a blood test, and discover that they are having uncontrolled diabetes for a very long time. Sometimes sugar is ranging 400, 500, and then we send patient to our physician colleagues. So early stage is dominantly glycosuria-induced issues. But then, as diabetes stays on in the body, there occurs a state of autonomic neuropathy, and the innervation of urinary bladder is affected. And both arms of innervation are affected, the afferent as well as the efferent. When afferent is stimulated, the sensation of urinary bladder goes down. The patient is not able to perceive a fullness of urinary bladder. And when efferent nerves, the motor nerves are affected to urinary bladder, the contractile function of urinary bladder is reduced. And this persists for a few years, and then later on it gets over and above it, you get diabetic vasculopathy. The blood flow to the urinary bladder is reduced. And this is what we call as
late stage situation, and is known as diabetic cystopathy. And here, the problems are poor sensation of urinary bladder, poor emptying of urinary bladder, chronic urinary retention in some patients, and then, of course, these patients keep coming to us with recurrent low urinary tract infection. So this clinical syndrome is different in early stage diabetes and late stage diabetes. In early stage diabetes, what is the issue? Issue is the patient has come to you with increased urinary frequency, and you are wondering whether this is due to diabetes, uncontrolled diabetes, or this is due to a urinary tract disease such as prostate or even stricture urethra. What we do here, the best way to sort this out is to give the patient this kind of a chart, and this is, we call this as frequency volume chart, and you ask the patient to make it for 24 hours, wherein he will note down the timing of passing urine in the day and the amount of urine voided, and then timing of urine in the night and the amount voided, right? For 124 hours, patient records this chart, and at the end of the chart, you can easily split this. In uncontrolled diabetes, the volume voided every time will be large, close to 300 cc, because the patient is polyuric. If the patient has prostatic disease, the volume will be variable and vary from 50 cc, 70 cc, 100 cc, 150 cc. At different point of time, the volume voided will be different. The time gap between the two acts of urination
for diabetic, for the one who has polyuria, will be reasonably fixed. That means only when the bladder is full, the patient will void, right? So this will take about 2 hours, 3 hours. But in a patient of prostatism or prostatic obstruction or low urinary tract disease, it is because of uninhibited contraction of urinary bladder, what we call as detrusor instability, and therefore the voided volume will be different. And finally, if somebody has pure diabetes, no bladder outflow obstruction, he will not have any obstructive low urinary tract symptoms. But if somebody has lower tract disease like prostate, he will have obstructive low urinary tract symptoms. So only by clinical questioning from frequency volume chart you can know. And then I said, a lot of these patients in early stage diabetes come to us with severe infection, sometimes emphysematous pyelonephritis, sometimes balanitis, sometimes a phimosis skin having changes, posthitis, and sometimes even epididymoorchitis. Some patients even develop infection in the prostate, which is, to begin with, is acute prostatitis, and soon it culminates into abscess. In late stage diabetes, issue in late stage diabetes is, this is the bladder now which is hyposensate and hypocontractile. The patient will first have increase in the frequency and nocturia, and these two things happen because of a large amount of post-void residual urinary volume within the bladder. Patient is only emptying 20% of the bladder volume, rest is retaining. So that's why he's going to washroom again and again. But soon the amount of residual urine will increase and it will become full bladder. And that is a state of chronic urinary retention, and in full bladder situation, patient will have in daytime, overflow incontinence, he will keep his garments wet, and in the night time, he will void in the bed, leak urine in the bed, nocturnal aneurysms. And then he walks with full bladder for a few months. This leads to back pressure effects on urinary tract, and patient's renal failure worsens. He is already having CKD because of diabetes and hypertension. Suddenly you notice his creatinine shot up from 2.5 to 6. So this is what will happen in late stage diabetes, friends. Getting back to what is happening because of prostate in stricture. Now if you see the voiding phase symptoms, these are 7 symptoms which are classically said to be voiding phase symptoms. On that, the one to my side, 1, 2 and 3, hesitancy, slow stream, thin stream, these are more specific for low urinary tract disease, the one for the prostatic obstruction. The one on the other side are not very specific of low urinary tract disease. They can happen because of poor contractile function of urinary bladder. And if I were to explain to you hesitancy, the patient stands in front of the urinal and he is not able to start the act of urination. He has to wait, and after waiting, slowly the stream appears. This is said to be very classical for prostatic obstruction. The second is the slow stream. The slow stream means, often I've seen people using word poor stream, weak stream. The correct word is slow stream. The stream does not have bank account, so it cannot be poor. The stream is not a fighter in the game, so it's not a weak stream, it's a slow stream. And the normal stream has a projection, weak stream has loss of projection. Then some patients have thin stream. Thin stream is thin caliber. Normal stream has a caliber. Thin stream happens in a stricture urethra. So if you see, these 3 types of streams are typical of urinary disease, either prostatic obstruction or stricture. Some patients complain of straining during voiding, which means their stream is slow, but when they strain, the stream becomes better. The stream is slow and strain, the stream becomes better. What are they doing? They are trying to augment the contractile power of urinary bladder by abdominal pressure. So the moment they use abdominal pressure, the stream improves a bit. This is straining during voiding. This indicates poor detrusor function. Then there is an interrupted stream. Interrupted stream means the stream stops. The stream comes, the stream stops. The stream comes, the stream stops. This is interrupted stream. This also happens in some staccato pattern voiding. So out of storage phase symptoms, frequency and nocturia can happen in both prostatic as well as in diabetes. But urgency and urge incontinence is not so common in diabetes. It is, but not so common. Presence of urgency, that means sudden desire to void, and inability to control the urination is typical with low urinary tract disease. So friends, if you go into detail of history of voiding phase and storage phase, you will know what you are dealing with. And if you are still confused, you have to resort to what I call 3 urological tests, and this is urinary flowmetry, whereby we know whether it is a prostatic obstruction or decompensated detrusor. We do ultrasound KUV to see the prostate size, to measure post-void residual urinary volume, to see hydronephrosis. And finally, we do a urodynamic study where we study the filling phase of urinary bladder to determine the sensations of urinary bladder, and we study the voiding phase of urinary bladder to determine the contractile power of urinary bladder. So then comes the question, how do you manage this patient who has both? How do you manage, in general, how do you manage low urinary tract symptoms? And you remember I told you that there are 3 phases which contribute to low urinary tract symptoms. Inflow, so you have to manage all the conditions which can produce high urinary output. Then there is the storage part. You have to improve the storage capability of urinary bladder. And then outflow, if there's obstruction in the outflow, you have to improve the emptying of urinary bladder. So there are 3 targets. In every patient, you will have these 3 targets. Some will be small, some will be bigger. But you cannot cut down the importance of each of this. Let me explain this high urinary outflow. Each and every patient of prostatic obstruction, we tell them to reduce their liquid intake, to reduce tea intake, coffee intake. If they're not suffering from urinary infection, they can easily cut down their liquid intake so as to cut down their urinary output. If there's a problem with the storage, patient's bladder not able to hold urine, and then you have these 3 areas to target. To give you some example about overactive urinary bladder, this is very common in prostatic obstruction. We are using these days drugs which can suppress bladder contractility, and we use fasotyrosine and solifenacine. We use beta-3 agonists to relax urinary bladder, mirabegron and bipegron. Bipegron is available in the US for the last 4 years. It is yet to come in India because of patent issues. And then we use the combination of both these drugs in majority of situations. So with these 2 drugs are very potent drugs to control the uninhibited contractions of urinary bladder and make bladder back stable again so that it stores, right? And there is no urgency and no incontinence. In Parkinsonism, we give these days fasotyrosine because it does not cross blood-brain barrier and there is a lesser risk of worsening the brain function. Finally, the outflow part, and I want you to take a few minutes here. In patients who have inability to empty because of obstruction in the prostate, where if you see only one diagnosis will come to your mind, this is BPH, because patient is old, BPH. But please remember, in prostate there are more diseases other than BPH. This is, some patients have obstruction in the bladder neck. The fibers of bladder neck are more constrictive. Some patients have cancer prostate, and it is your sacrosanct duty to discover that patient is not having cancer prostate. And some patients even have, I showed you, prostatitis and prostatic abscess, very relevant in patient who is diabetic. So if you have to target prostate, we don't claim that it's only urologist's domain to treat prostate. Physicians do treat prostate, and with that intention, I want to touch certain salient points here. If the prostate size is 40 cc, more than 40 cc, you need to reduce the prostatic size. It is only then you give these patients 5-alpha reductase inhibitors, dutasteride and finasteride. I have seen large number of prescriptions where prostate size is 20 cc and patient is taking finasteride and dutasteride. That's not on. If the size is less than 30 cc, you are not looking at reducing prostate size, you are looking at reducing the contractibility of the prostate, the tone of the prostate, the constrictiveness of the prostate. And for that we use these 4 alpha blockers today, tamsulosin, silodosin, alprazosin, and terazosin. And then you have some 4 points to remember. Remember some general points when you are treating prostatic obstruction. First, never begin a pharmacotherapy, which means alpha blocker or dutasteride, finasteride, till you have addressed lifestyle factors. Say for example, liquid intake. Never start pharmacotherapy without considering patients' comorbidities and co-prescriptions, because there are many drugs which enhance side effects. Many patients are on beta blockers, and if you give the alpha blocker, you combine alpha blocker to beta blocker, patient will have a higher incidence of drop in the blood pressure and postural hypertension. Never start antibiotics just because patient is saying I have some burning in urine or I have some pain in passing urine. This does not mean presence of urinary infection. Unless you have documented urinary tract infection by demonstrating both the pus cells in urine as well as the organism in the urine, you do not justify using antibiotics. And finally, please remember to treat constipation. The patient who is diabetic and has fair chance of having constipation, and constipation usually worsens low urinary tract symptoms. Just have to give them laxative, half the problems will be fine. Then specific guidelines. About alpha blockers. Don't choose alpha blocker at random, at your sweet will. Anyone, any of you prescribe. There's a rationale in writing a drug, I will let you know what it is this. Don't combine two alpha blockers. Very often I have seen a prescription, patient using tamsulosin, silodosin both. One in the morning, one in the evening. This is unscientific. This enhances the risk of side effects, not the benefit. When patient complains of frequency and he is not improving, what one tends to do, add antimuscarinic or add
solifenacin very casually or add media background very casually. Please don't do this very casually. Don't start antimuscarinic without checking post-void traceable urinary volume. If patient has more than 100 cc post-void urine in the bladder, and if you add a drug which is antimuscarinic, there is a risk of precipitating acute urinary retention. Never start
alpha reductase inhibitors, finasteride, dutasteride, without checking serum PSA. Because if somebody has a high PSA, you don't know it, and given dutasteride will suppress PSA values, and its future follow-up will be marred. So if you intend to write anybody dutasteride, finasteride, please check the serum PSA. Now about the alpha blockers, there are 3 alpha blockers. You will just remember only one simple thing, the age of the patient. If patient is less than 50 years of age, give alfuzosin. Patient is 60 years of age, give tamsulosin. Patient is more than 70 years of age, give silodosin. Now why do I say that? Alfuzosin is a drug which protects ejaculatory function. A man less than 50 years is expected to be sexually active. So give him an alpha blocker which does not give him ejaculatory dysfunction. But alfuzosin can reduce blood pressure. Young man can withstand this kind of issue. So alfuzosin therefore is a drug of choice for younger people. For 60 years, when sexual activity is waning a little bit, this drug can be given, very useful, very effective, it is economical. Silodosin is safe drug for the heart. For somebody who is more than 70 years and has diabetes, he is likely to have heart diseases, and you want a drug which is cardiac safe. Tamsulosin causes tachycardia in some people, but silodosin will not cause tachycardia. So if you remember just the age, you will know probably everything. And finally, when the patient is under you for treatment for prostate, you should know when will he need surgical intervention. And this is if he develops retention of urine again and again. The one episode is not an indication for surgery. You can put a catheter, after 4 days remove catheter. But if he gets retention again and again, or he develops
chronic retention of urine and bilateral hydrourinonephrosis with or without renal failure, or if he develops no response to therapy that you are giving, or the patient is not willing to continue long-term therapy on account of the economic factors, or we will bring the patient to you for follow-up. Also, you should know, patient does not need surgery. The patient is with you. You are treating the patient. When should you send the patient for expert opinion? At least once. And this is somebody who has non-responsive urinary tract infection, somebody who has hematuria.
Remember, hematuria is a very serious symptom. It can happen because of BPH. It can happen because of cancer prostate. It can happen because of transition cell carcinoma in the urinary tract, which is it's a killer disease. So hematuria, don't take it as casual thing. Refractory urinary retention, and of course anybody who has a high serum PSA must be sent for specialist evaluation at least once. So how to manage? Then is the issue of diabetes. Other part. Remember, in diabetes, what happens is when this bladder is not very full, it has its microvasculature like retina. It has artery, veins, arterioles. When bladder, this is the way the circuit is. When bladder gets over-distended, because of high intraluminal pressure, the perfusion of the bladder wall becomes weak. Because of stretch, the capillaries become thin. The resistance of blood flowing through the arterioles and capillary increases. So the bladder gets poor perfusion, and over and above autonomic neuropathy, a vascular insufficiency sets in. A bladder which is full to this much, when it is full to oversize and overfull, and it remains like that for a long period of time, a persistently stretched detrusor muscle leads to chronic detrusor ischemia, and that is why the bladder function goes off. So with that background, then there are 4 considerations for managing diabetic cystopathy also. First of all, what you need regular bladder decompression. If you give a drug, alpha blocker or something, and bladder empty only 50 cc, 30 cc, still large post-void residue is present, the bladder is not getting chance to get reperfused. So it will not improve in the function. Therefore, what we as a urologists feel, the best way is to do clean self-intermittent catheter. Put catheter in the bladder, drain the bladder completely. Sometimes we use cholinomimetics, bathenacol, of late, ecotiamide is a drug that is used for enhancing colonic contraction in diabetics. And we also found this enhancing bladder contractility in patients with diabetic cystopathy or those who have large post-void urinary volume. Regular bowel care is very important, and in some patients, to enhance bladder perfusion, along with complete decompression of the bladder intermittently, there have been some trials of the use of tadalafil to increase blood flow to the bladder body, the bladder muscle, so that bladder contraction power comes back to normal. So, but if you see out of all the 4, which is the most effective strategy is to put a catheter in the bladder and drain it completely once and remove the catheter and then allow the bladder to fill up, put the catheter again. 4 times a day, put in catheter. So friends, final picture, when you have one over the other, diabetes and BPH, you can sharpen your clinical judgment to give your patient the best he deserves. And what you should do, if you have a diabetic male coming to you who has low urinary tract, less of storage, more of voiding. S plus, D2 plus means storage symptoms less, voiding symptoms more. Then, and if he has early diabetes, please only correct his glycosuria. Right? And here I want to give you a word of caution. I just heard you talk about SGLT2 inhibitors. And if the patient has history of urinary tract infection, or if the patient has phimosis, please be careful in giving SGLT2 inhibitors because patient will have prepucial infection. The urine rich with sugar will collect underneath the prepuce and will end up in severe fungal infection. And I have been treating. I've been getting UTI, my colleagues, Rajesh will agree with me, Manmeet will agree with me, that because of the use of SGLT2 inhibitors without a thought that it can lead to enhancement of urinary infection, it has suddenly pumped in lots of urinary infection in our clinics. So that's a dental request. You have to use it. Please ask, can you pull back your prepuce? Don't have to examine it, but you can ask the patient. Patient says, yes, I can pull back my prepuce, it's fine. Have you ever had urinary infection? No. Just 2 questions, and then you are fine. If the symptoms persist after control of glycosuria, then is the time to think about presence of prostatic obstruction and order these 3 investigations. And I am here recommend to you testing serum uric acid levels. Because my feeling is uric acid leads to uricosuriya, makes urine acidic, more crystal urine, and patient gets more frequency urgency and dysuria sometimes. And PS of course. Here, if the prostate is less than 30 cc, post-void urine less than 50 cc, PSA less than 4, you are perfectly authorized in using alpha antagonist as per the age. But if the patient has prostate more than 30 cc, PVRU more than 50 cc, PSA still 4, less than 4, use 5-alpha reductase inhibitors with alpha antagonists. Right? So that's the way you can go in patients who have early stage diabetes. But if patient has a late stage diabetes, upfront, on first visit, advise ultrasound. Because here you are looking for a large post-void urine in the bladder, a thinned out stretched bladder which has risk. Upfront, look for serum creatinine PSA on day 1. And if patient has significant post-void urine, but not too much, less than 150 cc, bladder wall looks thin on normal on ultrasound, prostate is small, PSA is normal. Here is the case where you can give bathenacol and ecotiamide. But if patient has large post-wide urine more than 200 cc, bladder wall has become very thinned out, prostate is large, PSA is fluctuating. This is the patient you need to refer to us for more management. So thank you very much for your question.
If there are any questions, I'll be happy to answer. I would like to have views from my very able colleagues of mine here, Rajesh Arora and Manmeet, very senior urologist in the town. You want to add something to something you said, or you have your experience about it?
It was an excellent presentation and nothing to be added. All the clinical queries has been answered. And what we see in normal clinical practice is most of the patient in age group of above 50, they present with, especially with diabetes, and they present with frequency and urgency, a very common symptom. And so many times we are confused this as a clinician. We think that it is frequency and underactive diabetic bladder. So in those patients we have to be very careful, and we have to advise, as Dr. Danila mentioned, that ultrasound KUB and post-Valdezol is very important before giving this anti-muscarinic or this solifenacin or mirabegron, because if PVR is high, then if especially more than 100, then patient may go into the retention. So we have to be very careful in such patients.
Definitely, Dr. Dipankar has a flight, so we can carry on the questions.
So this was, yes, you are teacher par excellence at the site, and this was the first time that we have witnessed you speaking. As physicians, we don't have the chance. Excellent lecture.
Thank you.
I think a loud round of applause for him. It was a brilliant exposition on this subject. But because paucity of time, because Dr. Shubhankar has a flight, so we'll move on further.
Thank you very much.
Thank you so much, everyone.
Thank you very much. Yes.
On the chairperson.
For the moment. And without wasting time, I would invite Dr. Shubhankar Chaudhary sir for a lecture on bone health and diabetes. And as chairperson, we have Dr. Pooja Dham, Dr. Dinesh Karwani, and Dr. Adarsh Srivastava. As panelists, we have Dr. Shishir Upadhyay and Dr. Arpita. I will request Dr.
Pooja to please introduce Dr. Shubhankar.
Good evening. It is my privilege to introduce the speaker, though he does not require any introduction, formal introduction. He is Dr. Shubhankar Chaudhary, at present the Director, Diabetes and Endocrinology at Medica Super Specialty Hospital, Kolkata, and former Professor and Head of the Department of Endocrinology, IP, Jimmer and SSKM Hospital, Kolkata. He is the present President of the Endocrine Society of India, Editor-in-Chief of Indian Journal of Endocrinology and Metabolism, and also a member of some important committees. Also holds some important official positions related to endocrine societies and some ethical committees, with lot of publications, over 230 publications in peer-reviewed journals. So over to you, sir.
Thank you, madam, for those kind words of introduction. And first of all, congratulations to LDSSCON 25 Organizing Committee for a wonderful program, very well executed. My personal thanks to Dr. Awasthi, Dr. Mukulesh Gupta, Dr. K.P. Chandra for providing me this opportunity. Now we know about the chronic complications of diabetes. We have talked a lot about micro and macrovascular complications. Subsequently, over the last several years, we are talking about MASLD, liver being affected in diabetes. And now I think it's a time also to talk about relatively silent complications of diabetes, which is to do with bone health. So what I shall try and do in the next 20-25 minutes is to try and address these issues. First, is bone health different in diabetes from non-diabetes? If it is, whether it's type 1 or type 2 or it's both, what is the prevalence of this problem? What are the outcomes? If someone gets a fracture, he's got a diabetes, is it different? And if there is a difference in bone health between diabetes and non-diabetes, do we understand why? Is there any effect of anti-diabetic medications? We have had reference to bone health even in the morning with Dr. Vinal Mohit when she covered the ADA guidelines. But how do we assess bone health? Is it any different in diabetes? And finally, management of osteoporosis or poor bone health in diabetes. Are there any special issues? So first of all, fracture risk in diabetes, is it different? There are a large number of studies. I have here quoted a sort of community-based, population-based study, but which covered 65 lakh individuals, followed up about 6.5 years, included type 1 diabetes, type 2 diabetes, and of course non-diabetic as well. And the clear picture that emerged was that fracture rate is higher in those with diabetes. The risk is increased by about 32%. Is it different between type 1 and type 2 diabetes? Yes, the risk is much higher in type 1, about 99% higher in type 1 diabetes. And the risk is higher at all sites, especially so for hip fractures. An interesting observation, this is from a study in Canada, which suggested that while in type 2 diabetes also there is increased risk of fractures, but this pertains especially to those who have longer duration of diabetes, typically more than 5 years at least of diabetes. And for newly diagnosed type 2 diabetes, there was an observation that probably the fracture incidence is lower. We do not understand exactly why. And so what are the diabetes-related risk factors? One, of course, is having type 1 diabetes. And if you have type 2 diabetes, longer duration of diabetes, poorer control of glycemia, which stands to logic. HbA1c, the higher it is, the more the risk. And those who also have either microvascular or macrovascular, especially the microvascular complications, and in relation to treatment, certain agents, especially thiazolidine diones, we shall come to that later on. Now, if someone with diabetes has got a fracture, are the results, the outcomes, any different from in those who do not have diabetes? The answer is yes. They tend to have worse prognosis, longer hospital stay, and even higher mortality because of mechanism that we can well understand diabetes being associated with more infections, poor wound healing, higher cardiovascular events, and so on. So once you have diabetes, you have higher fracture risk. Once you have a fracture, you have worse prognosis. So these are the ones that we can take home straight away. And on top of that, vertebral fractures, at least in type 2 diabetes, has been shown not only to predict risk of other fractures, non-vertebral fractures, but also to predict overall higher mortality. So looking for fractures in diabetes possibly can also give us a clue as to the ones who are more likely to to go on a poorer downhill course than others. So how do we assess bone health? Well, essentially we need to look at bone strength. Now that depends primarily on bone quality and bone quantity. Now what we do most commonly have recourse to is to measure bone quantity by bone densitometry, BMD, bone mineral density. DEXA, dual energy absorptiometry, is the standard method these days. And this fortunately does explain almost 70% of the bone strength. And if you look at the BMD scores, type 1 diabetes clearly has low BMD. If you look at the use the point. Right. So this diamond is clearly to the left of the 0 mark, suggesting that there is clearly lower bone density in type 1. In type 2 diabetes, however, interestingly, intriguingly, the bone density actually is somewhat higher, 5 to 10% higher BMD in type 2 diabetes compared to non-diabetes. But we did commit that even type 2 diabetes have got higher risk of fractures. So why is it that despite having a higher bone density, type 2 diabetes also has higher risk of fractures? Well, so BMD is lower in type 1 than type 2. However, both type 1 and type 2 diabetes have higher fracture risk. In type 2, likely the reasons are related to poorer bone quality. So we talked about quantity in BMD, but bone quality is poorer. The microarchitecture is poor. There could be cortical porosities. And there is also more propensity to falls and the use of drugs like isolidindiols, which all explain the high risk of fractures in type 2 diabetes, despite a higher bone mineral density. So we shouldn't get carried away by BMD alone in type 2 diabetes. I don't think we need to go into the details of this slide, which tries to sort of tell us what are the different factors, how bone health will be affected in diabetes, hyperglycemia, increased adiposity, increased inflammation, and also the low insulin level, especially in type 1 diabetes. All of these could lead to poorer bone health. We won't go into the details of that. So what we do understand is in type 2 diabetes, BMD measurement clearly underestimates the risk of fractures. However, within type 2 diabetes, BMD still stratifies fracture risk. So those who have lower BMD tend to have high fracture risk compared to those who have higher BMD. So the other quantity that we were talking about apart from bone quantity is bone quality, and there are different ways to assess which are not very commonly done. One is the most commonly available is TBS, trabecular bone score. So this, and there could be other ways by doing a quantitative CT scan or biopsy with a bone histomorphometry, which are all difficult, but we can just talk about trabecular bone score, which gives us an idea of how the trabeculae are disposed in the vertebrae especially. This just requires an extra software, which is however quite costly, and this could be used on previously done bone density if you have the records on a machine. So TBS could be one way of assessing bone quality, and patients with diabetes have significantly lower trabecular bone score than those without diabetes, and trabecular bone score clearly outperforms bone density. So these are bone density measurements which would suggest a lower risk of fracture. Whereas if you look at trabecular bone score, it clearly shows higher fracture risk in diabetes. So beyond BMD in diabetes, probably trabecular bone score is something that we could also assess if we have the facility. And then finally, of course, what we need to know is bone strength. What we have been doing is beating around the bush. We have not We have tried to assess bone strength from bone quantity and bone quality, but now there are methods available, finite element analysis and micro-indentations and indentation studies, which of course are not yet in our clinical realm, they are still in a research area. So when we assess the fracture risk, it's not just bone density. Today we have access to this software, to this app, the FRAX score, and we have India-specific FRAX score calculator as well, for which you have to put in data like age, sex, weight, history of steroid intake, history of alcohol intake, tobacco, so on and so forth, previous history of fracture and so on. And then you can put them down and you can get a fracture risk at the total hip, at the hip or in the osteoporotic, major osteoporotic fracture risks. However, in these various inputs that we've got, diabetes is not a direct input to the FRAX estimator. So what it has been suggested is that we could get around it by either one of 4 different methods. One is when you are inputting the age, increase the age by 10 years instead of 60, right, 70. Then that may be correcting for the higher fracture risk that we see in type 2 diabetes. Or you may tick the rheumatoid arthritis box. There is a box for rheumatoid arthritis which is associated with higher fracture risk. Diabetes doesn't yet appear there, so you tick that box and so have a higher weighted evidence for diabetes causing fracture risk. Or reduce the femoral neck T-score by 0.5 or use trabecular bone score adjustment to FRAX. For this, there is a higher version of FRAX, FRAX Plus. However, this is a paid app as of now. FRAX is not a paid app, and here you can put in inputs of diabetes or trabecular bone score and so on and so forth. However, for most part, we have to be satisfied only with bone density and make our own adjustments to this bone density measurement. Now, what about the effect of anti-diabetic drugs on bone health? If we could sort of look at the fracture risk, this is the last column. What we see is thiazolidinediones stand out as being associated with increased fracture risk. Sulfonylureas are sort of plus or minus. Insulin, surprisingly, has been associated with higher fracture risk in type 2 diabetes. I feel this is not a direct effect of insulin, but reflects that insulin-treated individuals are the ones who are longer-standing diabetes, poorer controlled diabetes, diabetes associated with various organ dysfunction. So this probably reflects those other conditions rather than just the fact that they were treated with insulin. So, but thiazolidinedione clearly has been shown, and for us it's pioglitazone only, which has been shown to be associated with lower bone density measurements and higher fracture risk in women in particular, not quite in men very strongly, though there is evidence that even in men the BMD tends to be lower, and there is some suggestion that in men above 50 also the fracture risk is higher with thiazolidinediones. So in terms of bone health, I think despite all the good things that we know of pioglitazone, possibly we need to be cautious about its use, especially in post-menopausal women with type 2 diabetes. And then about management overall, as in osteoporosis, even in non-diabetes, look at calcium, look at vitamin D, adequate calcium and vitamin D, and also active lifestyle, enough exercise, not only aerobic exercise, but also muscle building or strength building exercises are important, limiting alcohol, and fall reduction strategies are also important in reducing fracture. What about the use of anti-osteoporotic drugs in diabetes? Do they fare any differently from non-diabetes? Well, this is a good meta-analysis which is looked at almost 95,000 individuals, of which only a small fraction had diabetes, about 7% had type 2 diabetes, from various trials covering bisphosphonates, selective estrogen receptor modulator like raloxifene, menopausal hormone therapy, denosumab, and odonacatib. Of course, odonacatib is not available in our country. So overall, it was found that there is no difference in the response rate between diabetes and non-diabetes. Similarly, if you look at the bisphosphonate studies separately, again there was no significant difference. However, if you look at the denosumab study, denosumab incidentally is one of the newer anti-osteoporotic agent that is available to us and which is very effective in improving bone density, reducing fractures. But in type 2 diabetes, it's been found, at least in the first 3 years of this usage, there tended to be higher non-vertebral fracture risk in type 2 diabetes, whereas it did perfectly well in non-diabetic. However, when we looked at the 10-year extension phase of this study, once again there was no difference between diabetes and non-diabetes. So overall, if we are looking at which anti-osteoporotic treatment to use in diabetes, probably it's better to fall back on our age-old bisphosphonates, whether oral or intravenous, as either of them have been shown to be quite effective. And then we all know that sarcopenia is a major issue in our country, not only visceral obesity, but sarcopenia is important. Assessment of sarcopenia and its management, which has to go with adequate protein, also adequate exercise programs, which will include resistance exercise training as well, not just a simple aerobic exercise, which should help us have a better role for people with type 2 diabetes. So, type 2 diabetes and osteoporosis are likely to conclude by suggesting that it could be managed as elsewhere with lifestyle intervention first, limiting alcohol intake, with smoking cessation, and adequate exercise, not only aerobic but also resistance exercise, adequate calcium and vitamin D. In terms of treatment of hyperglycemia, possibly avoiding thiazolidine diets, especially in postmenopausal women, is important. And in terms of, we also need to treat the other comorbidities, and in terms of treatment for osteoporosis, probably bisphosphonates are to be considered over others, especially denosumab. So with these, I would like to conclude and thank the organizers once again. And if you have any questions, I'll try and answer. Thank you very much.
Sir, I have a question. Sir, is the management of osteoporosis different in patients with type 1 and type 2 diabetes? That is one. And what is the role of therapeutics in management of these patients?
Right. So first of all, for type 1 diabetes, osteoporosis is more common. One of the best things, the first thing to do their insulin actually is helpful, protective. Is an anabolic hormone, and getting the glucoses under control would be the first step, and thereafter the management principles are generally similar to non-diabetic or even to type 2 diabetes. The other question was exactly, I did not hark upon teriparatide, partly because the meta-analysis that we looked at had very small number of individuals on teriparatide. However, if you look at the bone health in diabetes overall, one of the major pathogenetic mechanisms is low bone turnover. And teriparatide is a bone forming agent. The others are anti-resorptive agent. So theoretically, teriparatide should have a better, bigger role in type 1 diabetes, but we do not have enough number of, a large number of studies or large number of people in the studies to actually make this recommendation yet.
What about these patients? Because you will be using bisphosphonates for a long time.
Yeah.
So what is the present situation for these drug holiday?
Right, so what our chairperson madam was suggesting is drug holiday in osteoporosis management. The concern comes from the fact that long-term use of bisphosphonates, not only bisphosphonates, even for denosumab, has been shown to be associated with increased bone density, but once again making the bones more brittle and a risk of atypical femoral fractures. The other concern, of course, is also related to osteonecrosis of the jaw. In practice, so general current recommendations are that you can continue oral bisphosphonates once you start for 5 years, even up to 7 years. If you're using intravenous zoledronic acid once a year, possibly use it for 3 years, maximum up to 5 years. Thereafter, there is a suggestion that you provide a drug holiday and then you follow up, you look at bone turnover markers, and then when the turnover markers once again start to go high, then you reinstitute treatment. And that again, there is no different recommendations made in diabetes compared to non-diabetes.
There is a slight decrease in the bone density. So, is there any study where we can use the combination of denosumab and anti-resorptive agents together in these patients?
Absolutely. There are studies currently available which show that combined use, in the past it was a no-no. We do not combine the two, it does not give any advantage. Now we have evidence that if we combine the two, the bone density at the end of 1 year has been shown to be better. What we do not have data on is whether this actually translates into lower fracture risk, which we have to wait on. And denosumab, I'm sure others, physician colleagues in the audience would also know, despite it being such an effective agent, once you stop, your bone density tends to go down very quickly and your fracture risk tends to go up very quickly. So once you've started someone, possibly we need to counsel that this is not for short term, this is long term. And after 10 years data, at least for denosumab, is available to suggest that it does not increase significantly the risk of atypical femoral fracture. So after 10 years possibly can use. But once again, in the lifetime of an individual, if you start someone at 65 years, today people are living to 85 years. So what happens after 10 years, I think it's still up to a discussion with the patient and the clinical condition. There are no guidelines to guide us there.
Thank you, sir. And I request any questions, more questions from the audience.
A very nice explanation, sir. I just wanted to know what's the mechanism of decreased bone mineral density with pioglitazone? And is there any intervention that we can do to counteract that mechanism so that we can continue with pioglitazone without worrying too much about the osteoporosis?
Yeah, again, that's right. There are a number of mechanisms suggested. Possibly the easiest to answer is that pioglitazone acts on the mesenchymal progenitor cells, which give rise to both adipocytes and also to osteoblasts. So there is differentiation along the adipocyte pathway, so there is sort of shunting away from osteoblasts. So there is less bone formation. That's possibly the most commonly touted reason for pioglitazone-induced bone impairment. As to how best we could mitigate the condition, of course, adequate calcium, vitamin D, exercise possibly could help, but we do not have evidence that works. And really, I would have been very happy if I could have continued pioglitazone for no number of patients, especially women. I tend to stop them beyond their menopause, despite having good control, and thereafter you have to struggle with other agents in order to get the glucoses under control. But that's, and sometimes we need to continue with discussion, with documentation that we have discussed, and then we still will continue.
Rank ligand activity is modified by the pioglitazone. It is other theory supposed to cause the osteoporotic, increase the osteoclastic activity, cause the osteoporosis.
Thank you so much. Thank you.
So we end the session here and over to the organizers.
Thank you, Dr. Shubhankar, and thank you all chairperson and panelists. Please proceed on the right side of the dais for your. So now shifting gears from diabetes to thyroid. Rather a combination of diabetes and thyroid disorders, and to speak about this topic, we have our eminent speaker, Dr. Robin Maski, who has come all along from Dharan, Nepal, to just give his lecture. So it would be going to be a very wonderful lecture, though it's a last session and everybody's eyes are on the back, but still I think Dr. Robin will keep you warm. So for this session I would invite Dr. Shivam Verma and Dr. P.K. Pandey sir as a chairperson, and Dr. M.C. Srivastava sir and A.C. Rastogi sir for panelists. Dr. Robin. I would also request Dr. P.K. Pandey sir to please introduce Dr. Robin Maski.
Hello. I'm pleased to introduce Dr. Robin Maski from Nepal. He is Professor, Department of Internal Medicine, VPKIHS, Dharan, Nepal. He has published 112 research papers. He has written 10 chapters among various books. His research area of research interest is diabetes, thyroid, renal, and reproductive endocrine. His present designation is HOD, Professor and HOD Internal Medicine, PKIHS, Nepal. His current affiliation is Executive Board Member, Internal Society of Endocrinology. He is Editor-in-Chief, Journal of Need. He is currently President, Diabetes Nepal, Dharan Chapter. He is past President 2024.
Thank you, Chairperson, for nice introduction.
And at the outset, I would like to
congratulate LDSSCON team and especially thank KP Chandra, Dr. KP Chandra, Dr. Nitin and Dr. Mukesh and all organizing committee for inviting me to this conference. So the topic given to me today is diabetes mellitus and thyroid disorder, a dual endocrine dilemma. So I am from eastern part of Nepal, you can see there. From Dharan, the BP Koyal Institute of Health Science, and it was Nepal-India partnership project since last 30 years. So it's in eastern part of Nepal. So these are my outlines of my talk today. So since the topic was given to me, so are you aware like the term diabetes and thyroid was coined even before the use of insulin? So you may be surprised. So it was published in 1920, the thyroid diabetes term was published. So it was even before the discovery of insulin. Now the term called dual endocrine dilemma is coming. So why this is the term dual endocrine dilemma? Both these glands are endocrine glands. So I will be discussing why is the dual endocrine dilemma in the
subsequent slide. So before going to that, let's see the prevalence of thyroid dysfunction in patients with diabetes mellitus. So this is the prevalence in type 1 diabetes. You can see around 70 to 30% with autoimmune thyroid disorder and type 1 diabetes. Risk factor for autoimmune thyroid disorder is all are aware, like female sex, when the patient have TPO antibody positive and more duration of diabetes, and risk of
hypothyroid children with type 1 diabetes is more as compared to adults is around 25%. And the risk factor of hypothyroid children is usually because of poorly controlled diabetes. Regarding the prevalence of diabetes in type 2 diabetes, it is quite lesser than of type 1, is 6 to 20%. And risk factor is same as that of type 1. And risk factor of hypothyroid type 2 diabetes more than 65 years age is more common in female, and it is more common in non-obese, but it is more in TPO antibody positive patient if the patient have hypothyroidism type 2 diabetes. And risk of subclinical hypothyroidism type 2 diabetes is 10.2%. So these all are the Western data. And when I Google like the study of thyroid and diabetes in India, you can
see the prevalence around 18 to 29%, and most are subclinical hypothyroidism. And when I see Google in Nepal, it was around 36%. So it is similar to the Nepal and India, the prevalence is similar, and the most common is subclinical hypothyroidism still. So I am proudly like to share you my reference given in Williams textbook of endocrinology in the Southeast Asia edition, thyroid disorder, South Asian perspective. It was written by our Professor Ambika Gopal Krishnan sir, and he has quoted the article which I have published. The prevalence of hypothyroidism in type 2 diabetes only 4% in Nepal. So this was the study which I have done in Nepal, and we found that the prevalence of hypothyroid diabetes was 4%. So now the term comes, why there is a dual endocrine dilemma between the diabetes and thyroid gland. And what? Because it is not a dual endocrine dilemma, these are the similar organs. They have both etiological similarity and they have similarity in
various forms. Like these are both endocrine organs secrete the hormones. They have the contributing factors for both the endocrine glands are autoimmunity, and the genetic
factors are responsible for the pathophysiology. So they are both linked pathophysiologically. So if you see this cartoon, it is quite complicated, but I will make it simple. So whenever we have a appetite, so it all depends on the appetite which we have distinct since morning. So the appetite is controlled by the paraventricular nucleus and ventricular nucleus in the hypothalamus, and this depends on the food intake. And glucose and lipid metabolism is targeting all the organs like liver, white and brown adipose tissues, pancreatic beta cell and skeletal muscles. So how does this thyroid gland help in causing the pathophysical link between this diabetes and thyroid? So you can see in this cartoon that the thyroid gland have effect on the increasing glucose output, increasing gluconeogenesis, all these factors. And white adipose and brown adipose tissues, also the thyroid hormone receptors are active on that, and the active hormone like T3 helps to increase lipolysis, increase thermogenesis, increase expenditure, and likewise the beta cells, the thyroid hormone receptor will act on the beta cells, and it with the help of MAFA and cause the metacell maturation and increase insulin secretion, thereby cause the increased glucose absorption, increase insulin production. And in the muscles, it also acts by secreting the adipokines and myokines, the T3. So basically there is the control of hypothalamus pituitary thyroid axis from the hypothalamus, and thyroid hormones, the neonatal endocrine, the neonatals have the beta cell also, and they are equivalent to the thyroid hormone receptors. So all are causing the synergistic action with the diabetes and pancreatic glands and the thyroid glands. So these are the effects of thyroid hormone and glucose metabolism. It acts on the intestine, liver, pancreas, and all leads to the hyperinsulinemia and glucose intolerance, thereby causing the peripheral insulin resistance. So I told there are some genetic factors associated between the diabetes and thyroid. So if you see the confirmed joint susceptibility gene, there are the various genes, mostly the class 2, HLA class 2 genes, and CTL4. CTL4 genes are associated with type 1 diabetes. And that's why these CTL4 genes are associated with type 1 diabetes and thyroid disorders. Likewise, the candidate susceptible genes are there, lot of list you can see here. But in Asian, if you have to see, the PTN is responsible for the link between thyroid and diabetes. So what is the link of autoimmunity between thyroid and diabetes? So as you have heard, in the today ADA update of 2025 also, one of the speakers was telling there is a link of autoimmune thyroid disorder with type 1 diabetes. Yes, correct. So type 1 diabetes and autoimmune thyroid disease coexist together. Type 2 diabetes and thyroid disease also coexist together. And both diabetes and thyroid disorder have common comorbidity. So obesity can be seen in diabetes also and hypothyroid also. Weight loss is seen in hypothyroidism also, and if the patient has uncontrolled blood sugar, they come with the weight loss. Dyslipidemia depression can be seen in hypothyroidism also and diabetes also as a comorbidities. So this is, they are interlinked with each other. How does it impact on therapy? I will be going more on the subsequent slide. If you see the diabetes mellitus and thyroid disease, how does it causing the dual endocrine dilemma or causing the interlink between each other, you can see in this slide. So if the patient is diabetes and euthyroid individual, there is a, you can see in this figure, there is a decreased TS response to TRS, and there is impaired nocturnal TSS peak. And they usually present with decreased serum T3 and like the pictures of euthyroid or low T3 syndrome. And if the patient is in diabetes and hypothyroidism individuals, they are, the effect of glycemia is poor glycemic control, and they are more risk for this thyroid optic neuropathy. If you see the hypothyroidism glycemic individuals, they are with glucose intolerance in 50% of cases. Hypothyroidism in diabetes also have deterioration of diabetes control. Hypothyroidism diabetes have leads to recurrent hypoglycemia. And in autoimmunity in type 1 diabetes, we have already seen there is increased prevalence of the disease. So how is thyroid dysfunction related to type 1 diabetes? So it is more common associated with the Hashimoto's thyroiditis, Graves' disease, postpartum thyroiditis, and you must be aware of APS type 1, type 2 syndrome. So in APS type 1, the hypogonadism is there. In the APS type 2, the type 1 diabetes is associated with the hypothyroidism. But it is usually associated with APS type 3. And you can also have co-occurrence between celiac disease and Addison disease. So the key factor responsible for interplay between type 1 and diabetes and hypothyroidism is they are related with the genetic factors in some way. They are common biochemical factors, they are related with the hormonally, they have autoimmunity and clinical overlap. As I already told, they can have weight gain in both hypothyroidism and diabetes and therapeutic implications. So how does hypothyroidism cause hyperglycemia? So whenever there is a hypothyroidism, there is increased metabolism, so it causes increased glucose catabolic pathway causing increased lactate formation, lipid catabolic pathway causing NAFA hormone sensitive lipids are stimulated causing NEFA, and there is a increased glucose output liver and causing hyperglycemia. So whenever there is a high prevalence of hypothyroidism, type 2 diabetes, there are similar symptoms as I have already told. If there is a poor glycemic control, patient can present with the weight loss, and also with the hyperthyroidism they can present with the weight loss. If the patient has hyperthyroidism, with the diabetes, they can land up with the decay, diabetic ketoacidosis. They are more risk for cardiovascular risks, and they also mark the thyroid symptoms in the severe hyperglycemia patients.
and poor glycemic content on hypothyroidism leading to diabetic ketoacidosis. And hypothyroidism type 2 diabetes are more prone for metabolic syndrome increased cardiovascular risk because of increased insulin resistance. So what is the key responsible factor or what is the key link between hypothyroidism diabetes in nutshell? So it causes a decreased beta cell mass, increased insulin resistance, there is a clinical overlap, and regarding the therapeutic implication we will be dealing with the subsequent slide. So in the summary of both hypothyroidism and hypothyroidism diabetes, both have a clinical overlap. Obesity, distributed depression is seen with both hypothyroidism and diabetes. Autoimmunity is seen with type 1 diabetes and thyroid disorder. We can also see the poor glycemic control and hypoglycemia can be seen in undiagnosed thyroid disorder. And how does the anti-diabetic effect on the TSH level is also one of the important factors because the decreased TSH. So whenever the patient is taking metformin and they have a hypothyroidism, you can give metformin that can cause the TSH level and it may decrease the requirement of levothyroxine. They can be the alter absorption thyroxine with other drugs, for example calcium, if we are giving the patient is having diabetic kidney disease and taking calcium and iron, and if you give a thyroxine, they can have an interaction and they don't have a control in the thyroid levels. So relation with the hypothyroid insulin which I have already told in this previous slide. So what are the effects of various drugs in coexisting diabetes and thyroid disorders? So metformin is seen in this figure like it reduces the TSH level, it reduces the risk of thyroid cancers, by decreasing thyroid volume and nodule size, it will be promoting therapy especially with the thyroid disorder. Sulfonylurea is the body opposite hand, it increases the risk of thyroid cancer and risk of hypothyroidism and goiter. Thiazolidones have a PPR action PPR gamma agonist which have a thyroid hormone receptor also have that same cells, so it inhibits the activity of thyroid hormone receptors and increases the TSH. And we have also heard about the insulin-induced hypoglycemia, drug-induced hypoglycemia in the previous slide. Today morning, like non-diabetic causes of hypoglycemia. So carbimazole has been found to be causing insulin autoimmune syndrome that is known as Hirata syndrome. Okay, and it can cause hypoglycemia, especially diabetes. Both methimazole and carbimazole. Levothyroxine reduces the fasting and postprandial blood sugar level, reduces the glycosylated hemoglobin also. Incretin myometins, which is the today's lots of the talk was focused on GLP-1 agonists and SGLT2. So GLP-1 agonists we are all aware, it can also cause the medullary thyroid carcinoma. So you have to be cautious while dealing with the diabetes and thyroid disorder and see palpate the thyroid gland, see whether the patient have a thyroid nodule or not, and send the patient for the ultrasound of the neck and work up for the whether they are risk for medullary thyroid carcinoma or not. So what is the recommendation for major diabetes and endocrine practice guideline on thyroid screening with patients with type 2 diabetes? So since 2000, there has been guidelines has been changing as for ATA, AAC, British Thyroid Society, Association. So since then the various recommendations has come. So recently in 2019, what they have recommended by British Thyroid Association is telling that you can do the TSH and TPO antibody at the diagnosis in type 1 diabetes and every year. In type 2 diabetes, routine annual thyroid testing is not recommended. Only you can do the thyroid testing if you are suspecting the patient with the thyroid disorders. As per ADA, they have told in type 1 diabetes, TSH, TPO antibody and thyroglobulin antibodies, evaluation and diagnosis is done, and thereby 6 monthly and depending upon the risk factor, we have to do this screening of the thyroid TSH in the diabetes patient. In type 2 diabetes, thyroid palpation should be done as already told all diabetic patients, and TSH are more than 50 years of age or patient with dyslipidemia, increased lipids and all the triglyceride and total cholesterol, increased LDL, you have to do the TSH. According to AAC, American Association of Clinical Endocrinologists, they have told we have to do thyroid palpation both type 1 and type 2 diabetes. In type 1, we have to do the thyroid palpation at regular interval and in patients with goiter and autoimmune thyroid disorders. In type 2, we have to do the thyroid palpation TSH at diagnosis and regular interval in patients with goiter and autoimmune thyroiditis. These are all the Western data. Whatever the Indian screening I will come in substitute slide, before that
what is the benefits and limits of screening program in patients with type 2 diabetes? If you don't do the screening, asymptomatic thyroid disease is frequently absorbed in patients with type 2 diabetes, so we will be missing that. Patient won't be having control blood sugar, the patient won't be having their lipids may be controlled with if they have a thyroid disorder and diabetes, so we have to control the thyroid, and that's, depending on that, the sugar level and lipids will be controlled. Undetected thyroid disorder are compromise the metabolic control and amplify the cardiovascular events. They can also land up the patient with the stroke, myocardial infarction. So it's very important to screen them. The screening of thyroid disorder could prevent the high cardiovascular complications, which I have already told. Diagnosis of thyroid disorder in a patient with type 2 diabetes is difficult because some oral anti-diabetic drugs like metformin, sulfonylurea, GLP-1 can interpret with the evaluation serum TSH level. So you have to do the meticulous thinking, critical analysis before doing the diagnosis of thyroid disorder in type 2 diabetes. Sometimes the soft clinical thyroid disorder can progress to the low rate, suggesting a long-term screening program. That's why we should not do screening all the patients with diabetes and thyroid disorders. The use of age-specific TSS range should be considered to avoid the misdiagnosis of hypothyroidism in elderly patients with type 2 diabetes, and all the country has their own TSS, age-specific TSS range, and I think India has already developed that. In Nepal we have not developed till now, and India has developed that for both the euthyroid individuals and thyroid disorder in pregnancy also. There are insufficient data to assess the specific test for the screening. So the exact interval of periodic screening and the cost-benefit ratio should be considered while doing the screening of patients for thyroid disorder in diabetes. So what is this all very complicated, what is the simplified algorithm then for thyroid screening in diabetes? So if the patient is euthyroid, if the patient is type 1 diabetes and type 2 diabetes, you can do TSS and TP antibody and thyroid globulin antibody in the type 1 diabetes patient who are suspected to have a autoimmune thyroid disorder or Graves' disease. In type 2 diabetes, you do the TSS if the patient has dyslipidemia and women are more than 50 years. See the same thing, slightly modified. So we are all aware of that. If the patient have a subclinical hypothyroidism and thyroid disorder more than TSH level more than 10, you have to treat. If the patient have a subclinical hypothyroidism with dyslipidemia, they are planning for pregnancy, infertilities, they have goiter, then you have to treat. So it's the same thing for the thyroid dysfunction and euthyroid. So regarding the Indian guidelines which I have told as per RSSDI, the grade B recommendation is insufficient evidence to support annual TSH screening patient with type 2 diabetes. They are told to screen the patient for high risk, like for example elderly women, the patient is having uncontrolled diabetes, patient with frequent hospital visits, and patient with pre-diagnosed autoimmune thyroid disorder, Graves or vitopathy. Grade B recommendation, annual TSH screening along with TP antibody is recommended in type 1 diabetes in all patients regardless of the age, clinical presentation and gender. In patients with subclinical hypothyroidism, more frequent TSH screening can be performed keeping in mind the economic consideration of the patient. That is very important in our part of the world, both Nepal and India. Another grade B recommendation is in patients with type 1 diabetes, anti-TB testing at the time of diagnosis should be done along with the annual TSH screening is recommended. For patients with type 2 diabetes, TSH is done at the time of diagnosis and it is done every 5 years, not annually, like that of type 1, as the age more than 35 years of age. And annual screening can be recommended in high-risk cases like if the patient of diabetes have a complication like neuropathy, nephropathy, retinopathy, subclinical hypothyroidism, positive anti-TB antibody and dyslipidemia. They have also told by Indian guidelines, RSDI guidelines of India, thyroid gland palpation should be recommended in all the patients with diabetes with positive family history of thyroid cancer regardless of the glycemic presentation. Because if you are giving GLP-1 agonist, if you miss medullary thyroid carcinoma, you will be aggravating his cancer and you will landing up with the problem. So what is the summary of Indian evidence? So in grade B recommendation, what they have told is annual TSH screening should be done in all patients with Indian patient or Indian subcontinent like Nepal with type 1 diabetes, especially pregnant women with whom normal TSH cutoff must be considered. We all are aware of that. In first trimester we have to keep between 0.1 to 2.5, in second 0.2 to 0.3 like that. 3 and third time of 0.3 to 3. So for patient with type 2 diabetes, annual TSS screening is recommended. We will track patient who have a TSS level more than 2.5 microunit per liter. And patient with thyroid disorder and diabetes must be regularly screened for nephropathy and neuropathy also.
Because in the nephropathic patient, they can also have a pallor, edema, leg swelling. You may be missing that patient as a hypothyroidism. They have similar features, no? So we have to be cautious. And they can have neuropathy. Both the thyroid disorder and the diabetes patient can also have neuropathy. So we have to screening all the patients have these symptoms for diabetes, for TSS and TSS, the hypothyroid patient and these symptoms. We have to ask the history of diabetes and go ahead with that. So high risk patient including patient with hypertension, neuropathy, nephropathy, uncontrolled blood sugar and dyslipidemia have to be screened annually with the thyroid function test. Individual case presentation of the patient must be considered to decide the frequency of TSS screening, since the burden of hypothyroidism is much more higher in the Nepal and India. So I was focusing more on the Indian guidelines because we have to be proud of ourselves with our guidelines than following all the Western and European guidelines. So grade A recommendation is for regarding the treatment of anti-thyroid drugs in patients with diabetes. It's taken from same RSDA guidelines. So we all are aware, like we start with the levothyroxine and the dose is 1.6 microgram per kg body weight. We start with that. And metformin can be safely prescribed in patients with diabetes and thyroid disorder. But we have to regularly monitor the thyroid function test in patients who have thyroxine and metformin, because metformin has been found to decrease the TSS level. And other OHA like sulfonylurea, GLP-1, pioglitazone must be selected in caution, because pioglitazone has been found to be aggravating the growth of orbitopathy, because this PPR gamma receptor is also found in the orbits and can also aggravate that. So you have to be cautious while giving that drugs in the patient with the growth orbitopathy. In the patient on metformin levothyroxine regimen, the dose of levothyroxine may be reduced because metformin still can decrease the TSS. All insulin dose is recommended for elderly patient along with the necessary dose reduction should be there. And clinical indication and patient preference can indicate treatment choice of anti-thyroid drugs versus radioiodine ablation. Some little things about how to deal with thyroid disorder pregnant women with diabetes. So we have heard about that, like there are various mechanisms like immunological mechanism, genetic factors, epigenetic factors, environmental, all are causing this thyroid disorder pregnant women. And if you don't treat, they can have both maternal and fetal adverse outcomes. So we have to treat the patient with thyroid disorder pregnant women also. And what the guideline has recommended, which I have already discussed, in 2017 guideline 88, they have told to check TSS in pregnant women with type 1 diabetes and autoimmune disorders. They are also they do not recommend universal screening for all the patients who are pregnant or planning for pregnancy. Okay, all the patients should not be screened. Screening should be done in following this pattern which are listed here. Mostly the age more than 30 years, and they have a family history, they are weeks for all the autoimmune disorders likewise. So BTA and British Thyroid Society, Endocrine Society also are considering same. But Korean and ACOG are not recommending so universal screening of the thyroid function test in the pregnant woman. So at the end, I want to end by telling by some essential points or take-home messages of today's diabetes and thyroid talks are: autoimmune thyroid dysfunction is more common, around 70 to 30% in patients with type 1 diabetes. Thyroid dysfunction is more common in patients with type 2 diabetes also than other general population. If there is a patient has a pre-existing diabetes mellitus, we have to screen for if they have uncontrolled blood sugar, if they have uncontrolled lipids level, we have to screen for the thyroid dysfunction. They might be having hypothyroidism, that might be precipitating the decay. They might be having hypothyroidism, that might be precipitating the dyslipidemia. And so insulin treatment should be adjusted in patients with diabetes after occurrence of thyroid dysfunction. And hyperglycemia should be rehabilitated in hyperthyroid subject after the control of thyroid dysfunction. Because if you control before, then it may aggravate the decay. That's why we have to control first the thyroid, hyperthyroidism or Graves' disease, thyroid storm, then go ahead with the control of the blood sugar. And as I've already told, GLP-1 receptor agonist or liraglutide is not recommended in patients with personal family history, medullary thyroid carcinoma or type 2 multiple endocrine neoplasia. And prior detergent should be administered to diabetic patients with clinically, should not be administered with clinically active grades of allopathy. And at last, I want to thank all the LDSSCON committee for inviting me and conducting such a beautiful, excellent academic piece. Thank you. Thanks a lot. If you have any comment or questions, I am ready to answer that.
That can be over the glass of wine, I think. I think every good thing comes to an end, and so let this be too. And we really have left some real wonderful lectures in morning session, and we'll be leaving some good fond memories. Thank you, Dr. Robin.
Thank you.
And I request all the chairpersons and speakers to please proceed to the celebration. And finally, as a customary note, I would request Dr. Muklesh sir to please present a vote of thanks.
So now, as it's a customary, so I will sincerely like to thank each one of you, first of all, because I still see all of you sitting. Nice lectures over here. We have tried to give you good clinical topics, coming through experts, those who are well known in those fields. And if suppose you are there sitting at this time, that proves that our effort as a overall effort is now proving to be good. Certainly we'll try to continue with this sort of thing in future, as we have been trying in the past as well. The motive remains to dissipate knowledge to the best. And in this endeavor, each and every one of you has contributed significantly to the success of this conference. I will also like to thank our counterparts, the Nari Shakti, which is still busy. Backstage, they are not seeing in the front, but yes, without them, this program would have been so smoothly running. Immediately getting the pictures within a few minutes to deliver those certificates printed with those actual live pictures of the respected faculty and the speakers is a marathon task which is being continually done, none other by our counterparts, those who are there in the backstage. I would also like to thank the pharma people all around. They have been supporting us for continuing this. So once again, thank you so much, all pharma people here, those who are there in the hall or those who are there outside. I'd like to pass on my sincere thanks for the same. At the same time, I will also like to thank my own staff from my hospital, those who have been there with me throughout the day and doing whatsoever little things they have to be done for this particular conference. And then the event manager of this program, and that is Umair with the bag there in the center, and the audio video that was absolutely flawless throughout the time, the screen and whatsoever decor, whatsoever you are having has been done by Mr. Umair, who is the event manager for this particular event. So a big thanks for you also. You have been supportive throughout our past endeavors as well. So to my all seniors, to my all colleagues, to our fellow men, to the organizers, to my staff, to the staff of KP Chandra, and then I would like to specially mention about KP because people have been asking me ये live अचानक से scientific brief कैसे चले आ रहा है, ये कौन कर रहा है? मैंने कहा वो बंदा बैठा है ना एक बगल में, वो खुद AI है. So he is so hyper dynamic, full of energy कि वो जब भी एंटर करता है ना कहीं पर भी तो कहीं ना कहीं एक एनर्जी लेवल चेंज होता है उस पूरे इलाके का. So this is what KP is, and the scientific briefs whatsoever you are getting on your mobile is being compiled by him. So each and every person, Dinesh, silent worker in the background, all faculties have been contacted by him through these last 15-16 days, and he has been doing it day in and day and night continuously, and the end result is there. Most of our faculties, they were here barring for maybe few, everyone attended and contributed in their positive manner for this conference. So with this, and I will not miss on anyone, Vivek or Nitin or maybe people those who are not here, Arun and Santosh sitting in Australia, I like to also mention because he has been giving his inputs, though he is overseas, he is not here in India. So we as a group are certainly here, bonded together with our counterparts. They are there now free, so probably they can also come forwards. And this is where I'll end my words today. And now another 45 minutes of wait before these hotel people, they will settle down with the dining part, and the music people, they will settle down the stage, and then we will have live music with your contribution there itself. There also we'll be requesting Dr. Dalela बहुत बढ़िया गाते हैं, उनको भी कहीं ना कहीं invitation दूंगा, रोक के रखा है मैंने अभी. So now let us have good time of enjoyment after that education feast. Now here the cocktails and dinner, they will be open probably after 30-35 minutes from now. So we have some waiting time, relaxing time to chit chat and network, and then later on we'll continue with the music and rest of the things from there at around 8 or 8:15. Thank you so much, and sorry if I have missed someone in the process. So once again, Dr. Rajiv Avasthi, Shaili Avasthi, everyone, and is just a bond that takes us together through the process. Thank you so much for being here. So wait for another 30-35 minutes, and then we'll continue with the music and the cocktails and the dinner. Thank you so much.
मैं कुछ बोलूँगा नहीं, मुझे फोटो खिंचवानी है, सुबह से एक भी फोटो नहीं खींची बड़ी. अरे फोटोग्राफर भाई, मेरी फोटो लो भाई, मेरा ही फोटो मिसिंग है. हाँ, डॉक्टर मुकलेश ने सबका नाम लिया, बस शायद खुद का नाम लेना भूल गए. I think he is the source of inspiration, and हम लोग सब उनके पीछे हैं. जब उनका 11 बजे मैसेज आता है, सुबह 5 बजे फिर आता है, लगता है यार why can't we also contribute? तो बंदा 4-4 घंटे सो के सारा अरेंजमेंट कर रहा है. And I think he is the source of inspiration who made us work hard for the last, let us say, 2-3 weeks and maybe 6 months down back ago. So 3-4 हफ्ते हम लोग शायद 4-5 घंटे सोए हैं, लेकिन the inspiration has come from Dr. Muklesh and Dr. Muklesh. आइए, आपका भी फोटो हो जाए. 2 ही लोगों का फोटो मिसिंग है.
थैंक यू माय LDSS टीम. बाकी सबको तो सर ने थैंक्स कह दिया है, बट मुझे लगता है कि LDSS टीम ने मुझे इनकॉर्पोरेट किया है. आई एम सो लकी. राजीव सर, मुकलेश सर, द डायनामिक पर्सनालिटी, माय KP ब्रदर, दिनेश बॉस, अरुण, everybody, Tanushree ma'am, Shaili ma'am, Better House, everybody has been so dynamic and helping that we just feel elated when we are in this group. So thank you very much. Thank you, Muklesh sir.
भाई कहते अभी ये तो मेरे हाँ, तो मार्केट की बात नहीं कर रहा हूँ मैं, अपनी खुद की बात कर रहा हूँ.